late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Orijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, Hem and IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhale nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Orijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy.
Pushita, good morning.
Allergy and also provides a range of licensed
Hello.
হ্যালো
শোনা যাচ্ছে তো?
হ্যাঁ সম্পূর্ণ অডিবল। ভিডিওটা দেখা যাচ্ছে তো?
হ্যাঁ শোনা যাচ্ছিল, ঠিক ছিল একদম। আমাদের একজন মানে এইটা একটু খেয়াল রাখতে হবে, আমাদের এখন ফ্যাকাল্টি হিসেবে কি জয়েন করেছেন, ওনাকে যদি আনমিউট করা হয়, কারণ নাহলে ওনার নামটা রিনেম করতে হবে আর কি। মানে ফ্যাকাল্টি লিংক দিয়ে যারা ঢুকছেন
আর তারা ভিডিওটা অন করলে তাহলে করে দেওয়া যাবে। দেখেন
ভিডিওটা অন করতে হবে।
হ্যাঁ হ্যাঁ।
Hello.
Hello.
This is Dr. Devajyoti Shaha. So, my name is not being displayed in the screen. Hello, am I audible?
Yes, sir.
I am Dr. Devajyoti Shamboda.
Oh, Dr. Devajyoti, yeah. So you will moderate today. So you have now we can see your name.
Okay, fine.
Okay, so at 10 a.m. we'll start sharp at 10.
Sharp
So,
at 10 a.m.
Yeah. So you have to moderate this hall.
Okay, fine. This is Hall A.
Hall A. This is Hall A. Yeah.
Okay. Sharp at 10. The speakers, are the speakers available? Speakers and the chairperson, sirs. Hello.
Hello.
Are the speakers available right now?
I think another one link from faculty link I am seeing here.
Ambo, good morning. I am connected.
Okay, sir.
Sir,
good morning, sir. Sir, আপনার এটা নামটা একটু রিনেম করে নিতে হবে আর কি স্যার।
আচ্ছা।
কি নাম বললে আমরা করে দিতে পারবো?
অলোকেন্দু ঘোষ, ALAKENDUGHOSH।
স্যার আর স্যারের পিপিটিটা আমি কৌশিকদা তোমাকে পাঠিয়ে রেখেছি। স্যার আমরা প্রেজেন্ট করব না আপনি প্রেজেন্ট করবেন স্যার?
হ্যাঁ তাহলে তোমরা ওদিক থেকে প্রেজেন্ট করো, তাহলে আমি ফ্রি হয়ে গেলাম।
হ্যাঁ স্যার, আমাদের দিক থেকেই তাহলে
তাই ভালো।
প্রেজেন্ট করছি। কৌশিকদা তাহলে তুমি একটু শেয়ার করো স্ক্রিনটা। তোমাকে আমি এক্ষুনি গ্রুপে পাঠিয়েছি স্যারের, আবার আরেকবার পাঠিয়েছি পিপিটি।
ওকে 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 রিসিভ। জামুদা ইউটিউব লিংকটা অন করে দিয়েছি।
হ্যাঁ ইউটিউব স্টার্ট হয়ে গেছে, ঠিক আছে। আর আরেকটা হচ্ছে আমি তাহলে একটু তাহলে এখান থেকে বেরিয়ে আবার হল বিটা একটু দেখে নিচ্ছি।
ওকে ওকে দাদা ঠিক আছে।
ঠিক আছে ঠিক আছে, দেবজ্যোতি তুমি কিন্তু স্টার্ট করে দেবে যদি বাই চান্স আমার ঢুকতেও দেরি হয় এখানে।
আচ্ছা আচ্ছা ঠিক আছে
আমাদের
দাদা।
চেয়ারপারসনরা এদেরকে ইন্ট্রোডিউস করে, স্যারকে ইন্ট্রোডিউস করে শুরু করে দেবে। আর আমার মনে হয় যে আমাদের ইনিশিয়াল যে সিভি স্লাইড যেগুলো আছে হল মানে প্রথম সেশনের জন্য, কৌশিকদা তুমি এখন থেকেই প্রজেক্ট করতে শুরু করে দাও।
ওকে ওকে।
ওকে। Very good morning, respected faculties and respected delegates. So we are on the verge of the opening of 10th Annual National Conference on Allergic Disease, that is ALLERCON 2021. On behalf of Team ALLERCON 2021, it is my great pleasure to welcome all of you in this August event. So it is, may I request Dr. Debojyoti Saha to moderate this hall now, and we can start the session from 10 a.m. Dr. Debojyoti Saha, are you there?
Thank you for your kind introduction, Dr. Shambho Samazdar.
So we will start from 10 a.m. Okay.
Okay, fine.
Okay. Thank you.
Very good morning to all my respected faculty members and chairpersons. This is Debojyoti Saha from Department of Pharmacology, National Medical College. Today, I invite you to the 10th Annual National Conference on Allergic Disorder, that is ALLERCON 2021. And the theme of today's discussion is based on allergy in COVID times. So, the first session will be on allergy and autoimmune disease, any link missing or not. So for that, I do invite Dr. Jayati Das, Associate Professor, and Dr. Usha Rani Pingali, Head of the Department Clinical Pharmacology, Nizam, to chair this session. So very good morning to Dr. Jayati Das and Usha Rani Madam. So handing over to Jayati Das and Usha Rani Madam for their kind cooperation to chair this session. Thank you, ma'am.
Very good morning to everybody. I welcome all of you to this ALLERCON 2021. This is the 10th year that we are having this ALLERCON, and this ALLERCON is going to be held online because of this this particular situation that we are going through. So please bear with us. So in this particular session, we have three speakers, Dr. ALLERCON Ghosh, Dr. Neeraj Gupta, and Dr. Ruhi Rasul. So they're going to speak on very relevant topics. So I invite Dr. ALLERCON Ghosh to introduce himself and start the presentation. The time limit for the presentation is 20 minutes and followed by question answers if there is any. Okay, so I invite Dr. ALLERCON Ghosh.
Thank you. Good morning.
Good morning.
This is a topic given to me, and I must sincerely express my thanks to organizers, especially Professor Tripathi along with Shambho, to provide me to share some of the thoughts of autoimmunity in this forum. And when it was entrusted, when I discussed with Dr. Tripathi, who provided me the topic, I thought, okay, once we are dealing with the patients, let's explore that one. But it's really a very tough topic in the sense that allergy and autoimmune disease, to explore the missing link, it's to explore the basic interactions, because we have a lot of autoimmune patients in our armamentarium daily clinical practice, but the background of allergy and the immunodeficiency along with the autoimmunity has got a link. May I have the next slide, please? Next slide, please. Slides sharing, please. Yeah, next one. So the malfunction of immune system is basically expressed through three axes: immunodeficiency, allergy, and autoimmunity. Out of this, immunodeficiency and autoimmunity sometimes appear together, like in IgA deficiency or common variable immunodeficiency, there is autoimmunity in the background is working. But the link between autoimmunity and allergy has been less well appreciated over the years, but recently there are a lot of literatures are coming up to identify the link. Next, please. And the hallmark of the allergies are, as we all know, there is formation of IgE antibodies against environmental antigen, that is allergen. Immune complexes consisting of IgE and allergens are developed, which causes release of inflammatory mediators, protease and cytokines from the mast cell and basophil, which leads to allergic inflammation within minutes. And there is immediate type 1 allergic inflammation, which is basically Th2 dependent and IgE dependent process. Next, please. So what are the other components? Next, please. Other hypersensitivity reactions and autoimmune diseases are, as all of us know, one is type 2 and type 3 reactions. These are mediated by antibody classes other than IgE, and type 4 reaction basically through Th1 cell activation. And autoimmune disease, on the other hand, there is activation of Th1 cells along with cytotoxic cells, complement activation, and ultimately leading to production of inflammatory cytokines. Next, please. Next, please. So these are the 4 types as we have described. Type 1, immediate type reaction resulting from soluble antigen interacting with cell-bound IgE. Type 2 and type 3, antibody type 2, precisely antibody reaction with cells or extracellular matrix components, leads to destruction by complement lysis or Fc receptor bearing cell. Type 3 is an immune complex reaction, involves soluble antigen, IgG as an antibody, and complement activation. And type 4 is delayed type reactions are mediated by T cells along with APC, antigen presenting cells. So these are the basically 4 types of hypersensitivity reaction. And what is atopy? It's a tendency to develop immediate type hypersensitivity reactions to common allergen, And what is allergy? It's a situation of changed reactivity of the host to antigenic stimulation, resulting in immunity or hypersensitivity, whatever way it expresses. Nowadays, allergy is used hypersensitivity. And in that reference, one must appreciate the auto-sensitization process to overcome the problem. This is IgE-mediated sensitization to autoantigen. Next, please. So are there any common features linking autoimmunity and allergy? Yes, the common links in the pathogenesis of both autoimmunity and allergy are: one is mast cell, another is autoantibody, and dysregulation of T cell and cytokines are there. It has been defined. Next one, please. Next, please. So what are the diseases known to be affected through this axis? One is mast cell. For allergic reactions, the pivotal role it plays in all allergic conditions, including early, immediate, or late inflammatory phase, whereas autoimmune diseases where mast cell plays a pathogenic role are multiple sclerosis, congestive cardiac failure, cardiomyopathy, myocardial infarction, rheumatoid arthritis in rheumatology practice, liver disease like autoimmune liver disease or autoimmune fibrotic lung disease as a special entity being defined nowadays. Regarding autoantibodies, pathogenic in reference to allergic disease like chronic urticaria or asthma, whereas in autoimmune disease, autoantibodies plays an important role in Hashimoto's thyroiditis, Graves' disease, autoimmune hemolytic anemia, ITP, myasthenia gravis. Whereas T cell and cytokine dysregulation, it influences most allergic condition, allergic contact dermatitis, asthma, drug eruption, Th2 type condition, whereas pivotal role in numerous autoimmune conditions such as SLE, Th1 and Th2 type conditions. Next, please. So what links allergy and autoimmune phenomenon then? In many allergic patients, chronic allergic inflammation resembles features of type 4 hypersensitivity secondary to Th1 cell activation. Chronic allergic inflammation has been observed in allergic individual even without exposure to environmental allergen like atopic dermatitis, chronic allergic asthma, allergic rhinosinusitis. Chronic forms of allergic inflammation respond thus to targeted cell therapy like anti-CD4 treatment, cyclosporine, or other immunosuppressive drugs which are regularly being used in rheumatology autoimmune disease practice, which neutralizes mast cell, basophil mediators, or anti-IgE strategy as a target. Next one, please. In patients with allergic disorders, some IgE reactive autoantigens are potent activators of Th1 and cytotoxic T cell response. Immune recognition of these autoantigens might contribute to allergic inflammation in the absence of exogenous allergen exposure. Above phenomenon explains the co-occurrence of allergy and autoimmunity in certain allergic susceptible hosts. Next one, please. So IgE autoreactivity as a contributing factor to autoimmunity in allergic individuals. What are the information? Around 60% of patients with severe and chronic allergic symptoms, but are not patients suffering from mild forms of respiratory allergy or a non-allergic individual, have shown IgE autoreactivity. Our intensity of IgE autoreactivity was associated with the severity of atopic disease and was reduced after successful anti-inflammatory treatment. Next, please. So IgE reactive autoantigen can be divided into, as because it's a very important axis in which connects the autoimmunity and allergy. One is human homologs of environmental allergen and autoantigen, which are known targets in classical autoimmune disorder. So let's look toward the human homologs of environmental allergen. Next, please. Next, please. Human homologues of environmental allergens are basically profilin, serum albumin, manganese superoxide dismutase, or ribosomal protein. So structural similarity with exogenous allergen and leading to low intensity T cell activation and immediate and late phase skin reaction in sensitized individual. Next, please. Whereas autoantigen, which are known targets in classic autoimmune disease, classic antigenic targets in rheumatoid, systemic lupus, as well as in skin, gut like IBD, eye and endocrine glands, some of these antigens have been found to react with IgE antibodies. Next slide, please. So these are the IgE reactive autoantigens in allergen autoimmunity. The initial phases, like in allergy, these are the IgE reactive antigens. In atopic dermatitis, these are the allergic reactive autoantigens. Next one, please. And in rheumatoid arthritis, we have a targeted autoantigen. In SLE, we can have an anti-nuclear antibody or Rho SSA specifically being initiated in the reference of recurrent fetal loss, can have asthma, bullous pemphigoid, platelet antigen BP180, and these are the list for autoantigens, especially in autoimmune disease like Graves' disease. We can have a anti-TPO thyroperoxidase enzymes, and which are being targeted as an antigen. Next one, please. So mechanism triggering autosensitization and IgE reactivity. First is cross-reactivity and mimicry. Cross-reactivity with an autoantigen that has structural similarity with an originally sensitizing exogenous allergen structure or epitope. Escape from self-tolerance, another component. Altered self, autoantigens that are altered because of denaturation become antigenic and cause autosensitization. This self-tolerance escape is the initiating mechanism of autoimmune disease, especially in systemic lupus. And the presentation in a particularly immunogenic fashion by certain types of APCs, activation of certain T cell subsets by proteolytic fragments derived from autoantigen, defect in regulatory T cell function, intrinsic capacity of certain autoantigens to elicit certain cytokine responses. Next one, please. So the pathway of transition from allergy to autoimmunity in susceptible individual. So we are trying to identify the missing link from allergy to autoantibody in a susceptible host. Short-term exposure to exogenous allergen gives rise to acute allergic inflammation characterized by IgE-dependent mast cell and basophil dysregulation. Initial Th2 cell activation with little or no Th1 activity. Continued exposure to exogenous allergens leads to prolonged allergic inflammation and liberation of autoantigen because of tissue damage. Next, please. There is subsequent activation of Th1 cell, which leads to release of interferon gamma and causes IgE-independent tissue damage. Thus, it deviates from that axis and gradually becomes autonomous. And inflammation and perturbation of epithelial barrier, damage to the epithelial barrier by Th1-mediated mechanism augments exogenous allergen penetration and allergic inflammation and facilitates the transition of pathogens through epithelial barriers, promoting infections and vicious cycle progresses. Next, please. Let's look toward the final outcome of the above is a transition from acute to chronic allergic inflammation dominated by signs of Th1 activation and resultant autoimmunity in sensitized individual. Next, please. So let's look toward the cartoon, which we have discussed. The exogenous allergen, epithelial barrier being penetrated, it starts stimulating mast cell degranulation with and there is Th2 cells, and there is allergic inflammation, leads to tissue damage, as we have discussed, releases autoantigen, which has got a cross-reactivity, autosensitization, and boosting of autoantibodies, stimulates B cell to release autoantibodies. And on the other hand, there is Th1 cell stimulation leading to release of interferon gamma and TNF, and which again cyclically continues tissue damage and continuous release of autoantigen. And there is the cyclical tissue damage being continued from allergy to autoimmunity axis. Next, please. And this acute allergic inflammation through autoreactivity from upregulation of Th1 cell to chronic allergic inflammation with the upregulation of Th2 cells and IL-4 Ig dependent phenomena. So from Ig independent through autoreactivity, there is Ig dependent, and the balance of Th1 towards Th2 causing these gradual changes. Next one, please. So the question that remains to be answered, why are some IgE reactive autoantigens potent in inducing Th1 response while others are not, needs to be resolved. Can IgE autoreactivity be used as a diagnostic parameter for monitoring of tissue damage in allergic inflammation? Why is IgE autoreactivity preferentially associated with certain manifestations of allergy, atopic dermatitis? So these are some research questions which needs to be resolved in from bedside to bedside translation of the concept. Next one. And this is the recently published article which has tried to identify, to define the missing link, allergic disease and long-term risk of autoimmune disorders, a longitudinal cohort study and cluster analysis. And these are from UK Birmingham group. Next, please. So to have the information, they have the around more than lakhs, around 7 lakhs, 13 lakhs, 10 lakhs with allergic rhinitis, conjunctivitis, atopic eczema, and asthma respectively included. And they have tried to identify the risk ratios of development of autoimmune disease. And they have definitely identified that for risk of lupus 1.45, Sjogren slightly higher in this group, and there is other group as well. So the conclusion is the long-term risk of autoimmune disorders are significantly higher in patients with allergic diseases, and this needs to be addressed during the exploration of the underlying pathology of the autoimmune diseases. So next slide. So to conclude, we have the information and we have the identification of the axis to define the missing link from allergy to autoimmune diseases, and this needs to be addressed during planning of therapy for the autoimmune diseases. Thank you very much.
Thank you, sir. Thank you, sir, for your lucid presentation, thus providing us the concept of this missing link between allergy and autoimmune disorder. Immunology is a very tough subject and it requires very in-depth conception, and thank you for your very lucid presentation. Over to the chairperson, madam. So
Thank you so much, Dr. Allercon Ghosh. Since we don't have any question that is being asked for, I'm requesting Dr. Pingali if she wants to ask anything or you want to throw some light on this particular topic.
Actually, yeah, very well. You've discussed very well the missing link between allergy and autoimmunity, and it was very nicely that you have summarized the definitions of hypersensitivity, and what IgE, the presentation was pretty interesting, and I'm sure the audience would have definitely benefited from the IgE reactive autogenicity, and then the mechanisms of it, because that is always, there's a very gray area between allergy and autoimmunity, and I appreciate the way you have discussed the missing link, and that's it. Thank you.
Thank you very much. Thanks a lot.
So the next speaker for today's session is Dr. Niraj Gupta. He's going to talk on geo-environment interaction in allergic disorders. So we all know that environment plays a major role in all the diseases. So may I request Dr. Neeraj Gupta to start his presentation.
Good morning, everyone, and thank you to the organizers for giving me this opportunity to speak on gene-environment interactions in allergic disorders. I was listening to Dr. Ghosh, and it was a very beautiful presentation which he made about autoimmunity and the missing link with allergies. So after this, we will be now coming to another interesting topic, which is gene-environment interaction in allergic disorder. So we all understand that allergy is a complex term, and it is not a very simple one word. Like any patient comes to us and says that I'm suffering from allergy, but it can have different manifestations ranging from respiratory manifestations like asthma, rhinitis, conjunctivitis, or sinusitis, skin manifestations. Then there could be some drug allergies, food allergies, and other different type of forms like mastocytosis, many other different forms like anaphylaxis, and many other things which happen. Now, the question is that during the human development, from birth till the old age, the question is that at what time we really became allergic, or actually we became allergic when we were in utero. So who should be blamed? Should we blame the genes? Should we blame the microbiota around us? Or should we blame the environment, whether it could be in utero environment or ex utero environment? They should be blamed. So that is a $1 million question. We will try to solve this question, see that where we can reach. So there are two type of groups who are trying to look on this question. One is genetics oriented view, in which they are trying to attribute each and everything to the genetic makeup of an individual, that we are born and brought up with a certain genetic potential. And then depending upon that genetic potential, we are at a risk of a certain phenotype. And that phenotype could be like with a variation in the phenotype, that could be like different subtypes of the phenotype which happen. And ultimately that will decide the clinical sign. And the environmental contribution is, you can say, like considered to be minimal in this. A classical example from the allergic disorders is like genetic polymorphism, which exists in IL-4 and IL-13 genes, which leads to Th2 oriented immune response, ultimately lead to increase in IgE levels, and responsible for airway hyperresponsiveness, causing asthma type of symptom. There is so there are different type of genes, many genes which have been identified till date, which are responsible for atopy and asthma. And here you can see that the arrows which are going towards the right side, they are having, you can say, like the associations or the positive correlation, whereas which are going to the left side, which are having the negative correlation. And the darker the color, they are having the strong correlation, and the lighter the color, which is having the lighter correlation or the moderate correlation. So there are different genes like asthma, atopy, Ig levels, and then atopy, and similarly other atopic dermatitis and all other things. So almost more than 120 genes have been mapped till date, which have been considered to be responsible for or associated or correlated with the atopy or asthma. There are other group of researchers which look at it in a different manner, like exposure-oriented view, in which they say that a person who is exposed to certain risk factors, and he is likely to get that particular type of clinical disease, which might be depending upon the genetic susceptibility. So genetic susceptibility plays a minor role here. For an example, occupational asthma, in which a person is having a well-defined asthma, a well-defined environment. That environment could be environmental tobacco smoke, that could be some sort of dyes like toluidine diisocyanate, these type of dyes, or other type of gases. So the dose and the time of the exposure, that is the environment of either the dust or the gases or the fumes, and the protective mechanisms which are used, like for an example, the mask, the duration of mask, the type of mask used. So the interplay between these factors, these are the environmental factors, the interplay between these factors will ultimately decide about the cotinine levels, for an example, for environmental tobacco smoke exposure, and then that will lead to altered structure and function and bronchial hyperresponsiveness leading to asthma. And in susceptible individual, the things becomes much more. In less susceptible individual, the things are much lesser. So these are the different views. So we as a patient, or our patient is having a certain phenotype, we still need to figure out that whether this particular genotype and this particular environment, how they together are interacting with each other. So after the interaction, what happens? That a person who is born with a certain genetic potential, and then with certain environmental triggers or environmental risk factors. Depending upon the dose of those risk factors or the triggers, depending upon the time of initiation, it is decided that whether it is going into allergic phenomena or it is going into tolerant phenomena. Now, the gene environmental interaction, are they so simple that one particular person is born with that particular genetic potential and then an environmental factor is coming into picture and that particular person is going to have the disease? Or they are little complex? So let us see. So as we have just discussed in case of occupational asthma, where there are certain environmental risk factors are already existing, and these are going to lead the disease in a particular individual, a certain genotype will act as a catalyst. So here the genotype is acting as a milder effect, whereas the environmental risk factor is a major effect. On the other hand, if a person could be having a certain genetic potential, which is going to lead the disease, and the environmental risk factor are acting as a catalyst. So what we need to understand is that a particular genotype, the same genotype depending upon the environmental risk factor, or the same environmental risk factor depending upon the genotype, they might be having no disease to severe disease depending upon where they are having. So this is there. And then there is another correlation in which genotype and environmental risk factor, both in combination, in synergism or in antagonism, will decide about the disease. And then genotype alone can cause the disease and environmental risk factor can alone cause the disease. And in combination, they can cause either synergistic action or antagonistic action, and ultimately that lead to. So this is called as flip-flop effect, in which a particular genotype and the environmental risk factor will ultimately decide whether the two in combination will cause beneficial effect or though in combination will cause adverse effects. So how one can detect it? So there are different scientific methods to detect about the gene environmental interactions. The first most commonly used is in which we previously know about that this particular genotype is probably associated with this particular type of allergies. And these are the environmental risk factors like environmental tobacco smoke, air pollution, farming, occupational exposure. They are responsible for asthma. So this is one. So what we are knowing, we are already know that and we are trying to explore it further. The second thing is that we know the environment, that this particular farming exposure is there or smoking exposure is there, but we don't know about the gene. And then we are trying to identify certain genes. And the third field is that the unknown field in which the genotypes are unknown and the environment is unknown. So we already know about certain genotypes, certain environment, and we are trying to explore it further. That is the known field, which is very minimal, very minuscule. Whereas the actual field which requires research is that we still don't know many of the genes or the genotypes, and we still don't know many of the environmental risk factors. And this field is still, the researchers are still lacking in this field, and we need to really know much more about this field. So there are certain papers which I have taken. So in these papers, people have taken different phenotypes of asthma depending upon either the clinical symptoms like wheezing or the lung functions, or depending upon the total IG or the specific IG or the skin prick test or atopic marks. So different criteria which have been used. And then they have taken certain environmental risk factors. They could be some dust mite exposure or environmental tobacco smoke or pets or farm exposure or mold exposure. And what they have found that in certain studies, there have been a good interaction which have been found between the genotype and the environment. And in the other studies, there was no interaction at all. You just see that there is a mixed result which is happening in studies. Why this is happening? Why this heterogeneity is there in the studies? Reason behind the issues with these studies are, first is the phenotype. That is a loose phenotype definition. Like for an example, if we take an example of asthma. So a patient or a child who is having asthma. So asthma is not one disease. Under the term of asthma, there are several asthmas which are there. There are several phenotypes, there are several subphenotypes, there are endotypes, and even there are many genotypes which are there. So there are various types of asthmas which are there. Then the second thing is that one particular study is taking the clinical feature into account. Somebody is taking the recent feature, somebody is taking the past feature, somebody is taking the PFTs, somebody is taking spirometry and PEF, then somebody is taking, you can say like the environmental factors with a little time duration, more time duration. So the definition itself of classifying a particular allergic disorder for that particular study is varying. The second is the time dependence. That means the environmental exposure. So sometimes it is like very less exposure they are taking. Sometimes they are taking a, you can say like a big time. Similarly, a single phenotype or a heterogeneity of the data collection. So they all need to be taken into account, and then only we can probably think about a definite interaction which is happening. Then the same thing which is happening at the level of environmental level. So there is a loose definition of exposure which is happening. Like if somebody who is working in a particular occupation, we are just taking that that particular person is exposed, but we still are not taking that what dose actually that particular person is exposed, whether that particular person is taking the mask, which type of mask, for what duration, what type of dose or quantity of dose that particular person is exposed. So that all need to be seen. Similarly, the window of exposure. So that means how much repeated exposures which are happening to that particular person for how many years. Then the modified effect of another environmental factor. Sometimes we are just taking the environmental tobacco smoke, but that particular person could also be exposed to the dust mite or mold, or that particular person could also be exposed to the smoking, and we are not taking that factor into account. So these two factors are probably adding up each other, so ultimately giving you a positive association, but that is not actually related to one particular factor. Then there is a selection bias, which is also happening. Then the type of issue with the genetic potential is also like single nucleotide polymorphisms have been taken, but there are many studies in which more than one single nucleotide polymorphisms exist, and we are just taking only one, and it is possible that gene-gene interaction which is also happening. And then the interaction between gene and environment, the power of the studies, like depending upon the study design, some of the studies are only case-based studies, some are case control, some are cohort designs. Then the sample size calculation, there are certain studies which are having only few hundreds of patients, and there are several studies which are having, you can say, like thousands of patients. Even there are studies who are having like tens or 20s of patients. So the value of each study or the conclusion of each study cannot be taken with the same measure, same yardstick that we need to really see. So the notion is that one size fits all, it doesn't fit all, what I want to say. So the newer concept in the gene environment interaction is about the epigenetics, microbiome, and exposomes. What is epigenetic? Epigenetic means that functionally relevant modifications to the genome without any structural change in the nucleotide sequence, which is important. So the genotype of the person is same, but there are certain epigenetic changes which are happening. So functionally, they are producing different phenotypes, like exposure to tobacco smoke, ozone, oxidative stress, endotoxins, and there are certain diets. They can all cause epigenetic changes with the same genotype. For an example, if a mother who is smoking during pregnancy, the risk of developing asthma is 1.8 times higher in children. But if a grandmother has smoked during pregnancy, then that produces more epigenetic changes, and that can cause in the grandchildren increased risk of asthma by 2.6 times, even if the mother has not smoked during pregnancy. So this is all because of the epigenetic changes. So GINA 2020 also reiterates that the only modified risk factor for primary prevention of asthma is stop maternal smoking. And this stopping of maternal smoking is not only the first hand, it is the second and the third hand smoke that should also be stopped, because that also produces epigenetic changes. Then the second thing is about microbiome. Let us go in the history. So we all know that in the history, earlier the human beings were living in the small groups, hunters, gatherers, scavengers, in somewhere around more than 10,000 before Christ era, in which there were many microorganisms which are living with us, like certain helminths, saprophytes, mycobacteria, tuberculosis, hepatitis A virus, gut microbiota, H. pylori, salmonella, many different microbiota. So this was the old friends which were there, and we were not having any sort of allergies. Then first epidemiological transition happened, in which larger social group came, animal husbandry came, then the domesticated cats and dogs, and then there was 97% were still living in the rural environment. So the old friends remained, but the new intruders came. The new intruders were like certain sort of viruses, could be rotavirus, coronavirus, paramyxo, orthomyxoviruses, measles, mumps, and many different types of viruses. Still, there were no allergies. But a second epidemiological transition happened, in which we moved to the cities. We started using soaps, detergents more frequently, wash foods, less orophycal transmission, more vaccination, more antibiotics, deworming, less animal contact, chlorinated water. So we actually become modernized. And ultimately what happened? That the old friends which were there, they started reducing. So the dysbiosis happened between the old friends and the new intruders. And ultimately the balance tilted towards the new intruders rather than the old friends. And that ultimately disturbed the microbiota of the human being, and that led to the allergic disorders. So the concept of hygiene hypothesis, in which they say that absolute hygiene should be there, and absolute hygiene actually invites allergic disorders. So that has now been changed to the targeted hygiene, in which it is not the absolute hygiene, it is basically the dysbiosis, whereas the old friend and the new intruder, the disbalance between the two, that actually invites the allergic disorder. So the concept is now changed to targeted hygiene in 2017. So the normal intestinal microbiota, which is the balanced microbiota, that actually produces immune tolerance, whereas the dysbiotic intestinal microbiota, that can produce the atopic disorders and various types of asthmas. And we all understand about these risk factors, so not going in detail. And there are certain microbiota like Haemophilus, Neisseria, Moraxella, Streptococcus, and Morganella. They all have been found to be associated with increased chances of asthma, whereas the other microbiota like Lactobacillus, Bifidobacterium, Faecalibacterium, and Akkermansia, they have been found to reduce the development of asthma. But still a lot of work needs to be done to define that which subspecies or which species of microbiota will be really helpful at what time of exposure, whether they should be started in utero, whether they should be started in the first year of life, what dose of microbiota that needs to be started. So that all need to be really put down in the guideline before a strong recommendation. But there are certain studies which are saying that there are certain microbiota which are helpful. Now coming to the concept of exposomes. What is an exposome? So exposome is the measure of all exposures of an individual in a lifetime and how those exposures relate to health. So this we are talking since conception. So after conception, whatsoever a person is exposed to, the study of that is called as exposome. So there is an internal exposome, like a certain genomics with which or a genetic material the person is born. Then those genes are getting transcribed, transcriptomics. Then the proteins are formed, that is a proteomics, and then certain metabolites are formed, which is metabolomics, these different studies. So these are internal exposomes. And then the external exposomes, that is the environmental exposure, which could be in utero or ex utero. So these are the different type of omics era, like the genomics, transcriptomics, metabolomics, and then the complex interaction with the environment ultimately lead to different type of allergic disorders. The orange lines are showing the known associations, but the dashed blue lines, since still more work needs to be done. And the exposome involvement in the allergy, that means a person who is born with a certain genetic potential, and ultimately the external environment, that could be the smoking, or the diet, or the certain allergens like pollens, molds, pets, or certain drugs or pollutants, for non-specific external environment like the urban environment or the rural or the social environment. All these things ultimately, which are going to make certain changes in the epigenetics, lead to different type of main allergic disorders and involved organs. So the gene environment interaction is not simple. It is a complex phenomena. It cannot be explained on a two-dimensional arm. It requires a 3D model in which the third dimension is actually time. And what is happening, like the interaction in between gene or the genetics and the time at the individual level will decide about the window of expression. At the population level will decide about the selection and the concept of evolution. The interaction between environment and time will ultimately decide at the individual level about the window of exposure to various environmental agents. That could be occupational environment agents, or that could be tobacco smoke, or at the population level, that will actually decide about the certain phenotypes and the Western diet and farming and air pollution. And the gene and the environmental exposure, ultimately that will decide, that will depend upon that the interaction between the multiple exposures and the various doses. And if we combine all three, that is the gene, environment, and time, then that will lead to a complex 3D structure, which will ultimately decide that which particular person is going to develop allergic disorder, or which type of different type of phenotype or subphenotype which will happen. So just to summarize, whatever we have learned till now is a particular genetic potential a person is born with, and then depending upon the environmental agents, that could be certain allergen, certain pollutants, environmental tobacco smoke, physical damage, epigenetic changes, certain pathogens, bacteria, viruses, molds, and then the timing, which is also important. And ultimately, that particular person will decide that which particular phenotype or subphenotype that particular person will express. What we know till date is that the known risk factors are allergen exposure. If there is allergen exposure, then yes, we understand that that is going to influence the allergic disorder towards allergies. Environmental tobacco smoke, but what dose, how much exposure, what time, we still don't know. Lack of breastfeeding, yes, definitely. So this is going to potentiate allergies. Early introduction of solid foods, mode of delivery, cesarean delivery, infections, still plus minus which type of infection, bacteria, viruses, or what severity of infection, what timing of infection, and then antibiotics question, still plus minus. Protective factors, we understand that exclusive breastfeeding, at least 4 months, preferably up till 6 months, and then early exposure to some endotoxins, lipopolysaccharides, helminths, infections. Then once again, the question about vaccinations, like hepatitis A vaccination, typhoid vaccination, should we give it, should we not give it? So there are certain questions which are unanswered. So a person who is born at prenatal, then there is a, after conception, there's a prenatal life, and then, so the adverse risk factors are the maternal history of asthma, maternal or grandmaternal smoking, environmental tobacco smoke history, then the obesity, cigarette smoking, whereas the good factors are pet at home, farm animals, unprocessed cow's milk. But the important thing is pet at home in the early life, in the antenatal life, or in the first year of life, they are protected. But suppose in the antenatal life, in the first year of life, they are not there, and then the pets are present at second or third year or fourth year of life, they might potentiate allergies. So that will ultimately decide. Older siblings, daycare attendants, so they all are important, they all are the protective factors. Now, one important concept which I would like to highlight is that a person in utero is having a Th2 skewed response. That means when we all were there in the in utero side, so our Th2 pathway matured initially. So we all were having an allergic tendency when we were born at in utero, or when we were born. Then with the advent of the environmental exposure, environmental allergens, environmental infections during the first year of life, that could happen because of the daycare or because of certain viral exposures or all those things. So the Th1 pathway get matured, and ultimately our immune system get deviated from or skewed from Th2 to Th1. But suppose because of the extreme cleanliness, because of the environment in which we are not getting exposed to the infections in the early part of life, then at that time the Th1 arm is not getting challenged, and we remained towards the Th2 pathway only, and the person is born with a allergic disorder, or the person is designed to get allergies. And the same concept is getting true for the food allergies. There are certain food allergies like milk, egg, wheat, which majority of them, which get, you can say, like tolerant, or the person get tolerant to them by a certain age of like 5 years or 6 years. It is because the Th1 pathway get matured in these people by that particular age, and so they get tolerance to that. Whereas other allergies in which Th2 pathway still remain dormant and Th1 pathway never get matured in those. So what do we know about gene environmental interaction? Many environmental exposures we understand associated with asthma. Number of genetic loci associated with asthma, that we know. The window of exposure is critical, that we know. And few gene environmental interactions have been established. But the enigma is that the joint effects of environmental factors, genetic factors, or both on asthma, we still don't know. And the interaction between gene, environmental factors with the time, that we still don't know, we need to understand. So just to complete my talk, genetics loads the gun and environmental pulls the trigger to produce a certain phenotype or subphenotype. Thank you.
Thank you, Dr. Gupta. Thank you for your presentation. Nicely spoken. I would like to invite Dr. Usharani Pingley for her valuable comments.
Yeah. Thank you, Dr. Neeraj. Really appreciated the way you had very clearly, discussed the not only the role of gene and environment, but you put the third concept of time in the 3D effect. And the other thing which you have very nicely discussed is the role of smoking as one of the confounding factors, and your observation of the grandmother smoking and the grandchild being at 2.8% higher risk of developing these allergic phenomenon is. Can you throw light with your experience on that aspect? It was really interesting.
Ma'am, so what I wanted to say is that the environmental tobacco smoke exposure really creates a problem. So this even to the grandchildren also. So this is important. So and that this type of information is really helpful when we are counseling the patient. Like recently, I encountered a mother who was like smoking, and she was expected to conceive. They came to me, and she just wanted to ask that what can I do during pregnancy to prevent the allergies in my unborn child. So I told her that look, you are looking at your unborn child or probably a second generation. I am looking your third generation also. So if you continue smoking, then at that time you are not only going to risk your child, but you are increasing the risk in your grandchild also. So that actually really helps. The second thing which is important is the second hand smoke and the third hand smoke. In India, especially, there are in a rural environment and many in the urban also, there is second hand smoke which is there. And now many of the people come, okay, doctor, I smoke outside. I do not smoke inside or in front of my children or in front of my wife. So this also needs to be curtailed, that even the third hand smoke also needs to be curtailed, and that is also very important. So these are the things, these really actually help us in patient management at the bedside, and definitely for the studies and research purpose, this opens a huge area which needs to be done.
Yeah, thank you very much. And over to you, Shambhu. If there are any, I don't think there are any questions in the chat box, so over to you, Shambhu.
Since there are no questions in the chat box, may I ask you, sir, a question? Dr.
Yes, please.
Gupta?
Yes, please. Yes.
In one of your slides, you have shown that cesarean section is a risk factor for getting allergy. So
Yes.
I would like to say that whether normal vaginal delivery, whenever the baby is getting born through the normal pathway, exposing to the normal commensals during the vaginal delivery, is there any kind of protection for development of allergy, so that the exposure to those commensals produces any kind of protective mechanism?
Yes, absolutely right. So the concept goes to microbiota. So it is basically the normal commensal or the healthy commensal from the mother, which is lying there in the vagina. When the child is passing through the natural path, then it is likely that that particular commensal flora, the child is likely to be colonized with that. And this seems to have a more protective effect as compared to the C-section, in which the child is not passing through the natural pathway and it is not getting exposed to the microbiota. And based upon the same concept, even in US, now the people are practicing, or the gynecologists are practicing, that whenever a child is born through the CS, then at that time, they are taking the vaginal swabs from the mother, and the swabs are applied to the children or the babies who are born through the CS, so that they can provide the microbiota effect or benefit to that particular baby for protection of the allergies.
There is one question for you in the chat box, which says that which genotype or genome sequence are proven and established to give allergy?
So, ma'am, there are different type of genotypes which are there. So there are interleukin 4 and interleukin 13 single nucleotide polymorphisms which are existing, which are known to have asthma. Then there are certain other HLA types which are there, which are known to have asthma correlation. But what I want to say is that one particular person, if comes to us with a particular genetic defect or a particular genotype, still we cannot say, still we cannot label that this particular person is going to have asthma or this particular person is going to have this severity of asthma. So what I want to say, the complex interaction between a particular genotype and then the environmental exposure according to the time, that will actually decide that what will be the actual phenotype of that particular patient. And this is most important. And that is why the last slide which I made is genotype actually loads the gun. It is the environmental trigger, environment, which triggers it. So both factors are required. So same genotype, 10 people are not going to have the same phenotypic disease at the end.
If there are no further questions, I thank you, Dr. Neeraj, for giving us such a wonderful presentation. Thank you very much.
Thank you.
I think it's time we move on to the third presentation. It is being made by Dr. Ruhi Rasool. So I request Dr. Ruhi to kindly make her presentation. She's a professor and head of department on the SK Institute of Medical Sciences, Srinagar, and from the Department of Immunology. And she'll be speaking to us on antigen presenting cells and MHC, basic understanding for clinicians. So thank you, Dr. Ruhi, and I request you to kindly start your presentation. Dr. Ruhi, you're muted. I think you have to unmute.
It's okay?
Yeah, thank you. Yeah.
Okay, fine. Thank you very much, ma'am, for your kind words. I really feel honored. First of all, a very good morning to all of you. I'm grateful, thankful to the organizing committee, especially Dr. Saibal, to give me the opportunity to be on this side of the dice. And the topic which has been given to me, that is the APCs and MSc, which is a basic science topic, and to make it palatable and easy in front of the hardcore clinicians, it was slightly bit difficult to me, and it's just a hard nut to crack. Anyways, I will try my best to make it as simple as palatable, and hope you will bear with me on this topic. So I'm going to dwell upon these are the contents I'm going to discuss. This is the contents, various contents, which I will go discuss briefly. So the first slide, which I'm going to discuss is, the introduction of the immune system.
Ma'am, please share your screen, ma'am.
I'm sharing. It's not visible?
It's not visible.
No, madam, your screen is not visible.
Okay. Let me see. Let me see why there is a problem. Wait.
अगर नहीं हो रहा है वाईफाई से करो, मोबाइल से किसी के जियो से जियो चल रहा होगा।
Can you go into the slide presentation?
Make it full screen, ma'am.
Yeah, it is visible, but can you go into slideshow?
Yes, I will just.
Yeah, thank you.
It's okay? It's visible now?
Yeah.
Yes, ma'am.
Yeah, thank you.
So the various contents which I'm going to discuss in brief are these very headings. And to begin with the introduction of immune system. The immune system is a complex network of cells, tissues, organs, and substances the body to fight not only against infections, always the first line of defense, which is always there, and by the innate. It is a kind of immunity which has a memory response and provide the long-term protection. The another way of categorizing this immune system, that is innate and adaptive immunity, is we can say they are non-specific immune defense as well as the specific immune defense. Non-specific involves the various organs, like it is the first line of defense, as I said. So skin, mucous membrane, phagocytic cells, interferons, acids, and other things, and other cells will be involved. Whereas in non-specific, it is the cell-mediated and humoral immunity, both of which they attack the specific cells. So here we can see These are the cells which are involved in innate immunity, like dendritic cells, mast cells, macrophages, natural killer cells, eosinophils, basophils, granulocytes. Whereas in adaptive immunity, it is the B cell and the T cell, which are both involved. And here you can see it is a natural killer T cell and the gamma delta T cell, which share the both functions. That they will act as an innate immunity also and in the adaptive immunity also. The innate immunity there is no memory in the innate immunity. It doesn't need a prior recognition of the antigen. There are the receptors present in innate and adaptive immunity are different, and it is the first line of defense you can see in this against infection. So now we will go to the anti-presenting cell. The anti-presenting cells are the specialized cells where main aim is to display the antigen and present it in person of MSC to the T lymphocytes. There are two types, that is professional APC and non-professional APC. These professional APCs mostly include macrophages, beta lymphocytes, B lymphocytes, and dendritic cells, and they are distinguished by the features that they express MSC2 molecule on their membranes. Together, they have the co-stimulatory signal that is necessary for TH cell activation. Also, in addition to they have the receptors which are known as PAM receptors, that is pathogen associated molecular receptors. Whenever there is entry of either the allergen or the microbe or the virus, whatever they do, there is activation of these TLR-like receptors or PAM or DAMP receptors, which activate the dendritic cell and then leads to the activation of either humoral or cell-mediated immunity. This is here you can see, this is a pictorial diagram where I have shown in a very brief, in a very simpler way, what happens is this is you can see here the dendritic cell. It is one of the antigen is present, it recognizes it in presence of MSC1 or MSC2, and then here you can see this is MSC1. This is MSC1 in presence of peptide. They present it, and they are represented. They are recognized by the TCR of naive T cells. They get activated and they become effector cells. Here, after becoming the effector, there is a clonal expansion and differentiation of these effector cells. The difference between the macrophage and B cell with the dendritic cell is dendritic cell activate that naive T cell, whereas macrophages and B cells, they act on the effector T cells. The effector T cells, once they release the cytokine, that is either the interferon gamma, once they act on the macrophage will get activated and leads to the destruction of the microbe in itself, inside the cell, which is known as CMI or cell-mediated immunity. In B cell, that is the humoral immunity, what happens is once it will present the antigen to the once the APC is presenting antigen to the effector T cells, it activates them, releases the cytokines, whether it is IL-4 in case of allergy, which leads to the production of IgE production, or it can lead to the other antibody production, which can later on cause the, we can say, neutralization of that microbe or cause the death of that microbe, which is known as humoral antibody, humoral immunity. After going to with the APC, a small description about the MSC, what MSCs are. MSC is a group of the genes which are involved in the immunological recognition of self from non-self. Not only in this, they have also role in evoking the immune response. They are present in the short, as you can see, this is the short arm of the chromosome 6. They are encoded by the short arm of the chromosome 6. In humans, they are known as HLA, that is human lymphocytic antigen complex. They are expressed on the all nucleated cells except the these RBCs, and their main aim is to present the antigen to whether it is a cytotoxic T cell or whether it is a helper CD4 cell. So what is the function of this MSC? It determines the response of individuals to the antigen. It helps as an APC. It is involved in humoral and cell-mediated immunity. It helps in the discrimination between self and non-self, and it is helping in the intracellular replication also. So about its organization, there are 3 types of MSc class. That's MSc class 1, 2, and 3. The MSc class 1, this MSc gene is a 4,000 kilobase pair gene, and among them, MSc class 1 is the longest, having the 2,000 kilobase pair length. It is a glycoprotein which is present on, or rather expressed on, all nucleated cells. The major function is to present the antigen to cytotoxic T cells. Whereas in MSc class 2, it is a glycoprotein which is expressed only in field cells, that is on the professional APCs, that is either the dendritic cell, B cells, or macrophages. And their main function is to present this processed antigen CD4 helper cells. In between MSc class 1 and class 2, there is also a MSc class 3, but that doesn't have a role in antigen presentation. They have the role in complement, they encode complement system, inflammatory molecules, and factor F. Now, what about MSc gene? It is composed of, it is found in the region ABC in humans, and it is composed of 3 loci, that is ABC loci. These ABCs are encoded by MSc1, whereas in MSc2 encodes the 3 loci, that is DPQ, DP, DQ, and DR. These are the classical ones. The other non-classical ones in case of MSc1 is HLA, F, E, and G, whereas in case of MSc2, it is DM and DQ, and DM and DH. Whereas both MSc class 1 and MSc class 2, they share the structural features. They are both involved in antigen presentation. MSc class 1 is involved in regulation of antiviral immune response and also helps in presentation of normal self-antigen. However, class 2 is involved in the regulation of immune system, that is both cell-mediated immunity as well as the humoral immunity. And class 3 have no structural similarity to class 1 and class 2. There is no role of MSc class 3 in presentation of antigen to CD4 or CD8 cells. Now, a brief structural function. What MSc class 1 molecule is? It is a 50. It is composed of 2 chains, that is alpha and the beta 2 microglobulin chain. Alpha chain is about 45 kilodalton in weight, whereas beta 2 microglobulin, as you can see here, beta 2 microglobulin, it is just 12 kilodalton. They are non-covalently attached to each other. This alpha chain is composed of 3 domains, that is alpha 1, alpha 2, and alpha 3 domain. This alpha 1, alpha 2, and alpha 3 domain, this is the peptide binding cliff. As you can see, the most polymorphic nature of this alpha 1 and alpha 2 domain is that is antigen is binding in this cleft, whereas this is a non-polymorphic chain, and in this is like a immunoglobulin fold like structure. It is non-polymorphic, and this is the site of attachment of the CD8 molecule. It has this is the extracellular membrane, this is a transmembrane portion, and this is the intracytoplasmic region. They have since the cleft here is very close, it has a very less space of attaching the peptide size, just the size of 8 to 10 amino acids peptide gets attached to the base of this cleft. This is the MSc class 2. It is also composed of 2 chains, that is alpha chain and beta chain. But here, instead of having, they have alpha 2 domains. Here they have 2 domains, alpha 1 and alpha 2, and beta 1 and beta 2. Alpha 1 and alpha 2 are polymorphic, and the cleft here is for attachment of the peptides, and it is open as compared to the MSc1 where it is closed, and so the size is larger than the previous one. Previously it was just 8 to 10. Here it is 13 to 18 amino acids, and this is the site
I think the link is lost. We're not audible. Jumbo, can you check on that?
Hello.
Yeah, I think the link is lost or something. Can you check on that?
Yeah, I'm trying to contact madam. Madam is just joining. There is some technical glitch there.
Okay,
So-
no problem. No problem.
So we'll wait for maybe 1 minute or 2 minutes like that.
Yeah, thank you.
So actually, we on behalf of Team ALLERCON, we are really glad that we have a pan-India involvement of allergists here. So starting from, and it is a really honor for us that a speaker from Kashmir and a chairperson from Hyderabad. Really, we are very much thankful to all of you, all of our respected faculties, to acknowledge our appeal to present with us. So let's wait for madam. Maybe there is some technical issues. So
Yeah.
within 1 minute, it will be solved, I guess.
Yeah, thanks, Jumbo.
So madam, may I request if there is any question or any doubt in between, so that we can have that, because two of our previous speakers are still there.
Yeah.
So if we have any questions or any comments from the
Yeah,
respective delegates and other faculties, so we can discuss in between.
Yeah, true. So, but there don't seem to be any questions in the chat box. So if the other faculty have any questions for the two speakers, so it'll be great. I think they will definitely love to answer the questions. Dr. Alakendu Ghosh and Dr. Neeraj Gupta, I think they're still with us. So, and if you didn't have time to ask questions, I think this is the best opportunity for you to encash and discuss with the speakers.
May I ask one question?
Yeah, sure.
So my question is to Dr. Gupta. In one of the slide, he told about the flip-flop effect. Can he throw some light on that concept of the flip-flop effect on gene and environmental factors? What is that? So, hello,
Dr. Neeraj Gupta. Dr. Neeraj, I think you're there with us.
So
Dr. Neeraj has opted out.
Oh.
So
Okay.
we are also really honored to have one of the famous allergologists in our country, Dr. A.B. Singh, here. So may I request Dr. A.B. Singh, sir, also to throw some light on this issue?
Thank you. I hope so long this technical problem is being solved, we can chit chat, and I don't have any questions to the previous speakers, because I was listening to Ruhi, who is a well-known immunologist from Srinagar and is very active actually in this field. And recently she has published a paper on sublingual immunotherapy, which was very, it was required for the country very well, because we did not have much scientific information on the sublingual immunotherapy. And it is because of that reason, the drug controllers do not approve the sublingual, and it is but is still being sold off the label by the manufacturers. So, that way that will contribute probably to take an appropriate decision. And I'm glad that some more work will be done by Ruhi on the sublingual immunotherapy. Can you listen, Dr. Ruhi?
I had just a talk with her, sir. Madam is trying to join, but facing some problem there.
But can we share, and in the meantime, some next speaker can start, and is that because?
I think this this session ends with these 3 speakers, sir.
Okay. So through this this ALLERCON 21, I would like to appeal to all the members who are interested in the field of allergy and immunology to strengthen our Indian College of Allergy and Applied Immunology, which is a more than 50 years old organization. And probably we together can further take this discipline to the highest level, and it will make it academically sound as well as acceptable by other disciplines of the medicine as well. Still, there is some reservation by some quarters about the usefulness of the allergy and immunotherapy, although most of the global bodies are the professional bodies like European Academy, American College of Allergy, World Allergy Organization. They have come out with a lot of evidences and meta-analysis. And so, in India, but still, since allergy and asthma is not an approved course by medical council, and that's why it's still being, there's some sort of, so efforts are on, although for certificate course, MCI is approved, but the terms and conditions are there such that they require so much faculty, this facility, that facility. It has not yet been initiated in any one of the institutions, except Vallabhbhai Patel Chest, but that too is also not a recognized one so far by the MCI.
Yes, sir. And another, just want to share one information, sir, that from our center, that is the Allergy Asthma Research Center, we had also conducted a real-world evidence type study, a prospective observational study on those patients who were on allergy and immunotherapy. And actually, it was my thesis paper. So we had also seen benefit in terms of symptom score, medication score reduction, and we had almost a cohort of 600 patients in that particular study. So,
Sambhu, the question is, these are personal observations. Unless they are published and accepted by the scientific community globally, or maybe at least Indian papers, because we had discussed a lot in the drug controllers meeting, just to get the sublingual immunotherapy technically approved scientifically, so that manufacturers can start giving it with the licensed item. But unfortunately, they said there is no data as such available about the dose, concentration, other things in the Indian population. So some pilot studies are required to do the prospective study, some pilot study to collect our own data on our own local patients, so that dose, duration, concentration, everything is standardized, and then they are ready to approve it. So these are the technical problems. Very good, you are doing it, but to come out, publish, once there are 3-4 good publications from different parts of the country, probably we will be able to convince them that here is a science and it can definitely be approved.
Yeah, any further questions, please? There is one question by Rupali Jain, who says, I'm an ENT surgeon as well as a medical legal consultant. My interest is also in allergy and immunology. If SLIT is not accepted, how much liable we can be if some problem arises?
I didn't get her question actually. What is that?
She's an ENT surgeon and a medical legal consultant, sir, and interested in immunology and allergy. And she says that if SLIT slit is not accepted,
Yeah.
how much liable we can be if some problem arises?
Yeah, we are equally liable actually. We are doing unethical practice, it means. Because it has not been approved just by the Drug Controller Government of India. And even the manufacturers are not supplying with the label there is an immunotherapy, sublingual immunotherapy vial. They never write. So they same themselves. And they supply in the name of diagnostic kit, which is almost the same concentration, 1 in 10 concentration, 50% glycerinated buffer. So they supply in bulk as a skin prick test antigen. So these are some of the issues we as a scientist, we as a, in the field, we have to restrict that and we have to do a scientific approach for that. Once the data is available, Ruhi has published one very good paper recently. So 1 or 2 more papers, probably we will be able to convince the drug controller to give the permission to the manufacturers to legally produce the antigens. But as of today, this is unethical.
Okay. Yes, sir. Thank you very much, sir.
Yeah.
And I think that's it.
What is the status technical? Is the fault at the Ruhi's side or at your end?
Sir, could you please repeat, sir?
I mean,
No,
is the
sir is
technical
asking-
fault is at your end or at the Ruhi's this?
No, the problem is in the Madam Ruhi's end. So there is some network issue there.
Yeah, Kashmir, it is likely to be there. Yeah.
Yeah, true.
So I had again.
And just trying to answer that flip-flop effect question somebody had asked. Well, of course, I'm not an experienced, I don't have the expertise so much, but the little which I could understand is that, they had tried, when he was trying to discuss the relationship between the environment and the gene. See this, you have an environment and then you have many genes, or you have, the same gene versus the various changes in the environment. But, even if it's the same genotype in the same environment, you may or may not get the associated disease is what I have understood. Because there is a role of some phenotypes and there are a lot of other confounding factors also. So once the phenotype changes, so this aspect may be affected. And then he had discussed on the epigenetics, which is very well associated with the changes in the phenotype and the role of phenotype. So maybe something like that. So
I think this guy is started working.
yeah, yes.
Ruhi's slides are visible now.
Madam, you have to unmute yourself, Ruhi Madam.
Go into the slideshow and unmute. Then
Yes, madam. Now you have to make this full screen and we can see your slide. Yes, madam. It's perfect, madam.
yeah, thank you, Ruhi.
So sorry for this disruption in the internet. Actually, from last 10-15 days, there is a lot of internet disruption in the valley because of some problems here. So despite having a LAN connection, this gets connected. I'm very sorry for this. Anyway, I'm going to, may I know from which slide I was not audible because I was
yeah, from this slide. I think this is the slide.
This is the slide?
Yeah.
Let me talk.
Is class 1 MHC.
Madam was discussing on class 2 MHC molecule. Again, the connection is lost. Hello.
Hello. I think again the connection with the Rui is disrupted.
Yeah, I think there is problem.
I think Sambhu, you can take up the next one, and then in the meantime, let her try once they become stabilized the internet. I don't know.
I think Shambhu, the session ends at 11:25 or something.
Yeah, it's just exactly.
Yes, madam. We have to then we are very sorry, madam, because of this technical glitch. These are the part of this type of virtual meeting.
Yeah,
And,
understand.
I think we all have to accept this. Although this is unfortunate thing, but there is some real issue from
Yeah.
the madam sent. So may I request you to end up the session.
Yeah, and before I end up, let me thank you, Dr. Tripathi, you and the other organizers for having invited me for this session. And it was actually a very, very interesting session. I have my co-chairperson, Dr. Jayati Das, she actually very, aptly started the session. And we had Dr. Alkendu Ghosh and Dr. Neeraj Gupta, who are the first two speakers, and they had very emphatically discussed on the role of the allergy, autoimmunity, the missing links, and then finally they had even discussed on the various aspects of the allergy and autoimmunity, and and how complex it is. We all understand it's a very, very complex phenomenon. So actually we were having one of the best speakers with us. Unfortunately, the link got disconnected, and Dr. Ruhi was, she had in fact just discussed the cellular and the humoral immunity, the basic concepts, and she was going through the major histocompatibility complexes, the functional aspects of it, the various classes, and then it's very interesting to know that she had worked a lot on sublingual immunotherapy, and we thought we could hear more from her because it's a personal experience, and this is being very much practiced by clinicians. So unfortunately, we missed that aspect. But I just let me see. I think there's another question. There's a question, sir. If Dr. Singh can answer, it says that in accordance with Dr. Jain's question, is subcutaneous immunotherapy also unethical?
Subcutaneous immunotherapy is being used for more than 100 years now, madam. And this is very well, even in India, it is almost 40 years since we are regularly using at various institutions and private. And this is very well approved by the government of India drug controller. So it is very well ethical, provided the, selection of allergens, selection of patients as any other discipline is there, that should be there. But that has been approved. There is nothing unethical in using the indigenous allergens.
And then there's one more question, sir. Which manufacturers are having the license to manufacture FDA approved?
Okay.
Yeah.
FDA means Indian FDA. Okay.
Yeah.
Because here I'm talking about the local manufacturers who are producing the allergens for diagnostic and also for immunotherapy purposes. By and large, there are four manufacturers here in India. One is based in Delhi, that's Alcure Pharma. Another is a small organization, is Alcit India. There is a Cadisol in Bombay. And there is one bioproducts and diagnostics in Trivandrum. These are four well recognized, duly approved by the state government drug controllers. And they both are well equipped to supply the subcutaneous allergen immunotherapy. I'm not advocating any company, but these are the four ones with various levels of standardization of allergens. They are there. Unfortunately, we did not have much, quality control I mean, because even drug controller did not have much idea about this. Only recently, during the last 3-4 years, they have been sounded, and now they have fixed up some pharmacopoeia. What are the basic minimum standards for the quality control of local allergens? That is their protein content, that is their PNE units, weight by volume, and also the protein profiling has been introduced, and each and every batch is supposed to be reproducible and having less, discrepancies from one batch to the other. This is a common phenomena everywhere. So as per the Indian pharmacopoeia, there are some standard quality control guidelines that every manufacturer has to follow.
Thank you very much, sir. And I think Dr. Ruhi is joined in again. Welcome back, ma'am. So you can unmute yourself and start the session. Dr. Ruhi?
Yes.
Yeah.
So once again, because of the poor internet connectivity in Kashmir, as usual, this has been from last 20 years, we are seeing this problem with us. Anyways, I will start it again. So this MSC has two chains. As I said, it is alpha and beta 2 microglobulin, which are non-covalently attached to each other. And alpha chain has 3 domains, that is alpha 1, alpha 2, and alpha 3. And it is in between these alpha 1 and alpha 2 domains that there is this cleft where this peptide is getting bound and then presented. And this domain, that is this alpha 3 domain, is an attachment site for CD8 molecule, which is present in the CD8 cytotoxic T cell. This is a transmembrane segment, and this is a intracytoplasmic tail. You can see, since this is a very close site, only the size of peptide size of 8 to 10 amino acids gets attached to it. And this is about the MSC class 2 molecule having two chains, that is alpha and beta chain. But here we have alpha 1 and alpha 2 and beta 1 and beta 2, again non-covalently attached. And the peptide binding site, which is here, it is open. So the peptide size is in more than the MSC1, that is 13 to 18 amino acids. And it has these highly polymorphic sites, that is with alpha 1 and beta 1, where the peptides get bound. And this is a non-polymorphic site where the CD4 molecule of CD4 T lymphocyte gets attached. This is here, you can see, this is the closed end and this is the open end. So only just 8 to 10 peptides gets attached to this site, and more than 20 peptide sites gets attached to here. And this here you can see, as I said, that all nucleated cells except RBCs have the expression of MSC class 1. So they present the allergen or antigen to the cytotoxic CD cell, which then leads to the direct killing of that particular cell, having either a microbe or a virus or the tumor antigen. Whereas in case of CD4 cells, it is there. Once they get activated in presence of the co-molecule, that is CD4 molecule, they lead to the activity of cell-mediated, either the cell-mediated immunity or humoral immunity. Here I am going to describe what happens in the MSC class 1 pathway. Here, whenever the any cell, that is all nucleated cell, whenever the virus gets introduced into the cell, or any microbe or virus or tumor antigen are present within the cell, they get ubiquitinized. That is, here it is the cytosolic proteins that are getting processed, that are getting cleaved. So it is the ones the ubiquitinization takes place. There are some proteins which get leaked from the phagosome, so they also reach into the cytosol. They are all the cytosolic protein. They gets ubiquitinized and reaches to the proteasome. Proteasome is a slender group of the, you can say it is a slender where we have multiple enzymes which leads to the cleavage of this synthesized viral protein. So once they are here, you can see once there are peptides are there, they are taken by this TAP. That these are ATP-dependent transporter protein. They are of two types, type 1 and type 2, and they help in the transport of these peptides into this endoplasmic reticulum. This is the lumina of the endoplasmic reticulum, and this, by the help of chaperones, they lead to the synthesis of MSC class 1. Now this is MSC class 1, and here is a cleft where these where these peptides will get bound and attached to it. So, and releases the beta 2 microglobulin. Here from this endoplasmic reticulum, they are transported by the help of taps. They are reached to the Golgi apparatus. From Golgi apparatus, in the form of this exocytic vesicle, they reach to the surface of the nucleated cell. And now they are presented in a stable form. What stable form we can say is, once they have both alpha 1 chain and alpha chain, and this alpha 1 and alpha 2 chain, plus there is a binding of the peptide into the cleft, into the floor of the this cleft. Now it is a assembled, stable assembled. Now only these CD8 will recognize them once they are stable, once they are assembled properly in presence of the co-receptors like CD8 molecule and other co-receptors like B7 or CD40 ligand. They will get activated and leads to the cytotoxicity. That is, there will be destruction of these microbes or viruses by these cytotoxicity cells. This is the mechanism of class 2 pathway. Here, the difference between MSC1 and MSC2 is in MSC1, it is the cytosolic proteins which get cleaved. And here it is the exocytic proteins which enter into the APCs, which can be either, as I said previously, MSC class 2 is present in the dendritic cell, in the AP cell, and in the B lymphocyte. So, once the allergen, it can be either the allergen, it can be antigen microbe. Once it gets endocytosed, either by phagocytosis or receptor-mediated endocytosis or by pinocytosis. For any form, they lead to the formation of the phagosome, or this phagosome, or later on late endosome, this fuses with the lysosome. So this is the fusion of lysosome with the endosome. So the enzymes which are present in the lysosome, they will act on these proteins and will break down it into the peptides. So what happens? Here in the ER, as you can see in this endoplasmic reticulum, there's a formation of, with the help of chaperones, two chains of alpha and beta chain of MSC is formed. And there is a one beautiful thing in this in MSC, that is the invariant chain. This invariant chain comes, gets bound to this cleft of MSC2 molecule. And it is this MSC2 molecule plus this invariant chain which gets transported from this endoplasmic reticulum, and in the form of the exocytic vesicle, it enters into this late endosome or lysosome. Now, the enzymes which are present in the lysosome, they will do the cleavage of this invariant chain and will lead to the formation of clip protein. Am I audible? Am I audible?
Yes, ma'am, you're audible.
Okay, fine. I thought maybe there is again a break in the interview.
No, ma'am.
Sorry for this thing again. And anyway, now it leads to the formation of this clip, small monomer, which has a beauty of getting attached to this. Here you can see it is the beauty of attaching to the cleft of MSC2. Now comes the role of HLA-DM. What is this? It causes this HLA-DM causes this HLA-DM replaces this MSC2, this clip protein from it replaces this MSC class 2 from this cleft, and now this MSC2 is now this peptide gets bound to this MSC class 2 here molecule, and this in the form of exocytic vesicle, it reaches to the surface of the APC, whether it is a dendritic cell or macrophage or B lymphocyte. So now this and presents it to the CD4 T helper cells in presence of this CD4 co-molecule. And this, the beauty of these T lymphocytes is they don't recognize the allergen or antigen if they are present in the free soluble form, but only when they are attached to the MSC, then only they can recognize these antigens. Now, another beauty of MSC is that it is polymorphic. The most highly polymorphic gene which is present in whole genome. The causes of polymorphic is that multiple gene loci are present, and that means different individuals will have different alleles. some person will have one haplotype, another person will have another haplotype, and the other another important point, which is that is codominant expression. That is, the genes are linked together. That means they are transferred from maternal to paternal to the sibling as a whole. There is no recombination takes place. This is a beauty of this thing, that there is a codominant expression. Because of this codominant expression, there is diversity in MSC molecules at the population level. As I said, there are multiple loci are present in this, and each person will at least express 6 MSC class 1 and 8 MSC class 2 molecules. Although, as I said, there are enormous number of peptides need to be presented using these molecules. This is HLA loci, and these are they have 218 allotypes. B has 439, C has 96, and that goes on. Similarly, in HLA, DP, and DQ, there are so many alleles. And in addition to this, if we will do the sequencing, that is sequence-based typing, there are further sub-alleles. That is, instead of having HLA B1 or HLA DR1, there will be HLA DR1 04, 02, 03. There will multiple sub-alleles will be there. Now, what is the significance of this MSC polymorphism? This not only affects the ability to invoke the immune response, but also affects the resistance or susceptibility to infectious disease. That is, some people's ability to develop, that is at least part of the individual's ability to develop an immune response due to individual's MSC genes. Why some people will respond better to some allergen, to some antigen, some people, like we see recently some in COVID infection, some people responded very well, some did not respond, some had cytokine storm. So it is dependent on that particular individual's MSC. This is where the role of MSC comes into the play, that it will help the person to develop either to the resistance to the infection, that particular infection, or it will become susceptible, not only to the infections, but to autoimmune diseases and allergies also. As you can see, like in patients who have HLA-B27, they are 90%, their relative risk is around about 90 times. They are more likely to develop ankylosing spondylitis as compared to the person who are negative for HLA-B27. Similarly, in narcolepsy and in hemochromatosis, there are diabetes mellitus, there are other various autoimmune diseases where we have seen association of HLA antigen in them, which shows the susceptibility to that particular disease. Now, what are the diseases which is it associated? Number one is allergies, definitely, which is our topic, and the neurological disorders and autoimmune disorders. A huge list of neurological disorders. I'm not going to discuss into this. These are the autoimmune diseases like ankylosing spondylitis, as I said, 90% relative risk of developing this. This is Graves' diseases, multiple sclerosis, SLE, and insulin-dependent diabetes mellitus. They have the risk. Those patients who have these, HLA, they have more susceptibility to develop that particular disease. Now, very important point, that is a transplantation, whether it is renal, liver, or bone marrow transplant, we need to have the matching between donor and the recipient. That is the HLA matching. HLA matching is to be done. The more matching is there, more better is the graft will be surviving and graft will be accepted. Now is our own topic, that is allergy. Where is the role of MSC in allergy? So we can begin with this, like what happens is this is the dendritic cell which encounters the allergen. Dendritic cells present in the epithelial cells, whether it is a skin, whether it is a respiratory epithelium, whether it is a GIT epithelium. So the first, because they are abundantly present dendritic cells there, so the once they encounter the allergen, the first sensitization which occurs, that occurs because of this MSC. So once these antigens are processed, and these processed antigens are present in presence of MSC2 to the 9 T cells. Here you can see to the 9 T cell, and 9 T cells gets affected and they become differentiated into the Th2 helper cells, which lead to the production of the huge number of interleukins which have different functions. Like IL-4 will act on the B cells and will lead to the formation of IgE, which will go and bound to the mast cells and lead to mast cells, basophils, eosinophils, and lead to the production of histamine, bradykinin, and prostaglandin, which all of you know already. No need to discuss it here. They will act on they will impair the epithelial barrier. They will increase the hyperplasia of smooth muscle will be there. There will be increased IL-9 will lead to the production of the mucus production will be there. IL-5 will be produced by Th2 cells. And that will lead to the formation of, that will lead to the activation of eosinophils, and eosinophils will lead to the formation of major cationic protein and other basic cationic protein, which lead to the inflammation of the tissues. And thus all the characteristics which we see, whether it is asthma, rhinitis, AD, or food allergy, they are responsible because of these the cytokines which are produced by Th2, which in turn gets activated by this MSC2 molecule. This is the role of MSC2 in activation of the T cell. This is here, I will show just how APC is presenting the MSC2 molecule, the antigen, that particular peptide, which is represented by the TCR of the CD4 helper cells. And this is how you can see where they are acting on different mast cells, basophils, and producing not only the sensitization, that is the first acute reaction. So once there is exposure of the allergy, it will lead to the chronic allergic reactions and producing the multiple phenotypes of the allergy. Here now is what are the various alleles which are responsible. Some alleles are responsible, susceptible to the development of that particular allergy, and some are protective. Like you can see in red, I have put them as susceptible, and blue, black, I have them that they are the protective. So this is HLA-B, class 2 allele, and this is HLA class 1 allele. These are the various alleles. If the patient will have that particular allele, that means they are susceptible to develop this particular type of disease in that patient. This is ARD, this is drug allergy, this is ABPA, bronchopulmonary aspergillosis, this is in food allergy, susceptible genes, susceptible alleles that particular person will have, and this is a protective allele. If that person will have, it may have a role that it may genetically, they will not be prone to develop that particular disease. Now is how not only in the allergy susceptibility MSC is involved, but in AIT also. That is AIT, whatever the route it is, whether it is SCIT, SILIT, or oral immunotherapy, or intralymphatic immunotherapy, or epicutaneous, whatever the route. What is main aim of the SCIT? Main aim of immunotherapy to enhance the tolerogenic dendritic cell, to produce the Treg cells, whether it is T regulatory cell, whether it is B regulatory cell, whether it is tolerogenic dendritic cell. So to develop tolerance, or we can say to develop tolerance to the allergens. So what happens? The first thing that we see after using the AIT is that there will be suppression of these dendritic cells. So what happens in dendritic cells? Normally when the allergen or antigen is, they are in the resting state, but once there is encounter of the allergen, there is increased expression of the MSC2, there is increased expression of the co-molecules, and there is presentation of that particular allergen to the CD4 cells. And so, but once we will give the AIT, what happens because of this suppressor dendritic cell or tolerogenic dendritic cell, this MSC2 molecules will get, we can say, repressed. There will be downregulation of expression of these MSC2 molecules. So once they will be reduced, the co-molecules will be also reduced. So there won't be production of the IL-4 and other cytokines, which will activate the CD4L cells. So Th2 will be skewed back towards the Th1 or to the tolerogenic cells or to the development of the T regulatory cells. This is how here AIT has a role, even in has a role. That means MSC has a role even in AIT by reducing the MSC expression in the dendritic cells. So we can say it is not effective in all allergic individuals, AIT, and is not equally effective in treatment of different allergen sensitive. That is, some patients will have optimum very good response, some are less responders, some are moderate, and some are not responders. So what is the reason for being some are good responders and some are not good responders? The reason is HLA. Which HLA gene, which HLA allele that person, haplotype that person is having. By that, we will say whether they are the better responders or whether they are not, whether they are bad responders. So susceptibility or protection from the disease is influenced by HLA molecule. As we have seen, as several studies have been done recently, who have shown that it is either the susceptibility to the gene, to the disease, or it leads to the protection. As they have seen, not only with the protection to the disease or susceptibility, but also they have seen that it is, HLA has an association even with responsiveness of the AIT. So this is the once we will give AIT. What are these are the alleles which the patient may be having, who will have an optimal response, like they will have DRB1, 11, 0, 1 to 4 alleles. These are sub-alleles. A2, they will have A2, that person who will have A2, as I said, the person will have 6 HLA class 1 alleles and 8 HLA-B2 alleles. If the person will having this allele, they will have a good optimum response to the AIT as compared to the patients who will have this HLA type, they will have the poor response to the AIT. So again, a role of HLA in AIT also. So in conclusion, I have tried to make it as simple as possible because the clinicians in front of me, they are poor clinicians. It is very difficult to make it. It is a slightly hard nut to crack. Actually, I tried to make it as simple as possible. I don't know whether I'm able to do that. I have given just to my talk or not. Anyway, so in conclusion, MSC variants influence immune recognition, susceptible to infection and autoimmune disease. The role of HLA in the very beginning of allergy sensitization process makes them the natural candidate for research on genetic susceptibility to allergies. So if we will do the screening of the patients at early, we will come to know which patient is susceptible to the development of allergies or not. As various reporters have seen that association of HLA-DRB1, HLA-DQ are associated with the asthma. Similarly, there is seen in atopic dermatitis also, some alleles are there present in certain people which are prone to develop AD. So, and not only that, HLA gene has been also associated, reported to be associated with the responsiveness to the allergen. However, further research needs to be encouraged in the field of HLA and allergies, not only to the susceptibility or protection to the disease, but also in knowing the AIT response. So then we'll be able to discover the new markers for the same. With this, I know with the kind of potential the MSc carries, there is certainly a long way to go. Now that the yoke is off, the possibilities are endless. But I know no road is long with good company. Allergists who have a research bent of mind, like Dr. Saibal or any other who is interested to have collaboration, we can do a collaboration and start with doing a HLA typing in the patients who are having allergy disorders. Ladies and gentlemen, I will tell you something. Together we can do wonders. And thank you all and for your patient listening. Thank you very much.
Thank you, Dr. Ruhi. It was a really wonderful, insightful presentation on the basic aspects of allergies, and they try to link the MHCs, the major histocompatibility complexes, with the disease and the compatibility, HLA compatibility. Yes, definitely it can go a long way, because for transplant, yes, we are doing a lot of HLA compatibility studies, especially for the renal transplant, without which you cannot go ahead with the surgeries. So it was very, very insightful, and thank you very much, in spite of the glitches which you had with the transmission.
Sorry for that one, Sati.
You have done a wonderful job, and I think there are just, let me just check, there are a couple of questions in the chat box. I don't think so. Well, I don't think there are any specific questions in the chat box.
No, there is one.
Yeah, I know. Yeah, it says that it says can you repeat the small sequence as background noise? I'm not too sure which slide they made. Can you specify any slide, Dr. Prashant? And then the next, there's another question which says that how can we test the gene sequence Is it blood sample or mucosal swab? Or where is it done and at what cost?
Gene sequences is done in tertiary care hospitals. It can then be done in the private also. The sample is just, you have to give just 2 ml of blood. That is EDTA blood you have to give. Just you have to extract the DNA and then you can do the sequencing. We are today this time doing the, this is, I mean, some molecular type of, that is micro SSP ABDR typing we are doing. And that is, we are doing the typing of this. But if you want to go for sequencing of this, you need a sequencer in your lab, then only you will do the multiple sub-alleles. But for simple typing, while you will be able to know which type the patient is carrying, you just need a, this SSP trace, micro SSP ABDR trace, and you will be able to do it just from the blood sample. You don't need to have to take the swab or anything else.
I think that they have clarified. They said polymorphism phenomenon.
Yes, polymorphism means is just a change in the gene sequence. But if it is the change is more than one base pair in 1% in the population, then we can say is polymorphism. That is, it should be in the population more than 1%. Then we can say is polymorphism. You have to take a lot of samples in polymorphism as compared to the mutation. Where in a single case, although there is also a change in the mutation, change in the gene sequence, but that is in a particular person. But here we have to see a population study needs to be done, and we have to take the care of the controls also. We have to see whether that polymorphic change sequence is present in the controls also. That's what.
They wanted some, a few words on SLIT, slit. And do you need to take the consent before giving slit?
Yes, definitely. Not only we are here in our department, we not only give the consent, take the consent for slit, but we take consent for skit also, consent for SPT also, consent for all the allergy testings we are taking first. Definitely we have to do this consent. Without that, we cannot proceed forward.
Yeah, so I think that's with the questions, and thank you very much, Dr. Ruhi. It was really wonderful listening to you.
Thank you very much. Once again, sorry for the internet disconnectivity.
It was wonderful. And okay, over to you, Shambhu.
Thank you.
Shambhu, can you unmute yourself?
Yeah. Shambhu, can you unmute yourself and Shambhu?
Dr. Shambhu, are you listening? Anybody from the organization?
Yes, sorry, sir, because I have to there in the second call.
Okay.
So we are really thankful to Madam Usharani Pingali and Dr. Jayati Das to chair this session. And we have wonderful, or we can say galaxy of speakers in the first session. So I request our technical team to project the slides of our faculties, that is to show the next year here. So please make it. So we have chairperson Dr. Gautam Shaha and Dr. Shoibal Moitro there. But it is a real honor for us to introduce, next slide please, to introduce Dr. A.B. Singh, who is the scientist, emeritus scientist in the CSIR, that is Institute of Genomics and Integrative Biology in the Delhi University campus. And he had more than 250 research publications, international publications and national publications. And also he's the author of 4 books on allergy and allergens, more than 25 chapters he had written. And he is the secretary of Indian College of Allergy, Asthma and Clinical Immunology since 1993, and also the Secretary General of South Asia Association of Allergy, Asthma and Clinical Immunology since 2002. So may I request Dr. A.B. Singh sir to proceed with his presentation. And I think this is one of the most important topic while we are dealing with allergy and immunology, specifically the clinical practice on allergy immunology is very much dependent on this issue of aerobiology, the principles of aerobiology. So may I request sir to proceed with his presentation and to enlighten us.
Thank you, Dr. Shambhu, for your nice words of introduction. And I feel it's privilege and honor to join the galaxy of previous speakers here this morning. And I thank the entire organizing committee, including Dr. Mohatra and yourself, to give me this opportunity to share some of our work or the experiences with respect to the aerobiology, how the knowledge of aerobiology can enhance our capability to provide good, efficient diagnostic and therapeutic management of the allergic patients. So for those who are not well aware, sorry, can it be, there is, just a minute. So those who are not well aware, actually, what is aerobiology? First, we have to understand the fundamentals and basics. Aerobiology, nothing, is the scientific discipline which deals with the aerobioparticles, are the particles of biological origin which become airborne, including its source materials. And most of the biological particles comes from the bacteria, algal fragment, virus, pollen grains, fungal spores, plant parts, dust mites. Anything of biological origin comes under the group of aerobiology, particularly once they become airborne. However, in a recent concept, actually, abiotic inorganic particulate matters like gases, pollutants, also are included into the concept of aerobiology. The reason being, they are coexist in the environment together. These bioparticulate matters, whether it's a pollen grain or fungal spores and various pollutants, they have a synergistic effect on our system, particularly in allergic diseases, independently as well as in a synergistic manner. That's how they have also been included into the concept of aerobiology.
The slide's not visible.
They're visible to me, but is it visible now?
Yes, sir, it is visible.
Yes, visible.
Visible, but if I go for full,
make it a full slide. It is visible. Make full slide.
there is something wrong. This is stuck up. Is it okay?
Sir, you may post it, it's okay.
Headings are not visible even to me.
Screen, sir. Sir, sorry to interrupt. You have to make it full screen, sir. So there is
a the full screen.
I think there is some issue. So one thing you will do, please, stop the screen sharing.
Okay.
Stop your screen sharing. Minimize your
okay.
PowerPoint and then reintroduce. Yeah. So minimize your PowerPoint and then you have to again share the screen. Sir, you have to again share your screen, sir.
But sharing is not showing in the bottom actually. Can I go back? Shambhu, the sharing part is not showing in the bottom here. No, there is a
Sir,
green.
No, the green color share screen option is there, sir, at the end, at the below portion, sir. If you not find, sir, you can share the slides with me also, sir, so that I can share the screen for you. Sir, you please open the PowerPoint.
Just a minute, yeah. Just give me 1 minute, Shambhu. The sharing is not showing at the bottom green one. I'm not able to share it. Shambhu,
Sir,
I'm not
you may,
able to share it because there is no sharing symbol here.
sir, you can share your slides to Dr. Shambhu, and from your end, Shambhu can project the screen.
It was going on well, but सावित्री सावित्री ये है तो भेजना जरा, या तुम ही आ जाओ.
हेलो
हेलो, इसमें शेयर कहाँ से हो रहा है? इसमें आ नहीं रहा.
सर, इज देयर एनी
शेयर?
Kaushik, are you there?
हाँ हाँ.
Yes.
Share ka symbol.
Maybe Singh sir, can you please share the?
I'm getting help of somebody.
Me or the ALLERCON email ID so that we can present from our side, sir.
बोलो.
इनको दूसरे किसी को भेजना है तो कैसे करें? हाँ चलिए. इनको अगर भेजना है तो कैसे करो?
हेलो.
यस शंभू.
होस्ट बनाना पड़ेगा ना. होस्ट बना दो.
There is some problem. It was going on well, but are you able to see now?
No.
Shambhu? Is it okay?
Sir, your screen is not visible.
The slide is not visible to you. It is visible here.
Sir, one thing you can do, you can just share the slides with Dr. Shambhu or Kaushik from your end. They are going to share the screen so that it will be visible.
Sir, in below there is a share screen option, sir.
नहीं है, तभी तो दिक्कत आ रहा है. There is no symbol sign. Actually, it's not coming. It did
There is
come.
a green arrow. There is a green box which shows the arrow up sign. That is the share screen option.
I will start afresh, maybe.
Yes, sir. Okay, sir. Yes, sir. Now we can see your screen, sir.
I think the heading part will not be coming, but rest of the things are coming.
Yeah, you have to make it full screen, sir. There is a below. There is an option to make it full screen, so
I
that we
did that.
can.
That's how I am getting this one.
Okay, okay. So please, sir. Please go ahead, sir.
So another common word which we are being encountered every day, the term allergen. What are the allergens? In our clinical practice, whatever we find anything, there is a cause and effect relationship with the source material or triggering materials in precipitation of symptoms, we call them allergen. But scientifically, allergen is nothing but an antigen which causes type 1 allergic reactions. And physiologically, there is no difference between allergens and the high molecular weight proteins or the carbohydrates. However, the allergenic activity of these molecules depends on the antigenic determinants or epitopes with the chemical configuration, including the folding of the proteins. The allergens produced and disseminated by air is referred to as an aeroallergen. So they have been categorized into 4 different groups actually, depending on the exposure to the body, like inhalants, pollen grains, fungal spore, dust mites, they are come into the inhalants group, and they cause, of course, pollinosis, hay fever, asthma, and so on. Others are groups are foods and drugs, they are ingestants. Then contactants like latex, trichomes, and other plant materials, they are contactants, injectants. I will be focusing only on the inhalants, particularly the pollen grains and the fungal spores this morning. So when the patient comes to us, the major approach that have been established to manage the respiratory allergic symptoms, they include allergen avoidance. If you know to what you are allergic to, you can avoid them. That is the best form of treatment. Then medications to suppress the symptoms, that is pharmacotherapy, which is being adopted, antihistaminic and bronchodilators. Allergen-specific immunotherapy, we have discussed, we will discuss further actually. Patient-physician
The
interaction.
slides are not moving.
Yeah. Is it
Slides
okay?
are not moving. Only first slide is there.
Sir, I think that you need to make that in the home option, sir. If you just see the home, then there is a slideshow option. So you have to click in that slideshow option.
New pause. That is on. Slides are not moving.
No, sir.
Are you Savitri?
Sir, the thing is that the slide is completely freezed in your first slide.
It's very unfortunate. Savitri?
Yeah, now it's moving. Now it's moving.
Let it be like this one only. Maybe you have to compromise.
And now we can see. Now
Okay.
at least the slides are moving, sir.
Fine, thank you. However, the effectiveness of all these strategies in management of the allergic diseases depends on the sound knowledge and thorough understanding of the local aerobiology of the region or the country or the state. You know, India is a diverse country actually. It's a diverse Indian flora, and is blessed to be one of the richest flora on the earth, with thousands of species ranging from Thar Desert in Rajasthan to alpine tundra in the Himalayas. Consequently, we have a variable pollen concentration in season. You can see a fauna and flora found in the Rajasthan will be different than what you find in the coastal areas. Coastal area will find mostly coconut and other things that is not there in the Gangetic plains. Similarly, whatever you find in the high altitudes of Himalayas, they are not present in the local. Some of the pollen grains may be common, but that's how you have to have a local aerobiological information about their concentration, seasonality, and other things about the pollen grains in the environment. So we are bombarded every day by a variety of allergens actually, maybe pollen grains coming from grasses, weeds, and trees, molds as an indoor as well as an outdoor environment, dust mites, the various types of organic dust is not the silica dust on the road, and then denders or epithelium cells, insects, anything in around us can cause the allergic diseases. This is the aeroallergen pathway or the aerobiological pathway you can see. The major source of these bioallergens are the plants, animals, insects, as I told you. This is the left side. It is a classical aerobiological pathway, and this is a medical or clinical aerobiological pathway. These pollen grains or molds are spread into them not to cause the allergic diseases. That is their natural phenomena. They go and they do their own job. So once they are released, the source materials releases in its components in the forms of pollen grains, fungal spore, dust mites into the atmosphere, and they remain dispersed into the atmosphere, varying from few hours to several days, depending on the shape and size of these pollen grains into the atmosphere. And accordingly, they settle down. Where do they go? Sooner or later, they settle down either on the ground or the treetops, animal rooftops, and accordingly they have positive. So this is the fundamental or basic aerobiological pathway. We come into the picture when they become airborne, we inhale them and get the symptoms. So depending on our target organ, they can be deposited on our nose, they can be deposited in the conjunctiva, they can be deposited on the skin. So accordingly, they have their respective allergic diseases of the upper respiratory tract as well as the lower respiratory tract. And those actually we have ultimately the interaction into the body, it takes place. We have positive signs and symptoms. Those who show the positive signs means those who are allergic actually are the atopic status, they are more prone to develop the allergic reactions. And the other group, which are non-atopic, are not genetically predisposed to various allergens, they are the next. That's how 20 to 30% of the people suffer from various allergic diseases, and further pathological changes take place in them. Now you can realize what is the practical significance to a clinician for aerobiological informations, either as international level, national level, local level, or even at a district level even. Because they provide clue to the potential allergens to which patients are exposed to. You must have a knowledge. If you go and interact with the patient, take a good clinical history, he will himself come out, these are the possible cases, and that will help you in selecting the appropriate allergens for diagnostic purposes as well as for therapeutic purposes. The aerobiological information also provides evidence of regular exposure trends in public as well as the patient's interaction. Why? Wherever there is a regular monitoring is done, like in the Western countries, several centers are there across the Europe, across the USA. Unfortunately, India, we have the information for selective periods, only 2 to 3 years at one time, another student goes and another comes. So, and that too at a limited stage. But there is no regular monitoring, just like weather forecast or pollution forecast is not at a country level, is still available. And also the informations actually, if the regular monitoring centers are available, perennial actually across the year, then only you can find out the various, all of a sudden because of the climatic changes, they make the changes actually, and that provides insight actually short-term exposure loads for clinical correlations. All of a sudden, like in Delhi, during this pollution period, smog, a lot of patients start coming to the OPD and all those things. Then you can see what is actually happening in the environment. And this knowledge of aerobiological information is also effective for allergen immunotherapy, whether the patient has come out of that allergen to which he was to be exposed, or it is because of the effectiveness of allergen immunotherapy. And these informations also help you take the avoidance measures or environmental management of the disease. Now, how to briefly monitor the bioallergens? There are various sampling devices which are available. I will not go into those details, but I will see we have described in detail what are the monitoring standards. This is the WOW actually manual, World Allergy Organization, which I was also associated, and other experts from other parts of the world were there. So aeroallergen monitoring standards for the Asia Pacific region. Those who are interested, they can visit the website on the WOW aeroallergen monitoring, and further details about them are available. These are the various sampling devices which are available, and we are also using them for a long time now, and they are globally accepted sampling devices for monitoring pollen and fungal spores. I will not go into those interested, they may visit that site. I found it very useful. This is spot sampling actually for pollen grains and fungal spores, just for during the symptomatic period of 1 week or 10 days during when the patient is symptomatic. If you expose in their bedroom, in their office or their classroom, you find exactly to what they have been exposed rather than exploring 100 and 200 allergens. Those 5 or 10 allergens can provide you the clue to be tested during the symptomatic period. This is another sampling device. This is how, after bringing the sampling, actually, those who are experts in identification of pollen and fungal spores, they examine under the microscope and they can identify up to the generic as well as up to the species level. These pollen grains have beautiful structures, actually. They are multiporate, single porate, with the wings. I will not go into the morphological, but they can be identified right up to the generic level. A lot of evidences, a lot of aerobiological studies have been carried out in our part of the country at different places like Calcutta, Bangalore, and Chennai. And these informations are available in the literature, and they have compiled actually in the form of important about allergens. We conducted an all India coordinated project on aeroallergens in 2000 actually. And this data is available. This was basically conceptualized to find out the important allergens of different regions of the country and to correlate with the local patients' clinical symptoms of the allergic diseases. You can see the red spots are the 18 different aerobiological centers where we carried out with uniform techniques, uniform methodology, and whatever allergenic samplers I have shown, they were provided to all the centers so that the data is comparable. And we tested them, whatever we encountered in the northern part of the country or in the central part of the country or maybe the eastern region, they were tested in the local allergens in the local patients rather than coming from northeast to coming to the Delhi actually. That was not the case. So there are several centers of medical centers like in Trivandrum, in Chennai, in Bangalore, in Calcutta, as well as in Delhi and PGI Chandigarh. They were the medical center wherever facilities were available for assessing their allergenic properties by various methods. So these what they provide the seasonal variations of pollen grains. Like in Delhi, this is the project from Delhi actually. We exposed at 4 different places. We find there is a side-to-side variation as well as from month-to-month variation. And 2 major seasons, you can say March and April, mostly predominated by the tree elements. Whereas after the rains in August and September, mostly the grasses and weeds predominate the season. The World Atlas also is available if you are interested in information, what are the important allergens of Europe and others. I was also associated with this work. And the WOW has prepared a map actually of the global allergens, and they have divided the entire world into 5 different regions, A, B, C, and D. A is in North America, B is South America, C is Africa, European countries divided into D. We come in India, and the Asia Pacific region comes in the region E. If you are interested to find out the important allergens of region E, if you click the region E, you will find the information from India, Thailand, Australia, or Bangladesh. Further, you can go, if you click Thailand or Australia, you will find the important allergens of Thailand. Here are the important common allergens of which are listed over there. They have arbitrarily divided into 3 groups, actually, spring, autumn, and winter. I will not read these names, but they are the ones which are present in different sections. So they be useful, and you visit the site, you can find out these informations. We also carried out the pollen calendar from different states of India. And this is an old work, actually, this needs to be revisited. And important pollen 12 different states has been characterized like this one. The pollen of divided into three actually color codes actually. The green was the start of the pollen season, yellow is the peak pollen season, and red one is the towards the end of the season. Some are perennial in nature, some of them are having a strict seasonal variation. So once the patient comes to you with the seasonality, actually they suffer in the month of March and April, you can select the appropriate allergens whose pollen grains are more predominantly present in the atmosphere during that particular season. Now, how to select a short and relevant allergen panel for testing or for immunotherapy based on aerobiological information. So you should have a general knowledge about the incidence of various sensitization to different group of allergens. Like house dust mites is so far even in India is almost more than 50% people suffer from one or other species of dust mites. The pollen 25%, insect 20%, and this by and large this is the picture globally. But these are two important house dust mite and pollen allergens are important groups. So pollen allergens in India actually, again, whose causes 25% sensitization in the local patients. They are mostly the grasses, weeds, and trees. By and large, they have been categorized into three major groups. Now the question arises, is it necessary to test with all the pollen supplied by the manufacturer pollen extracts, or will be selective? Here comes the knowledge of the local aerobiology, as the local prevalence of different allergens actually in your region, in the atmosphere, in the state level, or at the country level, or at the local level is important. And some information about the cross-reactivity is also desirable. I will not go into the detail by reading the names. Actually, some of the grass pollen allergens which are relevant. Actually, this one, the phloem patterns, lolium, they are basically confined to the high altitudes, actually right from Kashmir to Arunachal Pradesh. They are the hilly regions actually. They were not, still are not available with the manufacturers. But once they recently, about some 2 years back, when the Allergo Pharma came, they located that. So at that time, question arose whether these are the allergens available in India or not. We had done some study on the Himalayan pollen allergen. That's why I could say they are relevant to the Himalayan or high altitude population who are residing. And then there is another group actually, Sargam vulgare, is Cynodon, Dactylon. There are other grasses which are perennial in nature sometimes, and they are present throughout the country. This is the way I actually have been demonstrated. If you interact with the patients, I have compiled them in the form of a book. I will show you. This Cynodon dactylon is very important, universally present all over the India, and these are perennial in nature with seasonal exacerbations. Another grass. So important wheat pollen allergens are listed here. You are very well aware, this Artemisia vulgaris, Parthenium hysteroporus, with their seasonality, pollen distribution, different parts of the country, Gentium chenopodium. You won't find them in their list of the multinationals, but their indigenous allergens, they are more pertinent to our patients as compared to the imported allergens. So Parthenium hysteroporus, Amaranthus, these are some of the wheat. Richness comes, a lot of work has been done. This is also one of the important allergens, wheat in your country and present throughout the country. Coming to the tree pollen allergens, most of the Indian indigenous allergens are Prosopis, Soloptilia, Cassia. You are testing every day. You can characterize them. On the other hand, mountain or Himalayan region foothills are like birch pollen, alder, hazel, poplar. They also, but unfortunately, these extracts are not available indigenously, and we are, trying to convince the manufacturers to also make these available, at least for those residing in the high altitudes. So these are the important tree elements. These Holoptilia and Tigrifolia, very, very important allergens. This is the birch pollen, actually, Butloa utilis, which is predominantly found in the high altitudes and is very, very important allergens. And that's how we are looking them. All the informations of more than 100 allergenic plants are available in this book, which has been published, and they are available with Himalayan publishers. So friends, aerobiological monitoring for public and physician awareness is available in different parts of the world. Like European Pollen Network, they have 88 centers in entire Europe, and every day's data is made available on the internet, on the news or print media, and as well as the visual media, for patients to take preventive measures, as well as for doctors to be aware what are the important allergens. If the patients are coming, to warn them to take the necessary steps. Similarly, United States, there are 88 centers which are governed by the American Academy of Allergy. And the data is again available to the patients as well as physicians on day-to-day monitoring basis. So is the case in several centers in New Zealand, Australia. Unfortunately, India, we do not have a regular monitoring system to find out, but recently there is one sampler which has been continuously working at Vallabhbhai Patel Chest Institute, but this is confined only to the total pollen type. They are not able to distinguish between different species, and probably in future, this data will be made available. This is how it looks like. If you visit the pollen alert, actually there is a site and alert pollen.com. You'll find today's data, and something I hope it will happen also. We have proposed it, and maybe in future, at least 4 or 5 metro cities, it will start functioning. The new emerging pollen allergens in India, based on in vivo and in vitro studies on respiratory allergy patients, we have found out the important allergens of the high altitudes, as I told you, and this data was published in the Asia Pacific Journal. So we conclusively proved by, not only aerobiological, but by clinical immunological methods and in vivo skin tests by demonstrating specific Ig as well as total Ig in the patients, and found the Alnus, Betula, that is birch pollen, Cedrus deodara, Melotus, Quercus, they are important allergens of high altitude regions, and they should also be included in the testing kit or the immunotherapy vial. Another threat which is actually looming large at our population is the olive plantations in India. You know, those who are in the field actually, they know Olea europea. Olive is very important. The oil actually comes from Olea europea. This plant actually, this middle-sized tree. And India's plan is to become a leading olive oil producer because of the shortage of mustard oil and other things. The government has come and they have started planting in plenty. About the more than 151.5 lakh olive trees have been planted in Rajasthan desert and adjoining Gujarat. So they are probably the future threat to us because they are well-known, well-recognized allergens in the Europe. So before introducing this, there should have been some pilot study about the sensitization pattern in the local Indian population. You know, this is more that it has been very well characterized, and we know the Olea europea 1 is the very important allergen coming from, and these are the places actually in the sunshine with different parts of Rajasthan. They are being grown for 150,000 olive trees. This is some 2 years back data. So in the majority of the allergic patients, several allergens add up to the symptoms. What happens? There are some perennial allergens to which the patients are those who are sensitized, exposed to every day. For example, dust mite is a perennial allergen. Modes is also perennial, or pet is also. But so long it is less than the concentration is less than the threshold limits, and you can see the yellow line, then you will not have a symptoms. But during a specific season, for example, the prothop is added in the month of March and April, or holopedia is added in that to which the patient is sensitive, and it crosses their threshold level, you will have the symptoms. So many times if the question, the mite concentration has not increased, the mold concentration has not, why you have got? Because this is the third element has been added to which you are susceptible, and that's how we get the symptoms. Another one is September, October, another wheat pollen or grass pollen is added and get. So long it is less than the threshold level, we do not get. Some more allergens are added. So threshold often exceeds when seasonal and perennial allergens are added up together. Just a few sweeping words about the fungal allergens. Actually, fungal spores are one of the most common source of indoor allergens, and around 30% people of atopic individuals, 6% are found to be allergic to molds. So Ig-mediated sensitization to fungi together with other indoor allergens has been suggested to be a major risk factor for asthma, both in adult as well as children growth. Fungi enter home through your winters, actually open doors, windows, and other places, and that's how later on they found conducive environment inside the homes. When there is a leaky tap or water in the bathroom or kitchen, they proliferate and grow and cause the disease. So major sources of fungi are outdoor soil, plants, dead organic materials, hay bagas, indoor environments, even food storage areas kept in your kitchen or somewhere, garbage containers, damp walls and basements, even air conditioner and cooler, those pads actually they are potential source of microorganisms. So like pollen grains, we also have the important 8 or 10 modes actually, which are relevant to us. For example, Aspergillus, Alternaria, Cladosporium, Penicillium, and they also have got the peak season, although some of them are in some concentration or some erratic concentration, they are present throughout the year. But the one with dark color, you can say the high concentration like June and July is required for Aspergillus. Alternaria is a thermophilic type of fungi, and that's why we find March, April is the peak period, although some of the mild concentrations are present throughout the year. We also conducted some of the studies in the asthmatic children, actually, in the age group up to 17 years of age, from 5 to 17 years of age. Even house-to-house variation in the modes is found, and that has been found to be correlated. Notice, I mean, at least 60 to 70%, whatever you encountered in the outset is also present in everyday's house. But this depends on the actual conditions of the housing. If you go to the Kacha house, if you go to a Jhuggi Jhopri area or low-lying areas, you'll find more modes. But if you go to the well-ventilated and concrete houses, very well maintained, you will find less fungi. This was our observation and correlated, and this information was published in Medical Mycology. So like pollen grains, fungal spores have also got the seasonality, like Aspergillus is more prevalent in the August, September, but Niger is more prevalent here, and then Alternaria is a thermophilic as of March. So seasonal variations are also for the individual fungus. While correlating the symptomatology of the patients after the skin test results, they are very useful before prescribing the allergen immunotherapy. Under selection of short with fungal allergens, these are the important allergens. I have counted out 8 to 10 types depending on the questions. Dust mite, there are several species, but most predominant trails as dermatobite, Tyronesinus, Ferni, and Blomia tropicalis. These 3 have been established to be important allergens for our country. I think Dr. Gautam Saha has done a lot of work on mites and published, and is from Calcutta actually. Impact of climate change, there's just one slide actually, impact of climate change alerts. I'm not going to produce the data actually here because very few or very scant information is available on the Indian allergens and the climate change, but whatever data globally indicate, the number of studies have revealed potential impact of climate change, that is global warming, on aeroallergens such as pollen and modes. And the rapid increase in the incidence of allergic diseases globally, including India, in the past few decades is partly attributed to the change in climate and enormous increase in carbon dioxide and atmospheric temperature besides the genetic predisposition. So friends, the global warming and more carbon dioxide makes allergy season worse by increased pollen productivity duration. We did some experimental studies in the laboratory conditions by challenging the pollen grains and fungal spores with the combination of the pollutants actually, like carbon dioxide, sulfur dioxide, nitrogen oxides, both individually, I mean, as well as in a group actually. And we found that they do impact the pollen grains morphologically as well as these clinical properties after the extracts after exposure were made, and they were tested and found by biochemical analysis, by protein profiling, they were definitely influenced by these parameters. So friends, the message, my final message is it is essential to have a knowledge of local allergens for appropriate selection of allergens for skin test and measurement of allergen specific IgE. The allergens vary from one part of the country to the others. Atlas and pollen calendars are very useful in selection of allergens and also for testing as well as for therapeutic management. The climate change actually also affects the aeroallergens with increased productivity, because when the production is increased, duration is increased, and that's how exposure loads to the patients is increased, and the more and more severe cases are likely to be there because of the climate change. So most of these aspects are covered actually from the Asia Pacific region in this book we published some time back, actually, Allergy and Allergen Immunotherapy. And this is available on the website. This also gives a lot of information, at least from the Asian region. Thank you very much for your patient hearing. I once again thank the chairperson and Sambhu and Dr. Mohatra for giving me this opportunity to be here and share some of the aerobiological perspectives in enhancing the efficient diagnosis and therapeutic management of the allergic disease. Thank you.
Thank you very much, sir. It is a really honor to hear from your end, sir. So you are one of the doyen in the field of allergology. We all know that, sir. So as we are running short of time, we will not receive now questions. Now we can, you may type in the chat box. We will try to address those issues later. So may I request for the next session, may I request Professor Vibhuti Shah, sir. So I am requesting our technical team to please share the screen with the slideshows of our respected faculties. Yeah. So we are really fortunate to have Professor Vibhuti Shah as our chairperson in this session. Professor Vibhuti Shah is professor and head of Department of Tropical Medicine of School of Tropical Medicine, Kolkata. So he is a well-known figure in the field of medicine, tropical medicine in this country. So along with him, also we are really fortunate. Next slide, please. We are really fortunate to have Professor Partho Sarkar, who is the professor of the Department of Medicine at Calcutta National Medical College and Hospital, who is also a very renowned figure in the field of immunology in this country. And he is also a postgraduate and undergraduate examiner in the multiple universities. So over to respected chairperson, sirs, to proceed for our next session.
Shambhu, am I audible?
Yes, audible.
Shambhu, can you?
Yes, sir. Yes, sir.
Okay. So it's our privilege to be with my co-chair, Professor Partho Sarkar, in this session. And we know that we have been hearing about complements since 19th century, since Jules Bordet described this. And the history of complements have gone a long way. So it's involved in so many infections, so many autoimmune disorders and whatnot. So it can be a friend as well as an enemy at times. So it's our privilege to hear from Dr. Soumya Nagarajan about this. So over to Dr. Soumya Nagarajan, please.
Thank you, sir. Thank you for a very kind introduction. And I think in the interest of time, I will begin my presentation, sir. At the outmost, I would like to thank the organizing committee, especially Dr. Moitra, to having given me an opportunity to be a part of this August forum and to be speaking the same forum as the galaxy of speakers before me. So we have been, so during our undergraduate days, when we heard about complement, it used to be so mind-boggling. Immune system, per se, we used to read a little bit in microbiology and just maybe just by heart it and just go along. But since my training in allergy and immunology, I have come to realize that there is a lot more to that. And it's quite fascinating because if we get the concept right, it's quite easy to understand. So complement system, before we go into this, Dr. Rohit did touch upon the immune system basics, but first few slides, I would just like to take first few slides to go on to the basics of immune system because complement forms a part of innate immune system. So one of my professors, Dr. P.K. Vedanthan, or my professor in Singapore, they used to approach this immune system. They used to say that it is a very similar to our armed forces who protect our borders so that we don't get any spies inside or we don't get any intruders. So it is similar to that with a central command with different sections of the armed forces with specific functions. So basically, even our immune system has different compartments or many subdivisions which have specific functions. Basically, they have, as a whole, they want to protect the host from the invading microorganisms, allergens, or sometimes against autoantibodies as such. So immunity, to put it very simply, it is resistance to disease and autoimmunity, as we have heard from the in the early session. Immune system comprises the constellation of various cells and tissues which come together with specific functions to give immunity to the host. So broadly, the immune system is subdivided into innate and acquired immune system. The innate immune system can be subdivided further into non-specific and specific. In acquired immune system, it is mainly active or passive in the form of humoral immunity or cellular immunity. So innate immunity is found in all living organisms, innate from birth. It forms a dominant part of the immune system. So it basically rushes the immune cells to the site of infection or inflammation. And definitely activation of the complement cascade is a innate inherent property of innate immunity. And basically innate immunity acts only against microbes, but not against other non-specific allergens or other antigens. So in innate immunity, along with complement system, other epithelial surfaces like the skin, mucosa of various other systems, cellular factors, complement system forms a major part of innate immunity. So the difference between innate and acquired immunity is very quickly, innate immunity is mainly, it forms as a part of the genetic makeup, whereas acquired immunity is acquired during life. Innate immunity forms an early defense response, whereas acquired is later response. This is very non-specific in innate immunity. However, in acquired immunity, it is highly specific, targeted. There is no memory. That is the beauty of acquired immune system, where memory cells are there. Upon re-exposure, these specific antibodies are produced, and this is not affected by prior contact or immunization and found in all forms of life. However, acquired immunity could be found only in vertebrates. Coming to the complement system. So complement system is quite mind-boggling at times. I have tried to make it simplify with some graphics as well. There are mainly three pathways. Before we used a traditional pathway, there were two pathways, the classical pathway and the alternate pathway. In the recent few decades, lectin pathway has also been well defined. So in the classic pathway is mainly antibody mediated specific immune response through which the complement cascade is activated. The alternate pathway is usually antibody independent, where neither the antibodies nor the T cells are involved. Lectin pathway is mainly by activation of mannose binding lectin, that is MBL. This is mainly, there are some mannose residue on some pathogenic surfaces. So upon activation of, exposure to these mannose, this mannose binding lectin, when it binds it, the complement cascade is activated. I will come to each pathway very briefly. So this is the traditional learning, where we see that classic pathway is mainly antibody, that is antibody antigen complexes, they are formed and they lead on to complement activation. Whereas the alternate pathway, it is mainly the pathogen surface, where it is antibody independent. This leads to a lot of, the activation of complement leads on to lot of specific targeted functions, like recruitment of inflammatory cells, opsonizations, or killing of various pathogens. So complement system, basically it forms a constellation of factors which usually occurs in normal serum. Upon which activation occurs, they mediate a lot of biologically significant consequences. I'll come to the functions later. It's very, very non-specific. It is non-specific because complement from one species can react with antibody of other species. And ordinarily, very commonly, it does not bind to the free antigen or antibody. Only when it is combined together, the antigen antibody complex, that's when it gets activated. Not all subclasses of immunoglobulins fix to the complement. Mainly it is the IgM. IgG also in that subclasses, probably IG3 and 1 could be more rather than the others. but never IG4, IgA, or IgE. There are different fractions of complements labeled from C1 to 9, mainly in the order in which they were discovered. So only in that way, in that order, it has been named. So the fraction of C1 basically occurs in serum as a calcium ion dependent complex. Then on interaction with EDTA, it divides into subclasses like C1Q or S. This is basically subdivided because few fractions come into role in the complement activation. So first I would be taking up the classical pathway. Here the portions of the FAB portions of the antibodies, mainly IgM, when it binds to the epitopes. Here, the C1Q complex, C1Q or S, come and bind to the FC portion of these antibodies to form, sorry, 1 second. So here they come and bind on the FAB portion of the So when the IgG or IgM come and bind on the antigen, the FAB portion, on the other end of this antibody, the C1Q, C1R, and C1S assemble to form collectively C1. This is the first enzyme of the classical complement pathway. This C1 would be able to cleave C4 further into C4A and other portions. So here the C1 convertase, this acts as C1 convertase, this cleaves C4 into C4A and B portions. Here the C4B is mainly important. This binds to the proteins and carbohydrates on the surface of the antigen. Then C2A comes and combines with the C4B. This forms C3 convertase. Don't get into too much mind-boggling. Mainly C1 activates C4. Then the subportion of C4B starts activating C2. This starts as C3 convertase, which is the main pathway which further divides C3 into further complement particles. So these C4-2B, which acts as C3 convertase, can subsequently cleave the C3 into C3A and B. So the C3B binds to the adjacent proteins, everything which can stimulate further on mast cells, everything. But mainly the C3B binds to the C4B2A to form C5 convertase, which has a further role in membrane attack complex. I hope I'm clear in this. So this membrane attack complex is the end point of this complement activation, where this gets embedded in the membranes of the infected human cells to which these antibodies have been bound, and further causes cascade of reactions which cause cells. This continues to activate further reactions such as mast cell degranulation, which releases histamine and causes other increases vascular permeability for in the pathology of inflammation and diapedesis. Also, it acts as a chemoattractant for phagocytes, which could be leading on to opsonization. So the main thing is C3 convertase and then C5 convertase, which forms C5A, which helps in membrane attack complex. So this forms the basis of the complement fixation test, which is quite commonly used in knowing whether certain antibodies are present in the serum of the patients. Mainly, it's a classical lab test whether certain antibodies are present in the patient sera or CSF during acute inflammation or during RH incompatibility. So basically, there are certain steps which is followed in the complement active fixation test, as we learned. Very briefly, the inactivated serum of the patient is taken, incubated, and then mixed with Wassermann antigen. If the complement is utilized, this was a classical example of the syphilitic antibody we had given. Not fixed, then it is not utilized. Here, it is incubated with sheep RBCs with hemolysin. If the serum has antibodies, there would be no lysis of RBCs. If the serum has no antibodies, then the lysis of RBC occurs. Quite simple to interpret. Coming to the lectin pathway. So here it is mainly mediated by the mannose binding lectin. This is a protein which is present in the surface of the mannose groups found in many microbial carbohydrates, but usually of microbes, but not in human serum. This is equivalent to the C1q, whatever activation happened in the classical complement pathway. So the activation of this pathway begins when this MBP binds to the mannose groups in the microbial carbohydrates of certain species. So basically, when this MBP binds on to the mannose groups of the carbohydrates, here the MASP, that is, there are certain proteins which come and bind to this MBP. This is equivalent to the C1 in the classical pathway. This leads on to an enzyme which can cleave C4. And further on, as we know, it comes C4, the C2 is activated to form C4b and C2a combination, which acts as the main director in this complement activation, that is C3 convertase. So I will be talking more about C3b in the alternative pathway. So alternative complement pathway is mainly mediated by C3b. So the classic pathway is mainly by C1 and its component forms C4, C4 and C2, which further activates, which forms C3 convertase. So alternate pathway is mainly mediated by the C3b. Lectin pathway is mainly by C4, C2 and mannose binding protein and associated proteins. So in alternate complement pathway, it is mainly, this is produced either by classical pathway or lectin. Sometimes C3 can also be caused by hydrolysis by simple water. It is antibody dependent, as I was telling earlier. It is mainly activated by the activating pathogen surfaces. So water can hydrolyze C3 and form hydrolyzed form of C3, which functions in a similar way as C3b we saw in the classical pathway. So mainly in conjunction with this hydrolyzed C3 and other various factors, the alternate complement pathway is activated. So when the surface comes in contact with these active antigen pathways, it comes in contact with C3b, which is hydrolyzed with various other factors. This forms C3b and factor B complex. So along with this, factor D comes along and forms a combination of C3b, factor B and B. So this combination works as in the similar way as C3 convertase we saw in the classical pathway. So this C3 convertase helps to form a combination of C3b, factor B, and small factor B, which forms a complex of C5 convertase, which is capable of converting various molecules of C5 into subportions of C5a and CB. And henceforth, it forms the membrane attack complex as highlighted earlier. So mainly, the functions of the immune system, complement system include in the inflammatory reactions control and chemotaxis, clearance of various immune complexes, antimicrobial defense, contributes to the pathogenesis of various diseases such as hereditary angioneurotic edema, nephrotoxic nephritis, paroxysmal nocturnal hemoglobinuria, infectious mononucleosis, autoimmune hemolytic anemia, to name a few. Mainly, as we have seen, complement mediates various immunological membrane damage, involves in the pathogenesis of type 2 and type 3 hypersensitivity reaction, has a wide antiviral activity, promotes phagocytosis. It also interacts with the coagulation, fibrinolytic, and kininogenous systems of the blood. So mainly, RBCs which are bound to the cell surface can also activate the complement system, both classic and alternate, and can cause cell lysis, as we see in various EBO incompatibility reactions. It has a very critical role in inflammation, defense against some bacterial infections. Not to mention, also has lot of damaging immune responses in the pathogenesis of various autoimmune diseases as well. So a few of the slide credits were from Dr. PKV, and definitely graphics is where I worked in National University Hospital Department of Immunology. They have a very good immunology lab. So with their courtesy, I shared this, probably trying to make it a little more simpler to use, to understand. Thank you. Thank you for a very patient hearing.
Thank you, Dr. Shoma Nagarajan, for your very brief, comprehensive, and very simplistic way of describing this complement system and their functions. Basically, what I understand, all the three pathways, they different ways they produce the C3 convertase.
Yes, sir.
Then they continue parallelly and produce C5 convertase. And
Yes,
then simultaneously they produce MAC.
Yes,
From
sir.
C5 convertase to MAC, almost the pathway is same. The
Yes,
final
sir.
common pathway is MAC, and then they are embedded in the membrane. So there is some pores, and then there is lysis. That is
Yes,
the
sir.
main thing.
Yes.
I, being a clinician, I am interested their implications in certain autoimmune diseases and other hemolytic diseases. So I would like to ask you two things. That is, one is hemolytic uremic syndrome or paroxysmal nocturnal hemoglobinuria. In these two diseases, the role of complements are very much there.
Yes, sir.
Would you please elucidate on that a few things?
Sir, basically, in paroxysmal nocturnal hemoglobinuria, it is a combination of type 2 and type 3, sir. So, mainly, I think it would be involving a combination of both classical and alternate pathway to a certain extent, because there is antibodies produced against those particular erythrocytes. So as I was highlighting, RBCs, when they have an antibody attached to them on the cell surface per se, that is capable enough to activate this classical as well as alternative complement pathways, which lead on to this lysis of those affected erythrocytes which have antibodies attached to them. So that's which releases the chemical mediators causing the respective clinical symptoms.
Okay, thank you. Any Dr. Vibhutisha, do you have any questions, sir?
I just have one small question, again from a from the perspective of a clinician, we do sometimes get patients with severe bacterial infections, so who have been suffering from childhood recurrent bacterial infections. So what is the role of diagnostic approach by complements? Do you have any idea?
Sir, definitely in patients who are more prone for infections like unusual infections, in the follow-up of primary immunodeficiency, even complement deficiency of certain factors definitely does predispose them to those immunodeficiency. So we have certain screening tests, sir, when if those like unusual bacterial infections or severe infections which require longer antibiotics, or unusual site infections, or requiring longer treatment process or failure to thrive, in those patients, definitely we should be keeping even complement deficiency as one of the factors which could be predisposing them to certain unusual infections, sir. So definitely point well raised, sir.
Thank you. I think I don't have any more questions. So, Professor Sarkar, would you please conclude?
Okay, thanks a lot for this crispy and comprehensive talk. We are very much benefited as we are lagging behind our time schedule.
Yes, sir.
So let us move to the next session. Over to Shambho for the next session. Thank you. Thanks to the organizer for asking us to chair.
Thank you.
Over to Shambho.
Thank you very much, sir, for this wonderful session. And I must thankful to Madam Dr. Soumya Nagarajan for giving his time and for this wonderful deliberation. And I think we have to move to our next session now. And for that, we are really fortunate to have Professor of Professors, Dr. Sukumar Mukherjee, sir, as a chairperson to this event. So may I request, sir, to please come up and please open your video, sir. And we are there is some problem from the side of Professor Raj Kumar. There is some emergency from his side, and we are really fortunate that the adjunct professor of allergology at Apollo Hospital, Dr. Shoibal Moitro, who is also the scientific chairperson of this ALLERCON 2021, had agreed to take this topic, this important topic on patient history and allergen selection. So Dr. Shoibal Moitro will speak on this topic. Dr. Shoibal Moitro had done his MD in pulmonary medicine, then PhD in allergology from Kolkata University, then MAMS, DAA, FCCP. So we are really fortunate that Dr. Shoibal Moitro had agreed. So may I request Sukumar Mukherjee, sir, to say a couple of words, then we can start with our talk.
Good afternoon.
Good afternoon, sir. We can hear you, sir.
You are not audible? Are you audible?
Yes, sir.
Yes, sir, you are audible.
Sure. Good afternoon, everybody. I'm extremely thankful to the ALLERCON 21 for inviting me to chair a very important session of clinical therapy. Now, I think as we understand, allergen immunotherapy is almost very important part for the clinician, but it has got a very selective indications, though it is a age-old practice for the since last 2011. So obviously, 1911. Now, allergen immunotherapy, as we understand, it is the very important step of injectables or sublingual method of inducing antigen in a very selective form to develop tolerance triggered by T cells, T regulatory cells. And obviously we have got some indications in the particularly in the aeroallergic conditions, particularly respiratory allergy and some dust allergy and possibly food allergy. However, we are very much familiar with the respiratory allergy, either in the form of seasonal rhinitis or perennial rhinitis and asthma. But that is the topic which I am interested. But the important point is that how to select candidates who will benefit. Is it all cases of seasonal allergy, or all cases show us how best land up with a conflict between the clinician practicing with the steroids and anti-allergic versus immunotherapy. Over to Dr. Shoibal Moitro.
Thank you, respected chairperson, and I thank all the delegates in this 10th National Conference on Allergy. As Professor Mukherjee has very clearly stated,
Dr. Shoibal Moitro.
Yes, means am I audible?
Yes, now we are not getting any slides.
I have shared.
Yes, sir, it's visible, sir.
We can see the slides, sir.
Can you see the slides now? Okay, so shall I continue?
Yes,
okay.
Please.
Okay. So, thank you, sir. As Professor Mukherjee has very clearly stated, that allergen immunotherapy is a modality of the treatment of the allergic patients of various allergic diseases like the nasobronchial allergy, the atopic dermatitis, insect allergies and venom allergies, along with the pharmacotherapy and the allergen avoidance. So these three arms of treatment forms the crux of treating any allergic diseases. But the important is to have a successful allergen immunotherapy protocol or a program. One needs to pay a very important attention in selecting the patients, number one, who will benefit from the allergen immunotherapy, and number two, in selecting the allergens. We have heard the talk by the famous aerobiologist of our country, Dr. A.B. Singh, who has in some way and in some slides, he has stated that how do we go about in selecting the specific allergens for the immunotherapy. I would be stressing more on the patient selection and also somewhat on the allergen selection so that we understand that who are the patients who will benefit from this treatment and don't unnecessarily give this treatment as a blanket therapy to each and every allergic patients, which will bring a bad name to this very age-old, time-tested and well-evidenced modality of the treatment. So this is very important. At the outset, we need to understand whom should we give this treatment. So my talk is on patient history and allergen selection, which are the important steps in the allergy management. First of all, we always start in clerking of the patient with the patient details. Name, age, the gender, the occupation, all are very, very important. Actually, the work of an allergist is to function as a detective because actually these are the environmental triggers which is causing the particular symptom, or it is causing the persistence of a particular symptom in a particular patient. So we need to identify what are these environmental triggers which is there in the patient's environment which is causing these issues. So for that, and how the patient is responding, it's a host response and the environmental response. So we start with the patient demographics and the occupation. Now, there's a very interesting concept in allergy, what we know as the allergic march or an atopic march. It says that the allergic diseases, it starts with some form, then it marches ahead with the other form over a period of time. So usually we say that the early elements of the allergic march or the atopic march are the food allergy or the atopic dermatitis, and the later elements are the allergic rhinitis and the asthma. So naturally, if an allergic disease starts early in the life, that means the children would be having more of the atopic dermatitis or the atopic eczema. And as we go ahead and as progress with the age, then more of the allergic rhinitis and the rhinoconjunctivitis or asthma that comes. So this is what is shown in this graph, but it is not always so. There can be mixing of the involvement of organs, and there can be some other relationships, starting with initially the allergic rhinitis going into the food allergies and atopic dermatitis. All depends upon the homing of the allergic cells at a particular time in a particular organ, depending upon the natural route of the entry of the allergen in the particular patient. But by and large, it usually starts with an atopic eczema or atopic dermatitis, food allergies, and then it proceeds towards the nasobronchial allergies. So age is very important to understand what is the age of onset of the disease. Not necessarily this allergic rhinitis, but any other allergic diseases which has involved any other organ system. So the key word is the sensitizations, which is according to age. So food sensitization reduces with the increasing age, and allergy sensitizations increase with the increasing age. You have seen that we all have seen whenever an individual is advised in allergy test, either in the skin prick test form or the immunocap form, they will come and they will see that there's multiple food items, then the pollens to which they're showing the positive. Now, what does this positive mean? It is wrongly interpreted as the allergy. This is not an allergy. That is, the report merely shows the sensitization. Sensitization is an immunological phenomenon which shows that there is a presence of the mast cell bound the IgE to that particular allergen, which is detected by the skin prick test, or there are the IgE in the circulation, that is a free IgE to that particular allergen. Can somebody please mute the other? Hello, Shambho, can you please mute the other?
Yes, sir.
Thank you. Okay, and or there is free IgE which is present in the circulation, which is detected by the in vitro test, which could be immunocap or an ELISA. So when this report comes, one needs to sit with the patient and the report and again go back to the patient's history and correlate it whether these allergens are there in the patient's environment, number one, or there in the patient food habits, and number two, whether the symptoms are triggered by this is allergens. Only when there is a positive correlation between the allergen sensitization and the symptom, then we call it as a clinical allergy. Otherwise, these are not allergy reports. These are basically the sensitization reports. So sensitization, without sensitization, the allergic manifestation does not occur. So sensitization has to occur for an allergic manifestation. Otherwise, it is not true. That is, some can have the sensitization, but not the allergic manifestation to that agent. So that has to be kept in mind. Then we definitely come to the current history with which the patient actually comes and sees us. It could be the patient has come to see us with a nasal problem like an allergic rhinitis or a rhinoconjunctivitis, or with a lung problem like an allergic asthma, with or without associated allergic rhinitis or rhinosinusitis, or the patient has come with some food allergies. A word of caution, true food allergy is quite low in our country, less than 2%, but most of the people will come and say that we have allergy to this food and that thing. We need to evaluate and properly test the patient, then do the correlation and do some challenge tests to come to diagnose the true food allergy in a particular patient. And then we have this atopic dermatitis with which the patient can come. Why it is important, because the manifestation or the clinical signs or symptoms with which the patient presents to us, it determines actually to what are the allergens which can be causing that particular illness or the disease at that particular time. Then we go about selecting the allergens for the testing. Then we have to know whether these are the perennial symptoms in cases of the nasobronchial allergies, or we have the seasonal symptoms. Seasonality of the symptoms is very important for us to know, because that will then throw some light on these are the symptoms that are triggered by some seasonal allergens, mostly the pollens, the pollen grains, or some fungal spores, which actually are liberated into the air in a particular season. So if we can find out that these are the patient gives a clear history, or we need to probe into that, we need to ask the patient, and then if the patient, if we can find the seasonality to the symptoms or symptom aggravation in a particular patient. Then we think in a particular season, in a particular place, what are the allergens which is available, and then we test the patient with that particular allergen to know whether the seasonal pollen is causing the symptoms or not. If the patient has a perennial symptom, then these are the perennial allergens. We have several perennial allergens which can cause symptoms throughout the year, irrespective of any season. So like the dust mites, it can have the perennial allergens with some seasonal exacerbations. Pollens are always seasonal. Cockroach allergen are the indoor common allergen, which is a perennial allergen. Moles, outdoor moles are mostly seasonal. Indoor moles can be perennial. So that's why it's very important to have or probe into the patient's environmental history, patient's house, that how are they, what are number of rooms, whether adequate sunlight is there, whether there is moles growth in the bathroom, toilets, kitchens, and all. These are all very important points which we need to very meticulously sit and we unearth to actually come down to the probable cause of the symptoms in the particular patients. And pets, definitely these are the perennial allergens, but the exposure at times may be intermittent, and because maybe somebody is visiting some other houses where there are pets and gets the symptoms after returning back. So for this, definitely we need to resort to the pollen calendars. And I must say this pollen calendar is a very important tool which we should have on our desk while we are evaluating a patient of a nasobronchial allergy. Because then at that particular season, in a particular place, we'll know what are the pollens and in which month's concentration is the highest, and whether the patient is giving this kind of symptoms in that particular month, and then we actually test the patients for that. Very commonly, we have seen that in the patients who are coming from the Shantiniketan, Bolpur, it is the place in the Birbhum district of Kolkata, and you know that it is famous for a Nobel laureate, which we all know, whom we all actually, he is a father figure for all of us, as Rabindranath Tagore. So in his university, the Central University is over there, there's lots of trees of the Alstonia scholaris, which we call in Bengali chatim, also the Indian devil tree. Now, the chatim, it produces the flowers in the month of usually September, October, and November. So we have been seeing patients who are coming from the Bolpur and surrounding regions. They usually give history of the symptoms aggravating in these months. And when we tested the patients for Alstonia scholaris, we found them positive to that, and which could be correlated to their history. Nowadays, we have this chatim tree that is grown in Kolkata also. In many places, they are grown. And these flowers are always in the month of November. This is just an example I'm giving. So this is how you correlate with the pollen calendars and with that particular place from where the patient is coming. It's very important to understand these pollen calendars actually differ from state to state, from region to region, and it needs to be updated. And this is actually very important to understand that updation of the pollen calendars in various areas, it helps in understanding the change in the pollination pattern of the pollens in a particular area. The All India Coordinated Project in the aerobiology, which was done quite long back, it is 2000, now it's 2021. Though we still, though it has been 20 years has passed since then, but still when we have to resort to any document, document which is from the government, we need to resort to that. But it has changed, it has got edited, and I think Dr. A.B. Singh's slide, we have got to know some various other changes in the pollen calendars which have come up in the various areas. So these are the pollen calendars of the moles that you can find the Aspergillus, Alternaria, Cladosporium. These are all having the peak A concentration in Aspergillus mostly in the rainy months, and Alternaria is also in the summer months, the Cladosporium in the winter days. So this helps in understanding if we are dealing with or thinking of a mold allergy, and specifically in the patients who have the outdoor mold allergies. So then we need to know very importantly how long they have the history. Why? Because if the history has been pretty long and it has been affecting the patient's life, that's a quality of life. So initially, along with the allergen avoidance, we might need to start all the three ways of treating the patient. That means pharmacotherapy, allergen immunotherapy, if the patient is the right candidate, and the allergen avoidance. So otherwise what we do is that we perform the allergen avoidance for the majority of the allergens. If possible, then see patients the response along with avoidance and the pharmacotherapy. If not responding well, or patient is not be able to be taken off the inhalers, patient having lots of exacerbations, quality of life is poor, then we embark on the immunotherapy after evaluating if the candidate is right for the immunotherapy. Otherwise, if the patient's symptoms quite distressing, then we may think of immunotherapy. If we have the guidelines of which patient can put on the immunotherapy, then we can put the patient on the immunotherapy. So always categorize the patient, allergic rhinitis or allergic asthma. These are the patients which helps us to initiate appropriate pharmacotherapy for the patient. And along with that, we see what is location of the symptoms, whether in the workplace or in the schools or in the home, and which is the time. Very importantly, in the morning, evening, or afternoon. We know that mostly the pollen allergies or the pollen concentration is highest in the air in the morning times. So definitely, if the patient is going outdoors having majority of the symptoms at that time in a particular season, we can think of the pollen allergies. But if the patient is having the symptoms indoors, like with dust allergies, also patients usually have the symptoms indoors, but also in the morning time. Usually we can think that it could be dust. Dust allergy patients also get symptoms at the night time while they're going to bed. So if a patient is having all these symptoms are mostly seen in the indoor perennial allergens like the cockroach allergens or the pet allergens, where dog danders or the cat danders, they can have throughout the day, they can have the symptoms. So these are the points which we need to understand to embark on or to come down or to a particular allergen. So again, the same thing, that which are the allergens at what time. It will again we resort back to that to understand the triggering factors. Then we see precipitating factors in the patient's history, like when was the thing started? Well, the patient was walking in the garden, or patient was doing some gardening, or like patient went into a dusty environment or with physical exertion, or when the patient got exposed to the pets or in the damp areas, or maybe eating some particular food items within 1 or 2 hours of that patient manifested with that particular symptoms. So these are we need to know if we have to really identify the triggering factors. So this helps in identifying the source of the allergen exposure. What is the source? Because we advise the patient if we can find the source. For the source avoidance is an important step along with the pharmacotherapy and immunotherapy, which can be initiated. That's a very cost-effective method. If the source can be avoided by the patient, then we advise the patient accordingly. And also the irritants. There can be irritants which may not be allergy, but it could be irritants like the dust and smoke. That is the vehicular pollutants, the irritants. Patient might be having again the nasal symptoms. Patient might be having runny nose. Patient might be having itching of eyes when exposed to the vehicular pollutants. But these are not allergy, but these are basically the irritant because of the various particulate matters and diesel exhaust particles, then various oxides of various nitrogen, sulfur, and all in the atmosphere, and because of the vehicular pollution. So therefore, this helps in delineating whether it is actually allergy or whether it is an irritant and nature of the patient's symptoms. Past history, obviously we have to know, because if the patient had had an anaphylactic reaction, very important to understand that this patient are a risk of developing serious reactions to the immunotherapy injections. Because then we think that if we have to give the immunotherapy to this patient, usually it has to be a totally supervised. We may think of giving a slit, but usually for the anaphylactic, who had anaphylactic reactions, we may not embark on immunotherapy. We'll rather be safely continuing with the pharmacotherapy and the avoidance. Only thing is that in case of the venom allergies, is if the patient cannot avoid that insect bite, we give the patient and the immunotherapy, and that immunotherapy might have to be taken lifelong if there is the anaphylactic reactions or underlying some mast cell disorders like the systemic mastocytosis. So, and having received the allergy immunotherapy before or some allergy vaccines before help us in understanding that whether this patient is going to be benefited again with allergen immunotherapy. Usually 3 to 5 years course is what is needed in conventional subcutaneous immunotherapy. But these patients, if they had it before and it stopped in between, that means patient compliance has to be ensured while before putting the patient in immunotherapy, because the patient might not be able to continue it for such a long time. So this is very important to understand. There is no use in starting a therapy if the patient is not able to continue it. So we need to actually counsel the patient, understand the patient's habit before, and then we need to decide about this modality of the treatment. As I was talking about the atopic march, the same thing is which is shown here, that is in the early phase, it is the food allergies and the atopic eczema or dermatitis, which then later on gives to atopic allergic rhinitis and the allergic asthma. Family history is very interesting for us to understand, because this is what we follow as a ballpark measure. If there is no close relative with a history of allergy, incidence is around 12%. If one parent suffers from the allergies, the incidence rises to the 30 to 50%. And if both the patients have the allergies and of the same type of allergy, the chance of having allergic disease in the child is 50 to 80%. So allergy is a genetically predisposed disease. So definitely if both the parents are having allergic disease, we need to understand that the child have an increased chance of developing an allergic disease. And that in this is children, if we initiate immunotherapy early, because allergen immunotherapy is only the disease modifying treatment which can actually change the course of an allergic disease in a particular patient. So this has to be understood. Medication history, obviously the antihistamines, corticosteroids and beta-2 agonists has to be taken. And because these patients, we need to know that whether they are on these medicines or not. And because some of the medicines increase the chances of the anaphylactic reactions or mask the initial symptoms of the anaphylactic reactions, which needs to be stopped. The current medications and appropriateness of the medications we need to know, and therefore this can help in up titration and down titration of the medicines, addition of some other drugs. And if we are planning to do a skin prick test, we have to take a detailed medicine history, because we need to stop the antihistamines and some other drugs for a certain period of time before we embark on a skin prick testing in a particular patient for the evaluation of their allergenic sensitizations. So this was an article which was, we showed that allergic respiratory diseases, different allergens have different symptoms. So the seasonal allergic rhinitis is like it was with seasonal allergens, perennial allergens were associated with the asthma. We showed that mostly the perennial allergens, they have the asthma. And therefore, when you're treating a patient with the asthma, definitely we need to focus more on perennial allergens like the house dust mite and the cockroach or the perennial moles and things like that. So based on the history and the environment, then we come to the next step, that is the allergen selection, which is very important. How to select? First of all, we need to know what are the diseases and what is the seasonality of the symptoms. And then we should see in the Indian prevalence of allergens, which is cumulative data from the multiple Indian literature has seen the majority is for the house dust mite, around 50%, and pollen constitutes around 20 to 25%. Moles around 7 to 10%, insects 10 to 20%, animal DNA around 10%. So we can see that when we are evaluating a patient from our country, our main focus is on the house dust mite and the pollens. And moles, or definitely some, but definitely main majority is on the house dust mite and the pollens. House dust mite, we have this Dermatophagos sternonicinus, Ferini, and the Blomia tropicalis, these are the main three allergenic mites. Apart from that, there are some storage mites also, but main three house dust mite are these three, which has to be included while we are testing a patient for house dust mite allergies. This was an evaluation of sensitivity towards storage mites and house dust mites among nasobronchial allergic patients from the Kolkata, which was published from our group in 2018. It shows that the house dust mite sensitizations is pretty high, to 87.87% for the Dermatophagos ferini, and Pteronicinus is 81.2. At most, more than 80% is because of these two mites. So even if we are testing for these two mites, we'll be able to detect more than 80% of the house dust mite sensitizations in our population. And it was from the different cities, as the Srinagar, Bangalore, and the Chennai, they also have shown that highest sensitization is with this Dermatophagus ferini and the Pteronosinus, which are the predominant house dust mite prevalent in our country. Apart from that, we have these pollens, which are grass, weed, and tree. This depends upon what is the seasonality of the pollinations and from which area. We have to remember the cross-reactivity of the various pollens and also the local pollens, that is the Himalayan pollens, as Dr. Singh has just told us. Grass pollens are many, but mostly the grass pollens has only some standardized actually extracts are available for the testing. Otherwise, we can resort to the mixed allergens group, which is there for testing the grass pollen only in selected patients who show a seasonal allergic rhinitis, basically, which are thought to be because of the grass pollen. Weed pollens are standardized are available for some of the allergens, but majority we do not have. We can have a skin prick testing with that, but definitely we have to take the report in caution because we need to know the allergen extract may not be standardized. Non-availability of standardized allergenic extract is a important gaps in the treatment of the allergic patient in our country, and which definitely needs to be overcome in the future to have a better patient and treatment outcome for our patients. Tree pollens also the same thing. And when we have to select a short relevant aeroallergen panel, we need to know for the moles. These are the majority of the moles: Alternator, Aspergillus fumigatus, Penicillium, Cladosporium. If we include these four, this is going to constitute the majority of the mole spores which grows in our country. Insects, obviously, we have the American and the German cockroach. Both cockroach is a very important allergen, perennial allergen, and cockroach allergies tend to persist throughout life and cause the asthma to remain uncontrolled and causes the progression of the asthma. So definitely we need to identify, we need to have a source control and to reduce the exposure to the cockroach allergens. Then some other Aedes and the moth, this is still being reported in some. Animal epithelia, obviously cat, dogs, cows, horse are there, but it's only very selected household where these pets are there. These are the common foods which causes the allergy. These 9 foods are main important: eggs, cow milk, peanuts, sesame, fish, seafood, tree nuts, soya, and wheat. They actually causes the 90% of the food allergic reactions globally. And that holds true for our country also. So if you included only these 9 in the testing, that suffices the majority of the food allergens until and unless the patient gives a history of having an allergic reaction to some specific food items. This mainly constitutes the majority of the allergens which is needed for testing the food allergy in a particular patient. So this is very important to understand that from the Indian diet, we need to have these food items and we need to specifically ask questions to the patient, because as I have said before, food allergy is still very, very low in our country. We don't know why it is still low, maybe because of our traditional diet, which is actually helping us in keeping this figure low. Maybe with the change in the lifestyle pattern in the dietary habits, so in the days to come, it might increase as it is there in the other countries like in the Singapore or maybe in the Europe and the US. But we should understand the factors which is causing a low food allergy in our country. And we should actually try to consolidate those factors so that there is no increase in the food allergies in the times to come. So these are and rice is also an important food allergen for India, because this we have to give reports of the rice allergies. But these are things which we usually test. And if there is a specific history, they can only go for the testing. So at the end, I would like to say again, it is very important to understand that the allergy is a disease which is caused by interaction of the environment and the patient. So to have a very successful treatment plan, we need to select the patient who will benefit from the immunotherapy, select the allergens, counsel the patient for the patient compliance, see the disease condition. So along with the pharmacotherapy and allergen avoidance, as adjunct therapy, immunotherapy can be given to selected patients to have the best outcome from this treatment modality. Thank you.
Thank you, Dr. Moitro, for your excellent delivery. I have got few points to raise for the clarifications of the audience. As my clinical experience in practice, what I have got, immunotherapy in allergic rhinitis and asthma is an important issue, and how to select the candidates, that is a very pressing issue. As I understand, this is of no use in acute setting. Particularly in the acute phase of the illness, we cannot go for immunotherapy. Second point, it is possibly more useful or relatively useful in children than in elderly people. And number three, I have seen dropout of the cases once the people start immunotherapy for a pretty long time of 3 to 5 years. The patient cannot keep the patients. So obviously, these are all my clinical observation, which you may agree to that.
Yes.
Second point is that the more often the cases which fail to respond to standard therapy or showing side effects of the drugs, then in that case, you can put the patient on immunotherapy and look at for the risks or adverse effects which can appear during the course of the treatment, and that may be one of the reasons for the patient to drop out. And for economic reasons also, particularly the cost of the treatment, so for 3 to 5 years, with a weekly injection, then fortnightly injection, then monthly injection, the patient may not like it. So patient choice is also important for selecting a candidate. I think we should also have a discussion, counseling. They opt in for the allergy and immunotherapy or go for the standard pharmacological therapy. And lastly, that it is not always accessible and affordable. This is what we find. Every part of the India do not have this kind of allergy and immunotherapy as a traditional practice, in contrast to curative symptomatic relief of the patient, where the patient is very satisfied. And these are my observations from the clinical practice, utility of immunotherapy. Not many experts are there, and we are all dependent on the skin prick test. So obviously these have got a limitation in our immunotherapy. That's why most of the clinicians have got the experience of some of the side effects which may not be liked by the patient themselves. Now I need your comment on this direction.
Yes. Thank you, Professor Mukherjee. As you rightly said, immunotherapy is basically a niche area. And number one, as you have said, this is not a treatment for the acute conditions. This is a long-term treatment for the control of the disease. So of this, the most important is the counseling of the patient. Apart from the patient selection and the allergen selection, next most important part is the counseling of the patient. Patient has to understand very well that it is a long-term treatment. Nowadays, we are having the options of the sublingual immunotherapy in the form of tablets or the sublingual drops, but the treatment goes on for 3 years, maybe up to 5 years. So this is very important to know the economics, the price involved, and the time duration involved, and what are the side effects which can occur, and how do we handle those side effects. Only if the patient is adequately counseled and before starting immunotherapy, the patient is going to comply with that. Otherwise, patient is going to drop out of that. Once the patient becomes fine with the pharmacotherapy, they are not going to continue with the immunotherapy. So this is one of the factors which is very important for everyone to understand. First of all, to identify the patient, and next is to identify the allergen, counsel the patient, select the right patient, the right candidate, the right allergen, and then only after proper counseling, we start the treatment to have the effect in the particular individual. It definitely has as a very important role to play, because it has known to cause the change in the biology of the allergic diseases, because it is only the biological treatment which can be given to actually change the way that particularly allergic asthma or allergic rhinitis behaves, change the body's immune reactivity to the allergens, develop an immunological tolerance which cannot be brought out by the use of the medications. But these are the limitations which we have to keep in our mind while we are embarking on this kind of specialized treatment for any patient.
Thank you. Over to Dr. Arijit Das. Is Dr. Das is there?
Sir, there is some technical issue from Dr. Arijit Dash's end. So may I request organizer to go forward with the next
Thank you.
symposium. And
Thank you.
On behalf of Team ALLERCON, we are extremely thankful to Professor Suman Mukherjee sir. That it is a real honor for us to have you in our national conference. And also we are thankful to Dr. Shoibal Moitro for giving his time to this very important topic. So may I request our organizers to please move forward with the symposium. So there is one announcement. The Dr. Shoilendra Handu will be present tomorrow in one session. So on behalf of Dr. Shoilendra Handu, we are extremely fortunate to have Professor Shantanu Kumar Tripathi sir, who is a renowned face in the field of clinical pharmacology and medicine in the country. And he is also the president of Allergy Asthma Research Center. So may I request Professor Shantanu Kumar Tripathi sir to chair the session, and along with that, please show the slide of Dr. Sunita Shukla. We are really honored to have Dr. Sunita Shukla also as a co-chairperson. So who has done her MS in ENT, then DNP, then FCPS, DORL gold medalist, and also she had done DAA, and she was awarded with gold medal there also. So she is the founder director of Mumbai Allergy Center and honorary consultant allergist at KEM Hospital and Global Hospital. So we are really fortunate to have Madam also. So now the session to over to our respected chairpersons.
Good afternoon, everybody.
Good afternoon, sir. Good afternoon, everyone.
Thank you, Dr. Shambhu, for welcoming us into this session. And I'm happy to have Dr. Sunita as the co-chairperson. And this session is about drug allergy and clinical pharmacological approaches to management of drug allergy. And we have 4 speakers here. And we are lagging behind time. So I would request the speakers if they could manage to make it brief compared to whatever time was allotted earlier.
Sorry for the
please consider if you can make it brief.
Sir,
And
sir, there is
before the first speaker can come in, I request Dr. Sunita to have a couple of words. I think Dr. Shambhu has something to share. Please go ahead, Dr. Shambhu.
Yeah, so actually due to the time constraint, we have shifted Dr. Shaugato Sarkar's topic in the hall B, that is Dr. N.C. Dash hall, and there will be 3 talk in this symposium.
So what is the time? How much time you are giving?
20 minutes each.
20 minutes each. So it's an 1-hour session then.
Yes.
And if it is 20 minutes is assigned, I would request the speakers to limit themselves to 18 minutes so that there is some time left for little comments from the chairs and maybe taking a couple of questions. So with this, I hand over to Dr. Sunita to take over, please. Over.
Yeah, thank you, sir. Good afternoon, everyone, and welcome to this academic feast organized by Allergy and Asthma Research Center of Kolkata. Without wasting any time, let us directly go into the most difficult part of any allergy, which is drug allergy. Right from history taking, diagnosis, the temporal relation, and then the management. It's a Pandora box. So let us start with our first lecture by Dr. Sumalya Sen, and he will be talking on diagnosis of drug allergy. Over to you, sir, Dr. Sen.
Thank you, dear organizers, especially Dr. Shambhu, for giving us the opportunity to present this topic in front of these delegates. Today, the topic that we are going to discuss is diagnosis of drug allergy, a clinico-pharmacological approach. Regarding drug allergy, it is a known fact that it is an immunologically mediated response to a pharmaceutical and or formulation that may contain excipient also in a sensitized person. And any kind of medication prescription drugs, over-the-counter drugs, household remedies, including herbal products, is capable of inducing drug allergy in susceptible individuals. Now, the question comes that is it a type ADR? If yes, then which type of ADR it comes? All those we will discuss in subsequent slides. Regarding ADR, that is also discussed earlier in this conference, that this is a response to a drug which is noxious and unintended and which occurs at doses normally used in man for the prophylaxis, diagnosis, or therapy of disease or the modification of physiological function. And ADR can be broadly categorized into predictable type or type A and unpredictable or type B. Now, when it comes to the diagnosis of drug allergy, that rests heavily on eliciting the history, and we have to ask the some right questions like what are the issues, give all the details like onset, duration, severity, response to any measure or treatment, and truly speaking, all those small points actually are building up the diagnosis for you. What new drug have been taken? When did you take it? Have you stopped taking the new drug? Next is what OTC medicine or prescription or drug or herbal medicine are you taking? At what time of the day do you take your other medications or supplements? Did you increase the dose of any regular medicine in this time period? Have you stopped taking any regular medicines? Did you take anything to treat your symptoms, and what was that effect? Have you had a drug reaction in the past? If so, what drug it was? And the last thing that is, do you have hay fever, food allergy, or other allergies in the past? Is there a history of drug allergy in your family? So all those questions are directing you towards a diagnosis, and that's why these questions were framed, and it was published in a very well-known journal of World Allergy Organization in 2018. Broad classification, if you see that we were discussing, that ADR can be categorized into two types, that is predictable type A and another is unpredictable or type B. Now, under predictable, we know that this is a dose dependent and also it is related to the known pharmacological action of the drug, and it occurs in healthy individuals. Unpredictable reaction, that is dose independent and it is unrelated to the pharmacological action, and it occurs only in susceptible individuals. Now, under this unpredictable reaction, the drug intolerance, drug idiosyncrasy, drug allergy or pseudo-allergic reactions comes. We will again discuss these things subsequently. Gels-Coombs classification. From our MBBS days, we have come across this classification of Gels-Coombs, and it is type 1, 2, 3, or 4, and they have different types of mediators in these different types of classification. IgE mediated or cytotoxic or immune complex mediated or cellular mediated. Under the cellular mediated, again, it can be classified into 4A, 4B, 4C, or 4D. This sub-classification was made later on, and again, these are due to certain specific agents like monocytes or eosinophil or CD4, T cells or neutrophils. Now, when drug comes as an etiology, then we have to capture lots of things. First of all, what we were discussing, that history taking is very important, and the detailed medication history we have to take from the patient as well as from the patient family members. Next is the clinical methods. Next, laboratory tests. Next, under the laboratory test, routine blood test. Apart from that, other tests like patch testing, LTT, tryptase test, HLA phenotyping, all those comes. Next, pharmacogenomics in certain susceptible individuals, that comes into focus. Therapeutic drug monitoring, autonomic neuropathy screening, indirect PKPD modeling, CGM, ABPM, Orfino, ECG, ECO, DLCO, PFT, all these are the battery of tests, but it is not like that all patients need all tests. It is patient centric, and ultimately the requirement of the test will be taken by the clinician who is treating the patient, and everything will depend on the patient history, patient clinical features, and how they are presenting with the symptoms. Now, if we look into certain syndromes which are due to drug allergic reactions, we can look into this table that some are IgE mediated, some are cytotoxic, some are immune complex mediated, delayed type of hypersensitivity. They have certain specific clinical manifestations, and again there is some common causative agents which causes this type of syndromes. So these are just for a few examples. Similarly, another very important initiative that has been taken by Government of India is the pharmacovigilance program. Pharmacovigilance program actually captures these different kinds of drug allergy or drug related issues, and IPC is taking care of that. That is Indian Pharmacopoeia Commission. Here just few examples has been put that whenever these signals, these are known as signals, any kind of adverse effect or anything that has been captured from a patient end or has been reported by the clinician, and those are published in the journals also in a regular manner. Similarly, what we can see that suspected drug doxorubicin, the adverse reaction photosensitivity was noted and it was published. Next, febuxostat, allergic vasculitis, and so on. At the end also we can see that amoxicillin with eye irritation, all those safety alerts has been published by the IPC. These are few amongst those. There is a long list, and that list is also dynamic, that is changing, and they are adding up. Now, the differences between allergy and pseudo-allergy. What is allergy and what is pseudo-allergy? The main difference between allergic reaction and the pseudo-allergic reaction is the mediators. Allergic reaction is mediated by the IgE, but pseudo-allergic reactions is mediated by IgG, IgM, or others. And clinical manifestations are almost similar. The diagnosis mainly depend on the clinical manifestation with elevated specific serum IgE to allergens for allergic reactions, but the for pseudo-allergic reactions, the clinical manifestation without elevated specific serum IgE to the allergens are helpful for the diagnosis. But for the treatment, almost it is similar, like antihistaminic drugs, steroids, beta-2 agonist, epinephrine. And here also antihistaminic steroids, beta-2 agonist, and epinephrine for pseudo-allergic reactions. What we were discussing a couple of slides ago, that certain markers or prediction of the untoward event can be taken by the clinician for certain specific drugs like abacavir. If the patient is having a certain HLA variation, in that case there is a chance of hypersensitivity reaction. Similarly, for ACE inhibitors, bradykinin B2 receptor genetic variation can lead to ACE induced cough and angioedema. Carbamazepine also very commonly used drug in case of convulsion or certain kind of neuralgia. If there is a variation in the allele of HLA-B1502, in that case there is high chance to develop the deadly Stevens-Johnson syndrome or toxic epidermal necrosis. The list continues. These are a few examples. Next, coming to some known terminologies as well as their importance, like drug tolerance and drug intolerance. From the name itself, it suggests drug intolerance, that is an undesirable pharmacological effect that may occur at low or usual doses of the drug without underlying abnormalities of metabolism or excretion or viability. Humoral or the cellular immune mechanisms are not thought to be involved, and a scientific explanation for such exaggerated response has been established. Drug tolerance is patient with a drug allergy will tolerate a drug without an adverse reaction, and drug tolerance does not indicate either a permanent state of tolerance or that the mechanism involved was immunological tolerance. Next, what is induction of drug tolerance? Again, from the terminology itself, we can understand the meaning is that it is actually also referred to drug desensitization also, and it is temporary induction of the drug tolerance. Now, the induction of the drug tolerance can involve IgE immune mechanism, non-IgE immune mechanism, pharmacological mechanism, and undefined mechanisms, and administration of incremental doses of the drug sometimes required. Drug desensitization is induction of the immune drug tolerance by which effector cells are rendered less effective or non-reactive to the IgE-mediated immune response by rapid administration of incremental doses of an allergic substance. Next, coming to the graded challenge or test dosing. What is that? That it describes the administration of progressively increasing dosage of medication until a full dose is reached. And the intention of a graded challenge is to verify that a patient will not experience an immediate adverse reaction to the given drug, and the medication is introduced in a controlled manner to the patient who has a low likelihood of reacting to it. Drug idiosyncrasy, that is an abnormal and unexpected event, and it is unrelated to the intended pharmacological action. It is mediated by unknown mechanism and not mediated by the humoral or the cellular immune response. Very importantly, another point is drug allergy delabeling. That is, drug allergy delabeling refers to the removal of the listed drug from the allergy section. Sometimes that is also a need, and that is a good as well as approach to save the drug. Sometimes those drugs are in the allergy list, and the clinical pharmacologists have a crucial role in drug allergy delabeling. Next, coming to the PI concept. PI concept stands for pharmacological interaction concept. That is, a drug binds to non-covalently to a T cell receptor and lead to an immune response via interaction with a major histocompatibility receptor. And the main difference is that here no sensitization is required because there is a direct stimulation of the memory and the effector cells. Skin test sensitivity and specificity, if we see for the immediate hypersensitivity skin test, in that case the high sensitivity is around 97 to 100%, and the specific the sensitivity is around 97 to 100%. The sensitivity is low, that is around 29 to 68%, and there it can be classified into three categories, like drug allergy, no drug allergy, or suspected drug allergy. That is, drug allergy could not be ruled out. In vitro testing, we will not discuss in detail about the testing. We'll just have a overall outline that immediate drug reaction and the delayed drug reaction. For immediate drug reaction, specific IgE testing that is safe, but there are limited numbers of suitable drug conjugates available for it. Next is that basophil activation test, that is promising functional test that requires viable cells and a drug conjugate preparation for activation. Next, under delayed drug reaction, lymphocyte transformation test comes, as well as some other tests like CD69 upregulation, in vitro cytokine production test, all those comes. Under LTT, it is most common research method to determine the responsible drug. Issues remaining include the standardization, requirement of the viable cells, all those. Now, focus of the in vitro testing, it is to confirm that the clinical findings are the result of immunological response rather than a pharmacological or idiosyncratic response that we were discussing just now. Identify the causative agent, and the current testing includes the under this broad heading is LTT, CD69 regulation, flow cytometry test, cytokine production, evaluation of the cytotoxicity. Now, diagnostic test under that, IgE mediated or type 1 reaction can be diagnosed, skin prick testing, and the intradermal injection of the allergen. Skin testing guidelines are standardized for the penicillin. A negative test result is useful for ruling out the penicillin allergy and high molecular weight proteins. Serum specific IgE tests are available for certain drugs, but it is expensive and less sensitive than the skin test and not optimally validated for the drug allergy testing. Coming to LTT, few points about LTT, that it must use the controls to establish the lack of drug-induced toxicity and to rule out the non-specific activation. It must have viable cells and require sterile tissue culture. LTT has been successfully applied to drug-associated maculopapular exanthem, pustular exanthem, SJS10, or drug rash with eosinophilia or DRESS syndrome. Positive LTT has generally been defined as stimulation index more than 2, and sensitivity is around 70% under optimal condition with a higher specificity, which were less for the sensitivity was less for the patch testing. Next, the negative test does not rule out T-cell mediated drug response. It appears to be a suitable complement to other testing in delayed drug reaction. Timeline for positivity may differ from the different types of this delayed type of reaction, and the positive test helps to identify the offending drug, but a negative test does not rule out the drug-related hypersensitivity. Coming to patch testing, it is like placing the allergen or the non-irritant concentration on the patient's back for 48 hours and then assessing any reaction. This is a broad points about patch testing, and it is useful for diagnosis of various delayed skin reaction type 4, which is often not helpful for the diagnosis of SJS or 10. Measurement of histamine and tryptase level in the blood have been useful in confirming acute IgE mediated reactions like anaphylaxis. Basophil activation tests are involved in both immune mediated and non-immune mediated reaction, and the quantification of the basophil activation is done by flow cytometry, and this test is a method of evaluating the expression of the CD63 on basophil after stimulation with an allergen. There are certain real-time tests to diagnose SJS10, but this is the access to these tests is very less to majority of the institutions. Majority are in research level, like the serum level of the granulysin. If it is more than 100 time, then we can easily make the diagnosis of SJS10 at an attractive target. Similarly, this assay could prove useful in predicting when a drug reaction will lead to the SJS10. In the future also, there are certain in vitro culture tests of IFNG, interleukin 2, interleukin 4, 5 may reveal specifics and about the type of immune response. Nature of drug-derived epitopes inducing an immune reaction often are not well understood, and mass spectrometry might help in that regard. Again, now if we re-look into this classification and see what are the investigations that are more related to the different types of the classification, in that case, the investigations for type 1 are like skin prick testing, intradermal testing, specific IgE testing, and drug provocation testing. Next, type 2 is CBC or Coombs testing. Type 3, under that C3, C4, apart from that, urine histology, chest x-ray, all those required. Under type 4A, 4B, 4C, 4D, patch tests come. Now we can have a look into these adverse drug reaction types and the treatment options that will be discussed later on in some other session. That medical history, symptoms, mediated physical, clinical laboratory data, if it is a drug reaction suggesting, in that case we will have a look into the left-sided part, that is whether it is immune mediated or non-immune mediated. If the answer is all those answers for suspicion of drug-induced hypersensitivity, answers are yes, that then it may be for IgE, cytotoxic or immune complex or delayed. In that case, we will have any test for supporting the immune drug reaction. Again, if the answer is yes, in that case, the diagnosis of drug hypersensitivity or immunological reaction will be confirmed. If the answer is no, in that case, it does not, test have high negative predictive value, that we have to find out. If the predictive value is high, in that case, administer drug with observation, and if it is no, in that case, consider desensitization. Anaphylactic reaction require the prompt emergency treatment, avoid drug if possible. So this is a broad approach along with the management approach for drug allergy. Drug allergy is strongly suspected when the symptoms and physical findings are compatible with the immune drug reaction. Sambo, I'm towards end. Please allow me a few more minutes. Definite temporal relationship between administration of the drug and an adverse event. class and or structure of the drug have been associated with the immune reaction. Patient had previously received the drug and no other clear cause for the presenting manifestation. Skin test and or laboratory findings are compatible with the drug hypersensitivity. Are appropriate confirmatory tests available? This is a very important question that comes into majority of the clinician's mind. And the answer is that diagnosis of many cases of drug allergy is presumptive, as specific confirmatory tests are usually not available. Penicillin and a limited number of agents are the only agents for which optimal negative predictive values for IgE-mediated reactions have been established. Where skin test results cannot be interpreted properly, that is generalized eczema or dermatographism or lack of response to the positive histamine control, some in vitro assays for specific IgE are available, and it is not as sensitive as the skin test and generally do not have optimal negative predictive value. If the laboratory tests are not diagnostic or available for in non-IgE mediated drug reaction, in that case, cautious provocative drug challenges under controlled condition can be considered. But again, the contraindications we have to take into keep in our mind, like if there is a life-threatening immunocytotoxic reaction, in that case, we cannot do that. The differential diagnosis for drug allergy also we have to keep in our mind, like IgE mediated drug allergy like urticaria, angioedema, anaphylaxis or bronchospasm, and non-IgE mediated like exanthema, DRESS, SJS, 10, and under that what are the possibilities are there that has been listed here. Now coming to the role of clinical pharmacologist, that is a very crucial role actually. And also I would say that this is an unexplored area, but the clinical pharmacologist has a potential to explore and help the clinicians as well as to assist the achievement of the goal for the patient of healing. That is, a clinical pharmacologist seems to be better poised to elicit a detailed medication and allergy history and to render the right advice to the individual with drug allergy with proper counseling. The domain skills of a trained clinical pharmacologist would facilitate the prescription of the right intervention for the lab diagnosis or guiding appropriate management. Post-treatment follow-up advice may be suitably drafted and monitored by a clinical pharmacologist. The patient-reported medicine allergy, particularly allergy to the antimicrobials, more often than not are over-labeled, and a clinical pharmacologist can take necessary steps to de-label them. And now to summarize, the diagnosis relies on a meticulous history and physical examination, skin testing, and if warranted, the graded challenges of allergen induction of drug tolerance procedures may be required in some instances. Alternative medications with unrelated chemicals structures should be substituted. Cross-reactivity among drugs should be taken into consideration when choosing the alternate medications. With that, I would like to acknowledge our department as well as Professor S.K. Tripathi sir, our HOD sir, Dr. Shambo also to help me out for making the presentation, and our student Dr. Devajyoti Shah for helping me for making this slide. Thank you. Thank you very much.
Thank you very much, Dr. Shambo. May I request my co-chairperson to have a quick comments?
Yeah. Thank you, Dr. Sen, for such an elaborate talk on diagnosis of drug allergy. Now moving to the next difficult part. Once you have diagnosed such allergy, how do you manage it? So I request Dr. Indranil Banerjee to shed few lights on this topic.
Well, by the time Dr. Indranil gets ready regarding the presentation by Dr. Sen, I think time permitting at the end, we may think of discussing in a couple of words, what are the current challenges in accessing the diagnostic tests, allergy tests. Yes, there are a lot of theoretical rationale and they have also generated evidence, but then to what extent, how many laboratories are actually comfortable and have the arrangements for doing these allergy tests? Okay, and whether there is an information gap also, that the physicians who are confronted with drug allergy, whether the physicians know in the city these are the laboratories which otherwise undertake allergy tests. That also is something which we need to discuss and deliberate on. And the other point I would like to mention about the I think last but one slide, Dr. Sen has rightly pointed out about labeling and the need for dislabeling. Okay, there are many cases where the patient would report that I have allergy to these or these drugs. That is based on their experience, but really whether there is an allergy or not, it was actually an intolerance, or it was just a non-immunological adverse experience. And in a very colloquial manner, okay, the patient feels that it was an allergy. Anything adverse happening after intake of a drug, patient has a tendency to label it as allergy. And in future consultation with other doctors, they will say, I cannot tolerate this, I have an allergy on this. So there is possibly a need for de-labeling of drug allergy, which can only an allergy specialist or clinical pharmacologist, they would like to do that. With these couple of comments, I would request the next speaker, Dr. Indranil Banerjee, again another clinical pharmacologist, and who is now a professor of pharmacology at Lady Hardinge Medical College at New Delhi, to please come up and speak on management of drug allergy. Prevention is better than cure. Over to Dr. Indranil.
Am I audible?
Yes, you are. Go ahead.
A very good afternoon to all of you. First of all, at the onset, I would like to thank the organizers of ALLERCON 2021 for inviting me as a panelist to speak on this particular aspect. I would also take the opportunity to particularly thank Dr. Shantanu Kumar Tripathi, who is my mentor also. And 7 years, almost 7 years down the line, I feel that I am giving a seminar in front of you. So for discussing this particular thing, management of drug allergy, prevention is better than cure. Always and always, whenever I was going through the details of these guidelines, I found that every guideline actually emphasizes the role of preventive approach in management of drug allergy. Let's begin. First of all, what is drug allergy? Drug hypersensitivity reactions, basically every documents, every guidelines mention it as DHRs. They are basically adverse reaction of pharmaceutical formulations, including active drugs and excipients. This is very important. Not only the active drug, but also the excipient that clinically resemble allergy. Drugs induce several different types of immunological reactions that, together with non-allergic drug hypersensitivity reactions, comprise 10 to 15% of all ADRs. Already I know my earlier speaker, Dr. Shomallu, has covered these types of drug allergy, what is adverse drug reactions. So I'm not going into the details, it is already defined. Classification has already been told by Dr. Somalia, so I will not again reiterate it. But what I want to emphasize this particular thing, that is classification of the drug adverse drug classification का जो details है, that is to some extent which is very important. If you look at the type A is something where the reactions occurring in normal patients given sufficient dose and duration of therapy. But it is type B, which is to some extent where an uncertainty prevails. These basically refer to the drug hypersensitivity reactions restricted to a small subset of general population. That can be drug intolerance. Example, tinnitus after a single aspirin tablet. Idiosyncrasy, G6PD deficiency, certain drugs produce hemolytic anemia, like dapsone. Then immunologic drug reactions, anaphylaxis from beta-lactam antibiotics. It is this immunologic drug reactions about which we are interested. Again, it is already discussed by me in the earlier slide that it actually contribute to 10 to 15% of all ADRs. It is not a very common ADR. Now, to know about, or rather for optimal management of a patient it is very important to identify the risk factor for developing drug allergy, because for a physician perspective, what your mind knows, only your eyes can see them. So regarding the risk factors for developing drug allergy, obviously the most important is the drug factors. Regarding the drug factors, the first thing that comes is about the nature of the drug. Now, the ability to elicit the immune response is based on two features of the drug. One is antigenicity, the second one is immunogenicity. Also, my earlier speaker, Dr. Somala, has already told about the PI interaction, that is pharmacologic interaction. But there is still a need for better understanding of different aspects related to the immunological mechanism and which drug determinants that actually contribute to this particular immunologic reactions. Because if you see, numerous drugs have been implicated in the production of allergic reactions. Globally, antibiotics and analgesics, these are the two drug classes which are most commonly implicated in drug allergy. But here is a very important twist. Geographical differences exist, which is caused by local prescription patterns. For example, where there is good data archiving, for example, in USA, antibiotics are by far the most common culprit drugs which contribute to anaphylaxis, followed by analgesics which also contribute to drug allergy. Whereas in Europe, the most frequently involved drugs are predominantly antibiotics. In Latin America, NSAIDs are the most frequent drug involved in anaphylaxis. In case of China, the most frequently implicated cause is antibiotics, followed by traditional Chinese medicines. It is important from the Indian perspective because in India also we frequently consume traditional drugs. But again, there is the pharmacovigilance of traditional drugs is to some extent, which is right now coming up, but still in its infancy. Then degree of exposure. Degree of exposure particularly refer to the dose, duration, and frequency. Dose, it has been found that though no rigorous study has been done or no meta-analysis or systematic review has not been published, but it is reported in one allergy update published by INCON that intermittent courses of moderate drug doses clearly predispose to sensitization. Route of administration, topical administration of a drug is associated with a high incidence of sensitization. And that is the reason why you will never find penicillin or sulfonamide. They are never used topically because of this risk. Oral administration of a drug is generally considered safer than any type of parenteral administration. The other thing, cross-sensitization has already been discussed. I would just like to add one thing, that once sensitization to a drug has occurred, the possibility exists of reactivity either to drugs with a close structural chemical relationship or to immunochemically similar metabolites. Now, this is one aspect which my earlier speaker, Dr. Somala Sen, told, and also my mentor, Dr. Tripathi, also just told that there the role of a clinical pharmacologist is very important because he is much more trained to identify the particular QSAR which can contribute for this cross sensitization. For example, it is known that say substances with a free amino group in the or aminobenzoic acid, sulfonamides, they are much prone for cross sensitization. Next comes the host factors. Host factors, age and sex. Obviously, in children, it has been found in there are studies that in children, the incidence of drug allergy is to some extent low. And while a patient gets old, in the geriatric patients, this particular prevalence increases to 30% almost. This may be due to the comorbidities or due to use of multiple medications. So there are age and sex. Regarding sex differences, the drug allergic reactions are more common in female. One of the hypotheses that has been put forward is regarding higher drug consumption in men compared to men. Apart from that, epigenetic factors, hormonal interactions with immune cells that can also contribute. Regarding genetic factors, it is obviously HLA typing, acetylated status, they contribute. For example, in one of our studies, which is published by the Institute of Genomics and Integrative Biology in New Delhi, they actually published one study where they have shown that HLA-B1502, this particular thing has been associated with carbamazepine-induced SGS or 10 in Indian population, not the Indian population to be precise. Next, what is very important is about the concurrent medical illness. Concurrent medical illness actually also contribute to this thing. For example, hypoalbuminemia, drug allergies. In hypoalbuminemia, drug allergy due to antibodies is rare, but cell-mediated reactions such as contact dermatitis, they actually gets increased. Patients with sarcoidosis, they have impaired cellular hypersensitivity and they are less likely to develop drug allergy. So this backdrop has to be kept in mind in the physician's mind to do an optimal diagnosis and management workup for a patient with whom he is suspecting to be suffering from drug allergy. Also, one thing is that is previous drug exposure. Previous drug exposure is very important because there is certain evidence that patients who have demonstrated drug hypersensitivity in the past, they have an increased tendency to develop sensitivity to new drugs. And one should be much more cautious in medicating such patients. A particular thing that is multiple drug allergy syndrome. It is to some extent low in incidence. Patients with multiple drug allergy syndrome, they have a predilection to more than one cross-reacting medication. Its prevalence is around 2.5% of total suspected DHRs, around 2.5%. So this is something which we should keep in mind. Now regarding the types of DHR. The types of DHR are immediate DHRs. They are possibly induced by an IgE-mediated mechanism and occur within 1 to 6 hours following the drug administration. They usually manifest as isolated symptoms such as urticaria, angioedema, conjunctivitis, rhinitis, bronchospasm, gastrointestinal symptoms, and the most dreaded one, anaphylaxis. Whereas this is about the earlier one was about immediate DHRs. The non-immediate DHRs, they have been mentioned as they occur at any time from 1 hour following the initial drug administration. They commonly occur after many days of treatment and are often associated with a delayed T-cell dependent type of allergic mechanism. Maculopapular exanthema and delayed urticaria are the most common clinical presentation of non-immediate DHRs. Please remember, although this classification is, it is not quite fixed. This classification is important in clinical practice for workup planning. There are limitations in classification because factors such as route of drug administration, the role of drug metabolites, and presence of co-prescribed medicine can accelerate or slow down the onset of progress of a reaction. The diagnosis, I will not go into the details of the diagnosis because that has been very nicely elaborated by my earlier speaker. I will just mention some salient points which will help in the management. The diagnosis is based on detailed history, onset of symptoms and signs, and temporal relationship. The chronology, it is very important between appearance of those symptoms and drug use, effect of drug use on discontinuation. The diagnostic test, as Dr. Somala mentioned, it will clear history, the importance of history, clinical examination, it goes beyond doubt. In vitro test, like measurement of mediators, histamine, serum tryptase. Serum tryptase is very high in case of anaphylaxis. Allergen-specific IgE levels, flow cytometry-based basophil activation assays, lymphocyte transformation test. In vivo tests include patch test, a skin biopsy, drug provocation test. In Delhi, there is one institute, Allergy Institute, that is a private institute which is near Patel Nagar, which actually do this particular testing. Apart from that, VP Chest Institute, there was a project which was going on, but I don't know whether they do it routinely routinely. I don't think they do. Now, other investigations for the drug hypersensitivity also includes, particularly when you are suspecting drug-induced pneumonitis. Then what happens is that you can go for chest X-ray, CT thorax to find the high-resolution CT, which may be useful. Bronchoalveolar lavage and open lung biopsy, that is usually not necessary. Now about the management of acute DHRs. The most dreaded one. First start with the most dreaded one, that is anaphylaxis. Anaphylaxis is a medical emergency. And so the basic of emergency, any emergency management, that is airway, breathing and circulation. So it have to say, the physician has to secure the airway, breathe and maintain the breathing and circulation, and use of specific drugs like intramuscular epinephrine 0.3 to 0.5 ml of 1:1000 concentration up to every 5 minutes in adults, or the same dose is for this particular dose is for adults, and the dose 0.01 milligram per kg in children up to a maximum of 0.3 milligram. During the course of treatment, if cardiorespiratory arrest occurs, then cardiopulmonary resuscitation should be immediately instituted. Now, studies show that this cardiopulmonary respiratory arrest usually occurs in older patients with, for example, who are suffering from angina, or there is certain decreased cardiac reserve. The route of administration is clear, intramuscular. In every guideline, it is mentioned like that. In certain studies and also in certain guidelines, they mention that the intramuscular injection should be preferably given in the thigh, because the absorption is better when you give in this particular location. The second line intervention that includes for management of anaphylaxis is high flow oxygen for patients with cardiovascular instability. Fluid support should be initiated promptly. Inhaled short-acting beta-2 agonists like salbutamol can be additionally given to relieve the symptoms of bronchoconstriction. The third line intervention includes H1 and H2 antihistamines and glucocorticoids. Systemic glucocorticoids, systemic corticosteroids like may be used to prevent the delayed phase reaction in acute anaphylaxis and to prevent or treat associated angioedema and the lower airway inflammation. Now, it is recommended to observe the patient for at least 6 to 8 hours in case of respiratory compromise, and at least 12 to 24 hours for patients who present with hypotension. This will facilitate the recognition and treatment of the biphasic reactions. And one thing is very important, that the entire management should usually be done in a setup which has got the intensive care facilities. For example, every equipments for cardiopulmonary resuscitation. For non-serious DHRs, stopping of the offending drug and judicious use of antihistaminics offer the treatment, basically the treatment of choice. In case of Stevens-Johnson syndrome or toxic epidermal necrolysis, oropharyngeal hygiene, gargle solutions, eye care, that is mouth care, eye care, skin care should be ensured. Adequate hydration, nutrition, and respiratory care are of paramount importance. High-dose intravenous immunoglobulin has been used at various centers with good outcomes. Particularly, they help in skin re-epithelialization. There are certain studies which actually advocate their use, but it has not been mentioned in, say, Cochrane guidelines or any definitive guidelines. Other immunosuppressive therapies like cyclophosphamide, plasmapheresis, systemic corticosteroids, they have not been found to be uniformly useful. Recent interest has reemerged on the possible benefit use of cyclosporin provided patients have not developed acute kidney injury and uncontrolled infection. These are basically two contraindications where despite SGS or 10, you cannot give cyclosporin. The next most important thing about the preventive strategies to prevent the DHR. this is actually included in the management itself. This is something which is unique. In case of other diseases, what we find is that general management, then specific management where any specific antidote or specific drug is mentioned. Here the preventive strategy is very important. When anaphylaxis has occurred because of exposure of a drug, the patient should be educated about agents or exposures that would place them at risk for future reactions and be counseled on avoidance measures that might be used to reduce risk for such exposures. It is a very naive area for clinical pharmacologists, where they can unexplored area for clinical pharmacologists and allergists who can play vital role in this regard. Patients with anaphylaxis to medication should be informed about all cross-reacting medications that should be avoided. Should there be a future essential indication for use of incriminated medications, it might be useful to educate patients about applicable management options. And also, I will discuss in details what are the things that are actually helpful. From the physician perspective, before prescribing, the patient should be questioned directly concerning previous drug reactions, and medical records should be reviewed for previous notations of drug allergy. Cross-reactivity between chemically related drugs should be considered. This is very important in countries where good healthcare records are maintained. For example, if you go in NHS UK, they actually maintain whether the patient has developed drug allergy, and that record is preserved. Orally administered drugs are less likely to produce reactions, and that should be preferred over topical or parenteral route. Medic alert tags and bracelets represent a useful way of alerting healthcare providers to a previous severe allergic reactions. Patients should be encouraged to carry epinephrine portable injections and appropriately trained for its optimal use. Actually, it has been found there are many studies where the use of epinephrine portable injections that has drastically reduced the mortality and morbidity associated with anaphylaxis. This is I will show the picture. This is a picture of a bracelet of a patient who is allergic to penicillin. The next one, this is about EpiPen. EpiPen is portable injection. It contains pre-filled epinephrine. In India, the cost of this injection is rupees 2,500. But the important thing is that the patient has to be trained properly regarding its use, how to administer it, where to administer it, that has to be trained. Next, about specific preventive management. That already my earlier speaker, Dr. Somala, has said, drug desensitization. Desensitization is a process in which the drug to which the patient is allergic is administered to the patient in small incremental doses to induce a state of temporary tolerance to the drug. This should be only attempted if the offending drug is deemed essential and no alternatives are available. Usually it is for IgE-mediated drug allergy, specifically to penicillins. Next, induction of drug tolerance. Drug tolerance is defined as a state in which a patient with a drug allergy will tolerate a drug without an adverse reaction. Induction of drug tolerance modifies a patient's response to a drug to temporarily allow treatment with it safely. It is only indicated in situations where an alternate non-cross-reacting medication cannot be used. Now, as have been elaborated earlier, I will just mention in details immunologic IgE induction of drug tolerance, how this drug desensitization is done. Immunologic IgE induction of drug tolerance is the progressive administration of an allergic substance to render affected cells less reactive. The induction of drug tolerance procedure vary with individual drugs, and they are intended for agents that induce IgE-mediated reactions. In some cases, anaphylactic reactions, as for paclitaxel, Again, for example, in penicillin, induction of drug tolerance, the initial dose is typically approximately 1 by 1/10,000 of the full therapeutic dose. The dose has to be, there are definite scales. You will find in any, there are particular guidelines which have been mentioned in American Academy of Allergy, Asthma and Immunology. The further dose increases are typically twice the previous dose and are administered at 15 to 30-minute intervals until therapeutic levels are achieved. Induction of drug tolerance should be performed in an appropriate setting, supervised by physicians familiar with the procedure, at continual monitoring of the patient and readiness to treat reactions including anaphylaxis if it occurs. Now, pharmacologic induction of drug tolerance. That is very interesting. Pharmacologic induction of drug tolerance to aspirin is primarily intended for patients with aspirin exacerbated respiratory disease, after which patients become tolerant to aspirin and NSAIDs. Aspirin desensitization is a form of pharmacologic induction of drug tolerance, but similar to other induction of drug tolerance procedure, pharmacologic induction of drug tolerance procedures induce a temporary state of tolerance to aspirin that is maintained only as long as the patient continues to take aspirin. After aspirin desensitization, loss of tolerance generally returns in 2 to 4 days after discontinuation of the continuous aspirin therapy. One important indication for aspirin desensitization is patients with aspirin exacerbated respiratory disease who require aspirin as a secondary prophylaxis for cardiovascular event. The other indication is poorly controlled AERD despite use of appropriate medications, or patients who require long-term treatment with systemic corticosteroids to control their disease. Then immunologic non-IgE induction of drug tolerance for non-anaphylactic reaction. For some delayed non-IgE mediated cutaneous reactions, immunologic non-IgE induction of drug tolerance may be performed to allow treatment with the drug. Immunologic non-IgE induction of drug tolerance procedures are intended for patients who require a given drug to which they have been previously experienced delayed non-IgE mediated cutaneous reaction. These are typically performed over hours to days with an initial dose in milligram range. Examples where it is performed, for example, the cotrimoxazole, that is trimethoprim sulfamethoxazole, induced typical delayed drug eruption in HIV positive patients. There, this particular strategy is undertaken. Words of caution: induction of tolerance to the offending drug is temporary. Patients should still be regarded allergic to that particular drug, and that should be communicated to the patient. Should the patient require the medication 3 to 7 days after cessation, the desensitization process should be repeated. Regimens have been described for many drugs, including cephalosporins, penicillins, cotrimoxazole, allopurinol, chemotherapeutic agents like paclitaxel. That has been detailedly mentioned in different national and international guidelines. Regarding the course of and prognosis of DHRs, the outcome of most cutaneous drug allergies is good after immediate cessation of the drug and symptom relief. Drug-induced anaphylaxis is potentially fatal only if it is not managed promptly. In SGS and 10, the reported mortality rates usually varies from 30 to 50%. The effect of IVIG on mortality in patients with 10 remains indeterminate. Ocular complications, they are measured, but relatively long-term sequelae of SGS-10. In studies, it has been shown this particular ocular complication is the most important morbidity of this SGS or 10. Drug allergy actually may result in anxiety and impairment in health-related quality of life for sufferers. So definite measures should be taken by the physicians, by the caregivers to allay their anxiety, to properly counsel them. Now let me share an experience which which I actually gained during my when I was pursuing my DM clinical pharmacology course in School of Tropical Medicine. There actually we are fortunate to have a clinician who was doing PhD at that time, and he actually got this particular case. He is a physician with very good clinical acumen. That's why he could identify that this was a case of drug allergy. In fact, the case goes like that: a 52-year-old male patient was admitted in a particular hospital with fever, chills, rigor, headache, and body ache. While doing the diagnostic workup, he found that there is a USG actually revealed that there is some space occupying lesion in the liver, and he suspected liver abscess because there was WBC count was increased. ESR was around 115 millimeter in for first hour, so far as I can remember, and the eosinophil count was 9%. And he suspected basically that he actually do USG guided percutaneous aspiration. The aspirate was sent for serology, and for Entomyba histolytica was found. The tropozoites of Entomyba histolytica was found. What he did was that he started injection metronidazole 750 milligram IV 8 hourly every day and just as he started, after 4 days of starting injection metronidazole, blisters appeared on the non-pressure areas, which were non-pruritic, non-tender in nature. The vitals were stable at that time. The blisters he found over the pressure areas like left shoulder joint, lower abdomen, non-pressure areas also. A mild edema was there over face, dorsum of feet, hands. Blisters were of different size, including multiple bulla. So he suspected that metronidazole may be the culprit drug. What he did was that he discontinued injection metronidazole. The skin biopsy was done, and their subepidermal vesicles were found. A diagnosis of metronidazole induced bullous pemphigoid was made. He was treated with IV fluids, tablet paracetamol 500 milligram on SOS basis, tab levocetrizine 5 milligram, gentian violet paint over intact bulla, fusidic acid plus betamethasone cream, topical application twice daily over these lesions which got eroded. And what he found was that upon withdrawal of injection metronidazole, there was improvement of eruptions and no new lesions appeared. We did a workup on this particular patient, and we did causality assessment using Naranjo algorithm, where the score was found to be 7, indicating a probable association, as well as we did modified Hardwick scale, where it was found to be of moderate level. And in metronidazole induced bullous pemphigoid is to some extent rare, but it was only the acumen of the clinical acumen of the treating physician that he could diagnose such a case. So one thing is very important. Usually, while diagnosing a patient to be suffering from drug allergy, usually what the physician gets carried away by the common diseases and ailments. But this particular diagnosis should be in the back of the mind of the physician. That is very important. Thanking you all for your patient listening. It was a nice experience for me. Thank you all.
Thank you, Dr. Banerjee, for such an elaborate talk on how to manage drug allergies. I further invite our dearest Shambhu for his next talk on sulfa allergy. Dr. Shambhu doesn't need an introduction. Welcome, Shambhu, for your talk. Over to you.
Yeah, by the time Dr. Shambhu prepares, just a couple of comments. I like the way Dr. Indranil had also highlighted the importance of providing some kind of document to the patient. Okay, in other countries there are very well recorded, or documentation is very good, and he has also mentioned about bracelet or giving some kind of identification that the patient would carry that he is suffering from the certain kind of drug allergy after it is really diagnosed. In this country, I don't think that maybe other people can throw some light that whether and to what extent it is considered really important a patient who has suffered drug allergy, diagnosed, was hospitalized, and then when he is being discharged, with how much seriousness and how much emphasis the patient is counseled that you must carry this document, you are suffering from this drug allergy, and there is a possibility of cross allergy or cross reactivity with these drugs which you should avoid. So that kind of guidance would be otherwise very useful, and I'm happy that Dr. Indranil has rightly mentioned. I was also expecting some discussion on the epigenetics of drug allergy and the pharmacogenomic approach. Although it may not be very routinely used, it may be a thing of the future. But then we need to also understand the basis of the epigenetics and predictive medicine in reference to drug allergy, particularly because Dr. Indranil was discussing about prevention of drug allergy, preventive aspects or preventive considerations. But then Dr. Indranil has certainly done a great job and handled the topic very nicely, done sufficient justice to the topic. Thank you, Dr. Indranil. Now we can go to the next session, that is Dr. Shambhu Samrat Samasdar. Over.
Sir, can I add one comment?
Yeah, please, yes.
Sir, in the drug
Dr. Moitro, please.
Yes, thank you. Means I must thank Dr. Indranil. He has presented it in such a nice way. His lecture was really very interesting. So there are 2-3 points, difficulties that we face in our country. I'd just like to say 1 or 2 points. One point is, as Professor Tripathi sir, you have rightly pointed out, here patients usually do not carry any such band or any such document which shows that he or she is allergic to these drugs. That is one of the problems. But two is that evaluation of the drug allergy we have seen it's in a very archaic manner, because most of the people are not following the European network.ENDA guidelines. And what happens at that time, the patient gets mislabeled as a drug allergy, because non-written concentration of the drugs are not used for the skin prick test or the intradermal test. And there are very few centers, hardly 1 or 2 in the country, which is doing the drug patch test to determine the delayed drug allergic reaction. So these are the 2 gaps which is still there in our country. That is, patients are not getting identified as the allergic drugs, and second thing, they are getting mislabeled for drug allergy. So I think which needs to be looked into in the future to improve the treatment and also diagnosis of this very important issue.
Thank you, Dr. Moitro. So let's move to Dr. Shambhu Samrat Samasdar. Over.
Thank you, sir. So this is one question that has been asked by one senior nurse last year. When we don't have any COVID-19 vaccine, we were relying upon some prophylactic regimen for COVID-19, and we often used hydroxychloroquine as a prophylactic agent. So 58-year-old nurse asked this question: Doc, I have a history of sulfur allergy. Shall I take hydroxychloroquine sulfate? So let's find the answer in my next 20-minute presentation. So we will discuss about sulfur allergy. What is it? Mechanism of sulfur allergy. Sulfur allergy, which drugs should be avoided, and no need to panic with which drugs. Then we will discuss one real life case also. So we all know about Bombay duck, and there is no direct relationship with Bombay or duck with this Bombay duck. And this is the actual picture of Bombay duck, which is a famous fish. And like that, sulfur allergy, that is also a very much colloquial expression, and actually promotes misinterpretation and over-leveling. So as a clinical pharmacologist or allergy physician, we need to be very cautious and try to delabel this sulfur allergy very often. And for that, we need to take proper history And sulfur allergy does not equal to allergy with medicines that contain sulfur, sulfides, or bisulfate salts. There are some other drugs, completely different groups of drugs like penicillin, cephalosporins, omeprazole. They also contain that sulfate moiety, like morphine sulfate, ferrous sulfate, like that. So sulfur allergy does not mean we should not take atropine sulfate like that. Sulfur allergy means actually the allergy with some sulfonamides, and for that we should revisit our chemistry knowledge little bit. And sulfonamides, what are they? They are compound with that SO2 NH2 moiety, and there is two specific groups we need to understand to know about that sulfonamide. One is sulfonamide antimicrobials like sulfomethoxazole, and another group is non-antimicrobial sulfonamide. That we'll have some brief discussion on that. And to ring, that is most important here, we can see this N1 heterocyclic ring, and this is the N4 aromatic amine. What are their significance we will discuss, but we need to understand in this sulfonamide structure, these are the two important ring that is present, and that is responsible of manifestation of different types of allergy. Now coming to the mechanism of sulfur allergy, and we must appreciate the type 1 Ig mediated reactions, type 1 hypersensitivity reactions are generally due to that N1 heterocyclic ring. So when there is a history that's suggestive of type 1 hypersensitivity, we should focus on that N1 substitute, and we should think before prescribing any other drugs whether they contains that similar type of N1 heterocyclic ring or not. And for non-Ig mediated reactions like Stevens-Johnson syndrome, 10 like that, the N4 is the responsible. And for that, who are more prone to develop this Stevens-Johnson syndrome or toxic epidermal necrolysis? Those who have less action on CYP2C9, because that causes the N4 hydroxylation, and that particular metabolized will oxidize and produce some reactive nitroso compound which has a direct cytotoxicity by binding to the T cell, CD8 mediated reactions. And what is important to note here, maximum of non-antimicrobial sulfonamides, they lack N4 aromatic amine. So if a person has history of Stevens-Johnson syndrome with a cotrimoxazole, then we should not be be fearful regarding the development of Stevens-Johnson syndrome with non-antimicrobial sulfonamides. So this is very important to note. So when there is sulfur allergy, that means sulfonamide allergy, which drug should be avoided? Avoid all sulfonamide antimicrobials. There is no doubt on that. The sulfasalazine should be avoided because as it is metabolized, it produces sulfapyridine, which is just like a sulfonamide antimicrobial. So we need to avoid sulfasalazine also. There are some conflicting information on cross reactivity of dapsone. Better to avoid, but when required, we need to consider other issues, desensitization like that. Two antiretroviral drug, that is fosemprenavir and darunavir, they had also the similar N4 molecules like sulfonamides. So sulfonamide antimicrobial. So we need to be cautious, or rather avoid those antiretroviral drugs. No need to panic with which drugs. Generally, the sulfonamide non-antibiotics, it has been seen that in those patients who has sulfonamide antimicrobial allergy, they are more likely to react with sulfonamide non-antimicrobials, 9.9% versus 1.1%. But the thing is important that the penicillin, if just to see the penicillin allergy, penicillin hypersensitivity in that particular group, that found to be 14.2%. So what at the beginning, Professor Shantanu Kumar Tripathi sir was mentioning how we can predict. There are some concept theories known as pharmacological immunological interaction. So most probably those persons who has sulfonamide allergy may possess some specific HLA phenotype that causes them to react more with different groups of drugs. And another important issue is that generally this type of antibiotics like sulfonamides or penicillin we used in presence of infection. And it has been seen by different studies that the threshold of reaction becomes little bit in lower side when there is concomitant fever is present. So these all issues we need to consider. But yes, if we try to initiate sulfonamide non-antibiotic in patients who has history of sulfonamide antibiotic allergy, we need to be vigilant. So these are few sulfonamide non-antimicrobials like tamsulosin. So in the prescribing information, it was mentioned we should use this drug with caution if they are reported with sulfa allergy, but they are not completely contraindicated. Drugs like acetazolamide, brinzolamide, they are also have similar types of recommendation. Very commonly encountered problem, whether we should use furosemide or not. In the prescribing information, there is mentioned it as a precaution thing that in patients who has allergy to sulfonamide, we need to be cautious, but it is not completely contraindicated. There are some case reports with type 3 hypersensitivity reactions by producing SLE-like manifestations, but that is a different issue. Regarding other thiazide group of diuretics, it has been mentioned that hypersensitivity to these products or other sulfonamide derived drugs, we should avoid this group of medicines. Specifically, they mention we can consider metolazone in these regards. Now, just if we try to check the structure of a sulfamethoxazole and the furosemide, there we will found the N1 portion, there is nothing like this. So if a patient has sulfamethoxazole induced type 1 hypersensitivity reaction, there is very less chance to develop type 1 hypersensitivity reactions with furosemide. Yes, if there is sulfamethoxazole induced type 4 hypersensitivity reactions or type 3 hypersensitivity reactions like Stevens-Johnson syndrome, we know that N4 molecule, the N4, there is an arylamine ring. Here also there is an arylamine ring. So there is a possibility, but that is not an absolute contraindication. So there is one study and it was found, this is a medication chart review, that include patients with intracranial hypertension and a self-reported sulfa allergy. There is 37% of those patients on acetazolamide and or furosemide had no cross-reactivity. 56% had predictable adverse reactions specific for the medication, and 7% of the has the case like urticaria. Thus, although there is a low risk of cross-reactivity as exhibited by the urticarial reaction, there was no significant evidence to suggest that a self-reported sulfur allergy is likely to produce a life-threatening cross-reaction with either these two drugs like furosemide or acetazolamide. Other sulfonamide non-antimicrobials, if we see in our common practice, the cocci drugs, they are in the PI it was mentioned, it is contraindicated. But in case of sulfonylurea, the glimepiride, glyburide, and glyclazide, if we go by the FDA recommendation, FDA label, they mention it as a warning. But in case of EMA PI, EMA derived PI, European Association PI, they mention that if there is an hypersensitivity to glyclazide or any other sulfonylureas or sulfonamide, better to not use this drug. Contraindication is there. So these are few issues for our medical legal things. Now, if we again go by the structures, then we will found there are dissimilarity between that N1 part. So if there is any type 1 hypersensitivity reactions with sulfonamide, generally it is not going to happen with the other sulfonamide non-antimicrobials. But if there is type 3 or type 4 hypersensitivity reactions, we need to be cautious. So whether hydroxychloroquine sulfate has any concern, so it does not contain any sulfonamide moiety. So therefore, no chance of cross-reactivity. Sulfur containing drugs are there like amitriptyline, azathioprine, even clindamycin contains that. But sulfur containing drugs are not contraindicated in case of sulfonamide moiety patients. Sulfide is a very common additive that is used in food and drugs in different countries. Generally, this additive stimulates the allergic responses like asthma. That is a separate issue, but that does not mean that sulfide containing drugs should be avoided in presence of sulfur allergy. Sulfate salts, atropine sulfate, hydroxychloroquine sulfate, and ferrous sulfate, magnesium sulfate, they can be easily used in case of sulfur allergy patients. There is no contraindication. So we will end up with this case, a 60-year female, hypertension, obstructive sleep apnea, osteoarthritis, type 2 diabetes, and nasobronchial allergy. There is history of multiple drug allergy, sulfur drugs, and also hydrochlorothiazides. So she was on these medications like amlodipine, perindopril, glimepiride, metformin, and etoricoxib with aspirin, complaining of increasing dyspnea on exertion, orthopnea, and peripheral edema. So clinical examination and other findings suggested or confirmed the biventricular congestive heart failure. So whether we can initiate the 40 milligram oral furosemide here, or in case of emergency, whether we can give IV furosemide, that is one important question here. So what is important to note in this case? Yes, the patient has a history of sulfur allergy, also to allergy to hydrochlorothiazides. So maybe these patients has a chance to develop sulfonamide antimicrobial and sulfonamide non-antimicrobial allergy. But we need to take a detailed history of that particular hydrochlorothiazide induced hypersensitivity. And it was found that it is just itching after initiation of hydrochlorothiazide, and it was stopped. So this is a very important algorithm to see the seriousness of previous reaction. So if the history of sulfur allergy is there, whether it is serious like anaphylactic reaction, then if it is yes, then we should consider not to prescribe sulfur non-antibiotic unless it is an emergency or any alternative exists. If it is no, we can give sulfur non-antimicrobials, and we should have a vigilant approach to see whether the reactions is happening or not. Here it is important to note, in the diuretics, if we not consider furosemide, what are the other options? But unfortunately in our country, the drugs like ethacrynic acid is not available at all. Ethacrynic acid is not containing sulfonamide moiety, and we cannot use that ethacrynic acid in our country due to non-availability. So that is a problem that need to be explored more. But as a whole, we need to balance between the risk of using a furosemide and risk of not using furosemide at that point, and after balancing the risk versus benefit of using furosemide, we can prescribe furosemide in these patients. So this is the take-home message. Sulfa allergy, we need to see, is it sulfonamide antibiotic allergy? Then there is a high chance of cross-reactivity with other sulfonamide antibiotic. So better not to prescribe other sulfonamide non-antibiotic. And if at all it is required, like in case of HIV patients in some groups, or in case of some organ transplantation patient, we need to do the desensitization of this sulfonamide antibiotic. If it is with sulfonamide non-antibiotic, we are going to prescribe sulfonamide non-antibiotic in background of sulfa allergy. There is very low risk of cross-reactivity. We can prescribe, but prescription should be with caution. We should be very much vigilant. If it is sulfate, sulfite, or sulfur, we are going to prescribe in background of sulfa allergy. There is no risk of cross-reactivity, no concern with prescribing. With that, I thank you all for giving me this opportunity. And now over to our respected chairpersons.
Thank you, Dr. Shambhu, for such a nice talk. I think we are done with the drug allergy session here, as we don't have the fourth talk. Right, Shambhu?
Yes, madam. So we can end up here because we also running late. Now it is 4 minutes past 3. From 3 p.m. we should start our inauguration program. I am seeing Professor Amol Banerjee sir had joined already. So if you all permit us, Professor Shantanu Tripathi sir, Dr. Shoival Moitra sir, so then we can proceed for our inauguration.
Yes.
Yes, of course. Let us close this session and proceed for the inauguration, which is already overdue.
Yes.
Thank you.
So thank you all the speakers on behalf of the organizers. Thank you, Dr. Tripathi. Thank you, Shambhu. See you. Bye.
Thank you, madam. Thank you for giving us time. Okay. So, Dr. Jayati Das, have you joined, madam? Dr. Arijit Das, sir, have you joined? So, sir, let's take 1 minute, and I am requesting the technical team to please project that particular presentation I had sent on Allergy Asthma Research Center, and then we can proceed for our inaugural ceremony.
Allergy Treatment Center, a unit of
technical team, please stop this video.
is the pioneer institute in Eastern India in treating.
I'm requesting to share the slides that have been sent to you. Please check the mail, and the last slides, PPTs we had shared with you. Please share. Unless so, all the respected delegates and faculties, we are really honored to organize this 10th National Conference on Allergic Disease, ALLERCON 2021. So we are really fortunate to get the endorsement from Indian College of Physicians West Bengal chapter and Indian Chest Society in this conference. And today we have our President, Allergy Asthma Research Center President, Professor Shantanu Kumar Tripathi sir. Along with, we also have Dr. Shoibal Moitro, who is an adjunct professor of allergy and clinical immunology at Apollo Clinical Hospital. And also, we are fortunate to have Professor Amol Kumar Banerjee sir, who is the Dean of Indian College of Physicians West Bengal chapter. He is Professor of Professors in the field of cardiology. So, so this is the PPT PowerPoint. So a very good evening, everyone. Everyone present here with us today. It is a great pleasure for us to declare open the 10th National Conference ALLERCON 2021. It has been held on this electronic platform for the second time for reasons well known to all of you. It has been a truly laudable effort by the organizers as well as the sponsors to organize this meet at such a short notice. And one of the main objectives of this web conference is to try to bring together clinicians, medical practitioners with other domain experts, researchers, scientists, professors, postdoctoral fellows, and students from around the world, providing them with the opportunity to report, share, discuss the scientific questions, their achievements and challenges in this particular field. And we are sure that over the course of these next 2 days, we shall gain some valuable insights in the fields of allergy and immunology. And on this occasion, however, we would like to give you a brief overview about our organization, the Allergy and Asthma Research Center. It is a non-profitable organization whose mission is to dedicate to cater the well-being of the underprivileged sections of society. In our free clinics, we try to provide a holistic and affordable approach to the detection and systemic management. Since its inception in the mid-90s, this NGO has been tirelessly striving to provide the relief to countless number of people afflicted with allergic disorders. Its sister concern, the Allergy and Asthma Treatment Center, or AATC, as it is more generally known as, has been operating in the field of allergy detection and management in the city of Kolkata and as well as its surroundings for last 40 years now. And with fairly reasonable success in this course of from its course of its development, it has also set up various branches in different parts and districts of the states, as well as in adjoining state. So various survey reports showing increasing trend in the allergic disorders. We need more awareness among the general population, physicians about the magnitude of this problem, the different manifestations of this type of allergic disorders which may take place and available different types of ways. So with that, the prime objective of this NGO has been to make earnest endeavors to rectify these situations as well as offer available contemporary solution in a more pertinent, scientific and rational manner. So with that, may I request President of Allergy Asthma Research Center, Professor Shantanu Kumar Tripathi sir, to say a few words of blessings to us.
Thank you very much, Dr. Shambho, and good afternoon, everybody. So since the morning, we are actually enjoying a feast of academic activities with experts from different corners of the country. And in fact, I'm told that there are more than 350 registration and participants from different parts of the country. They are attending this academic feast. And as you would appreciate that the scientific deliberations have been very thoughtfully planned with equitable representation of the basic science, applied science, including some of the social science aspects. And we have the best of experts in the field from different parts of the country. Cross-discipline deliberations have taken place and also going to continue for the rest of the day and also tomorrow. I am sure that all of us attending this are benefited with the deliberations, and I can only hope that the deliberations which are possibly also being recorded, there is some follow-up activity beyond the actual conference days. And if we could come out to it, I would request the organizers to consider if you could come out with some kind of compendium of the different presentations and deliberations. That would really be a very useful resource for all the clinicians, academicians, researchers to take their activity forward with the scope and opportunity in exchanging views and networking. So this organization has been doing tremendous job in the service of the community, and I believe that with the help and cooperation of all the stakeholders, we will be actually able to reach out to more and more people who are in need of care in this area of allergy of diverse kinds. I'm not going to stand between the proceedings of the sessions, technical sessions, and prolong my talk further. I'll rather stop here and looking forward to very exciting deliberations for the rest of the day and tomorrow. Okay, I rather stop it here and look forward to the further proceedings in this great inaugural session. Thank you very much. Thank you for the opportunity. Over to Dr. Shambho. Over.
Thank you, sir. Thank you very much. So may I request Professor Shoibal Moitro, who is also the medical director of Allergy Asthma Treatment Center, and who is a strong, we can say, strong pillar of this institute, Allergy Asthma Research Center. So may I request Dr. Shoibal Moitro, the organizing scientific chairperson, to say something.
Thank you, Dr. Shah. First of all, I would like to welcome all the delegates and the faculties and chairpersons this 10th annual conference in Allergy 2021. So you know that we are passing through a very trying times of COVID. So this year our theme is allergy in the COVID times, or COVID-19. As you all know, allergy is an interdisciplinary science, and actually it involves not only the various clinical sciences, but also the basic and the social sciences. So whenever we talk about the allergy, we talk about the treating an allergy patient or reducing the morbidity of the allergic diseases. Actually, it has to be a compendium involving the module, not only the clinical clinicians, but also the basic scientists and the social scientists who play a very important role in making this disease burden lesser in the times to come. So in this year's conference, we have also tried to have a platform in which the basic scientists, the clinical scientists, and social scientists they all come together and forms a melting pot where we can develop ideas for the treatments and also for the new researches, and which will definitely help us to move forward in this field. So with this, I again welcome you all and hope that in this 2 days academic feast, we'll all learn and share our views so that we can enlighten ourselves a bit more and gain from this conference. Thank you very much, and I welcome you all once more. Thank you. Stay safe, stay healthy.
Thank you, sir. Thank you very much. So just now, Dr. Aratrika Das, who is the organizing chairperson, she had called me. There is some technical issue from her side, so she cannot join now, but she had expressed thankfulness to all of our delegates and faculties for helping us out. So may I request now Professor Amol Kumar Banerjee, sir, the professor of professors in the field of cardiology and medicine. So sir is also the Dean of Indian College of Physicians West Bengal chapter. He was ex-Dean of ICP, Indian College of Physicians, and also the ex-President of API, Association of Physicians of India. So it is our privilege to have you, sir. So please say something, sir, and bless us.
Welcome, Professor Banerjee.
Okay, welcome, Shantanu.
Yeah, so very nice to see you, sir.
Respected Shantanu, Shambhu, Shoibal, and esteemed faculty of this conference, I am really very privileged to be here in participating in this inauguration program for the 10th Annual National Conference on Allergic Diseases, ALLERCON 202 year. I also impressed by the theme being allergy in COVID times. Really, this sort of theme and also allergy, we know, be it any discipline of the internal medicine, subspecialty, allergy is really a problem and real world challenge. So it should be tackled properly, appropriately in right perspective. So I'm very happy that you are deliberating on these very important, very nagging issues, particularly from the point of patients who are having the different allergic problems. And also, I would rather emphasize that physicians, primary and secondary care physicians, they should be made aware regarding the allergic reactions, be it from the environment, be all from the therapeutic pharmacologics, all these things, so they can tackle it appropriately. I wish success for this sort of very, we rather say, important and helpful endeavor and exercise, scientific exercise on part of your organization. I wish full success. The attending delegates, along with your those who are associated with your allergy associations, they will be benefited. I also think that API members and also other members of our sister organizations, they will be not be the gynecologists, be the surgeons, they will be very much benefited from discussion of this sort. Thank you. I hope you will expand your activities and be in touch with some international organization on the area so that everyone, your organization members, also the internists, be enlightened with the recent happenings in the field. Thank you.
Thank you very much. Thank you.
Thank you very much, sir. Thank you for your blessings. So may I request now our technical team to start that video, and so that we will start, because we don't have that lunch time due to these time constraints. So maybe we will take up 10 minutes gap and we'll start from 3:40, because the next session is on 3:40. We should not have any lunch time, so we will take a 10 minutes gap with all of your permission, and then we will start our second half of presentations. We will start from 3:40, and may I request our other distinguished faculties to please join us.
Allergy and Asthma Treatment Center. Medicare Private Limited.
I am seeing you after তোমাকে অনেকদিন পরে দেখছি, ভালো আছো তো? তোমার সাহায্য মাঝে মাঝে নিয়েছি বিভিন্ন ব্যাপারে তোমার লাইনে। তুমি আগে আমাদের সঙ্গে তো আসতে, দেখা সাক্ষাৎ হতো, এখন কোভিড এর কারণে তো বন্ধ। এনিওয়ে, আমরা একসঙ্গে এসএসকেএম হসপিটালেও কাজ করেছি। এনিওয়ে, তোমাকে দেখে ভালো লাগলো। ইয়াং জেনারেশন সাম্য শৈবাল বা যারা রয়েছে এরাও যে এই সমস্ত জিনিস নিয়ে কাজকর্ম করছে, দিস আর ভেরি ইম্পর্টেন্ট ইস্যুস।
I'll meet you, Dr. Banerjee. I'll meet you and we'll talk. Sure.
Okay. Thanks a lot. Thank you, bhai.
Thank you.
Okay. Thank you, sir. Thank you very much. So our technical team to start the video from the beginning, and let it on, and we will start from 3:40.
Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients do come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic catanic protein or ECP, Human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients do come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center.
Yes. Good afternoon and welcome back. So now we have the keynote address. No, sorry. Okay, welcome back. So now we have the keynote address. In today's keynote address will be delivered by a very eminent physician of our country. He is also a Padma Shri recipient, Dr. Shashank Joshi. And Dr. Shashank Joshi has sent his lectures, so we'll be running in the pre-recorded lectures as his topic is COVID-19 and allergy immunological interactions. Where we'll understand that what are the interactions which are occurring in the allergy pathophysiology and the COVID-19 so that we get some better idea about this complex disease, both the COVID-19 and the allergy. Thank you, and I welcome you all. So, I welcome Professor Shashank Joshi.
Today, we are going to discuss COVID and allergy immunology interaction. And predominantly, I'm going to restrict my topic to COVID immunology. Now, it is a very interesting topic, COVID immunology. The host immune response is the critical factor in driving COVID, and the analysis of this response will provide a very clear picture of how the host response impacts disease and severity in some individuals, while most infected people will only show mild symptoms or no symptoms. Early analysis of the RNA sequences revealed some interesting features. There was a very variable response of the interferon stimulated response and HLA class 2 downregulation. Interestingly, in subjects who had mechanical ventilator and acute respiratory failure, had a novel B cell derived granulocyte population. Importantly, there were circulating leukocytes which do not express high levels of pro-inflammatory cytokines and chemokines, clearly suggesting that COVID-19 cytokine storm is driven by cells inside the lung. So it is very crucial to study the host immune response from acute and convalescent individuals, and that provides molecular insights into these mechanisms by which we may be able to enable protection and long-term immune memory, which can design prophylactic and therapeutic measures to overcome future outbreaks of similar COVID or coronaviruses. So this was an early hypothesis. The acute SARS appeared in December 2019. It precipitated a global pandemic. But there were many parts in Africa where there were fewer than expected COVID-19 cases and lower rates of mortality. So is it the individual human leukocyte antigen alleles that affect both susceptibility and severity of viral infections? In the case of COVID-19, such an analysis can contribute to identify individuals who are at a higher risk of disease and epidemiological level of understanding of the differences between countries and epidemic patterns. It is recognized also that the first antigen exposure influences the consequence of subsequent exposure. For example, people think that people of South Asian ancestry from where we come probably have a lower predilection to severe disease. And this was a theory which proposed that incorporating HLA antigens, the original antigenic sin or OAS effect in presentation of viral peptides could explain the differential susceptibility or resistance to SARS-CoV-2 infections. So now what we know from this? From the current available immunological and HLA data, the clinical course of infection with SARS-CoV-2 is strongly dependent on the relationship between virus and host immune interactions, in which the host HLA plays a central role in activation of the immune response. There is a scope for studying the role of HLA in COVID-19, and we need to do public health studies, epidemiological studies to look at HLA profiles of host immune determinants. Such studies should include HLA typing of COVID-19 patients to unravel the complexity of disease response and inform and make personalized or customized therapies. In addition, the prior history of COVID infection in the patient
could be relevant in the magnitude of immune response of current SARS-CoV-2 infection, a phenomenon referred to as the OAS, original antigenic sin. This concept refers to cross-reacting immunity due to past infections of similar coronavirus strains, which must be considered in interpreting the immune response to infections and vaccinations. So obviously, when pathogenesis of COVID is not defined, but reports from many countries indicate virus have the same mechanism by which it enters or invades the host cells. We don't know the origin of SARS-CoV-2, but one thing we know is that the spike protein is associated with its receptor, and the viral RNA is encapsulated and polyadenylated and encodes various structural and non-structural polypeptide genes. These polyproteins are cleaved by proteases that exist chymotrypsin-like activity. Although the TMP-RSS2, which is the transmembrane serine protease, is a major protease which contributed to the COVID activation and linked to SARS-CoV activation, current evidence from single-cell RNA sequencing analysis show that ACE2 and TMP-RSS are not expressed in the same cell, suggesting the involvement of other proteases like cathepsin B and L in this process. Also, we know that the viral tract in the novel computational approach screens various RNA sequences of the virus. There has been a major change in the bronchoalveolar immune cell landscape, severe SARS-CoV-2 infection. Interestingly, such lavages have yielded the viral tract co-infections of monocytes within the human metavirus following the dampening of the interferon response. So clearly, we now know better about immunopathology of the COVID. We clearly know that the abnormal host response or overreaction of various inflammatory cytokines lead to a transcriptional footprint of SARS-CoV-2 infection, which is distinct from highly pathogenic coronaviruses or similar respiratory viruses like IV, HPIV3, RSV. It is very noteworthy that despite of the blunted interferon 1 and 3 response to SARS-CoV-2, recent studies have shown a consistent chemokine signature. So COVID immunology has two things: transcriptional footprint and a consistent chemokine signature. And therefore, from a clinical standpoint and signature biomarkers, we know that there is a trinity of immunity, inflammation, and intervention. We know that there is a cytokine signature which is available, and the inflammatory immunological cytokine signature helps us to predict severe COVID and death in people. And therefore, COVID immunology and treatment options are important. Also, it is not just about antibodies. The B cells and T cells both mediate immunity in COVID. So clearly what happens in COVID? When SARS-CoV-2 is trapped, there is an adequate immune response, timely innate adaptive response, quick type 1 interferon response, efficient clearance by the macrophages of the virus, and activation of the Th1 cells and the B cells which make neutralizing antibodies. That is what happens in 80 to 85% of people, where there is a very efficient immune system which clears the virus through a macrophage Th1 B cell neutralizing antibody system, and the type 1 interferon is delayed. However, in people with comorbidities, severe diseases, or people whose immune response is penetrated by the SARS-CoV-2 virus, there is an inadequate immune response where the type 1 interferon is delayed or limited. There is endothelial, epithelial, and cell death and leakage. There is overactive and exhaustion of T cells and NK cells. And there is an activated macrophage accumulation with cytokine storm and death. So clearly we have various predictors of mortality. There are dynamic COVID-19 immune signatures in various biomarkers which are associated with poor prognosis. And there is a risk stratification of people hospitalized with COVID, including age, male sex, white cell count, lymphocyte count, platelet count, hemoglobin, HSCRP, the various other enzymes, including LDH and D-dimer. So typical SARS-CoV-2, 80% is self-limiting, 15 to 20% is severe, and 1 to 2% is fatal. In the first stage of the immunology, or the stage 1 of the dysregulated immune response, it is asymptomatic. There is innate immune activation. There is viral engagement of PAMs and a low type 1 interferon response. In the second stage, there is a non-severe symptomatic adaptive immune activation. There is generation of specific antibodies and T cell response, and there is a release of DAMs. While in the stage 3, there is a severe immunoinflammatory respiratory response, where there is a cytokine release syndrome with IL-1, IL-6, TNF, GM-CSF, interferon gamma, and others. there is a coagulopathy and complement activation and a cytokine storm-like situation. So clearly we know the temporal designs. For example, symptoms before onset, the PCR is likely to be very high, and many a time by second week, the PCR is likely to be negative. We have different types of antibody response. There are high affinity antibodies, which are generated by a maturation of somatic rearrangements and hypermutation of IgG genes. There are non-neutralizing antibodies which recognize viral epitopes that do not distinguish infective from non-infective virus. And then there are these crucial neutralizing antibodies which recognize the viral epitopes, which eliminate or generally diminish inactive virus, critical for preventing reinfection. And development of non-neutralizing antibodies are typically preceding that of neutralizing antibodies. So remember, when we have antibodies, there are neutralizing antibodies, there is opsonization, there is sensitization of our natural killer cell killing, there is sensitization of mast cells, and there is complement activation. So obviously, when SARS-CoV-2 is predicted, how does one predict the time course of adaptive immunity? This is a diagram which shows that when we are inhaling the SARS-CoV-2 infection, there is an innate immune response to the virus. There is a dendritic cell activation and uptake of viral antigens. There is induction of adaptive immunity, which will lead to Th helper cells making cytokines, TL regulatory cells regulating inflammation, cytotoxic T cells killing infected cells, and follicular cells inducing antibodies like B and D cells. And then, of course, we have memory T cells and B cells. So clearly, induction of SARS-CoV-2 specific memory T and B cells are important for long-term protection. The T follicular helper cells indicate maturation of humoral immune response and establishment of a pool memory B cells, which rapidly respond to plausible reinfection. These specific CD4 T cells are important in eliciting potent B cell response, antibody affinity maturation, spike-specific T cells which correlate with IgG and IgA titers. This robust immune response with spike-specific neutralizing antibodies, the memory B cells and circulating T follicular helper cells are found in people who have recovered from SARS-CoV-2 infections. So when you see the immune response against the coronavirus, there is leukopenia, leukocytosis, lymphopenia. Lymphocyte counts of 800 cells and reduce their chance for survival. So as the lymphocyte counts drop, just like there is a lymphocytopenia, like HIV/AIDS, there's a direct effect of virus on the T cells through apoptosis. The dendritic cells have a huge role in the same also. The CT, cytotoxic lymphocytes and NK cells also have a huge role in the activation. And CD4, CD8 also with HLA clearly are blunted. If you see the activation from the high proportions of HLA-DR and HLA-CD8, CD25, CD28, CD69 expression in the T cell subsets, there's a delayed development of adaptive immune response, and then the virus clearance is prolonged and you get a severe human response. So clearly, we now recognize the generation of neutralizing antibodies as they recognize the viral antigen by the antigen presenting cells. So understanding the immune response, understanding the HLA class 1, class 2 epitope pools have been used to detect CD4, CD8 T pools of population from the covalescent plasma of COVID-19 patients. And these responses have been studied in detail. And intriguingly, what has been found that 40 to 60% of non-SARS-CoV-2 exposed individuals are possessing CD4 cell responses against SARS-CoV-2, indicating some degree of cross-reactivity between coronaviruses. Both C and cell-mediated and humoral-mediated immune system defense have effector cytokines like interferon gamma, which inhibit the viral replication and enhance antigen production. So clearly we now know that it has been postulated that there is a secretion of a novel short protein encoded by ORF3b, which inhibits the expression of interferon beta and enhances viral pathogenicity. We also know now there are chemokine produced activated T cells, which make cytotoxic molecules like granzyme B, which directly kill epithelial cells and eliminate the pathogens. So we are understanding better and better about the immune response. As I told you, that the host immune response has a varied interferon stimulated response to HLA class 2 downregulation. And obviously, we are understanding better on immunology. Classically in patients, these were the 5-6 things which we saw as biomarkers to look at immunology. The first one was lymphocyte and neutrophil interacts. That is NLR, neutrophil to lymphocyte ratio. If it is more, it is more severe. The D dimer, the HSCRP, the IL-6, the LDH, and the ferritin, if they are elevated, we know there is a biomarker signature of survivors versus non-survivors. So from the WBC count, we now know that the RDW, if it is more than 14.5, if the neutrophil lymphocyte ratio is abnormal, there is a challenge. There could be leukocytosis, neutrophilocitosis. There could be lymphopenia, lymphocytopenia, platelet count or thrombocytopenia. Various other biochemical parameters could be abnormal. The ESR could be non-specifically high. The CRP, ferritin, PCT, IL-6 could be abnormal. And various other biomarkers could be abnormal. And there's very good outrage. What happens is this immunology activates inflammatory and thrombotic processes. And that is what kills. So the responsibility of severity of disease is not only on viral load, but on immune dysfunction and various other things. And it's important to predict who will deteriorate within 24 hours of hospital admission. There is a H score for macrophage activation syndrome. There is a QCSI, quick COVID severity index, and this is how it interacts. This is the immune response and immunopathology of the cells, of T cells and the B cells and the humoral response and the cell response, and some may have a low levels and recovery, and some may have high levels of cytokine signature, cytokine storm, and you might get a cardiorespiratory complication and death. So it is very important to understand that when the respiratory system is impacted, the interferon response and the interferon landscape is important. We know interferon is expressed in COVID-19 based on the location, viral load, age, and severity. We know that there is a protective effect on the airways through interferon pathways. And we know that the epithelial cells produce protective interferons while CDCs express the negative interferons. So obviously, when we look at the interferon response, severe COVID is characterized by overproduction of immune mediators. And the role of type 1 and type 3 interferon families has been debated. We all know that high interferon 3 may be protective, and the upper airways are high with viral burden, but do not have reduced risk of disease severity. So production of specific interferon 3, but not interferon 1, will denote milder pathology and may be able to clear the virus better. So remember, interferons are overrepresented in the lower airways. In severe disease, there are gene pathways associated with increased apoptosis and decreased proliferation. And now there is a good data which is showing that dynamic production of interferons in SARS-CoV-2 infected patients might have opposing roles in distinct anatomical sites, upper respiratory airway and lower respiratory airway. Cytokine release syndrome has potential targets. We all know that there is recruitment of T cells which amplify the pro-inflammatory cytokine response. The SARS-CoV-2 infects and destroys T lymphocytes, contributing to lymphopenia, overwhelming viral load, magnifying inflammatory response, and lymphocyte exhaustion. We clearly know that there are 3 stages. The first stage is where there is complete depletion of ferritin and lymphopenia. Then there is an amplification stage where more inflammatory mediators are poured, and ultimately there is a consumption of all these inflammatory markers with multi-organ damage. So T cells in the COVID response is very crucial at the cytokine syndrome. We know that the macrophages are infected. Macrophages will present the COVID antigen to the T cells. The T cell will activate and differentiate. They will make the cytokines with different T cell subsets, including Th17. And then there is a massive bomb sport or release of cytokines, which amplifies immune response. However, CD8 T cells are producing very effective mediators to clear that virus. So obviously, the role of T cells in activation, exhaustion, lymphopenia is very well illustrated in this slide. And we clearly know that when there is immunopathology of COVID, there is depletion and exhaustion of lymphocytes, increase in neutrophils, cytokine storm induction, and antibody enhancement. So that is the time course of the immune response. Some will have a deleterious response and multi-organ failure, while some will eventually come out of these whole situations. So there have been molecules like CD6, which are co-stimulatory receptors expressed on T cells. For example, one of these humanized anti-CD6 monoclonal antibody is itolizumab. It's a humanized IgG1 antibody. It binds to the domain of CD6 and it does dose-dependent inhibition of T cell proliferation. And it is a selective T cell co-stimulation modulator. So this current compound of monoclonal antibody, itolizumab, inhibits CD6 co-stimulation and modulates the pathogenic role of Th1, Th17 in various autoimmune disorders. And it downregulates the ALCAM CD6 interaction. It activates the T cell CD25 marker. It hyperphosphorylates and co-stimulates molecules like ICOS and CD28. It modulates signaling molecules like PMPA, AKT, STAT3, transcription factors, and inflammatory cytokines. So that is something which we know, and it also is migrating and trafficking B cells and chemokines. So clearly we can see that they can modulate the cytokines of Th1 and Th17. And obviously, when it comes to the cytokine syndrome, we know that CD6 has a central role in immunoinflammation as a potential target. And clearly we know that you can see here in this diagram that the optimal immune synapse formation, activation, and proliferation at the APC level, the pro-inflammatory cytokine secretion at the T effector site, and you can see the increased trafficking of the T effector cells in the target tissues. So if you give such a molecule, then what happens is there is downregulation of the pro-inflammatory cytokine secretion, decreased trafficking of the T effector cells in target tissues, inhibition of optimal synapse formation, co-stimulation, activation, proliferation, and restoration of regulatory pathways. This has been documented even at the sites of lung cells. So now we have three options available with us. Anti-CD6 monoclonal antibodies, which bind to the CD6 receptor and block the ALCAM-mediated T cell activation. It is immune modulation by regulatory T cells. They downregulate the pro-inflammatory cytokines IL-6, IL-2, TNF-alpha, and IL-17, and have a longer upstream pathway and duration. Should be used early in the disease when somebody is already on steroids and they are needing very high doses of oxygen. That's the time to use this one. We have all used the anti-IL-6 monoclonal antibody, which is not having any activation on immune modulation of the regulatory T cells. It blocks signaling of IL-6 alone. It has a shorter impact on the downstream pathway, which is tocilizumab. And we also have an anti-IL-1 receptor antagonist, Ancarena, which we have used sparingly. So what is the difference between tocilizumab and itolizumab? One is a cytokine receptor blocker, while other one is a cytokine formation blocker. They have different mechanisms of mechanistic differences and pathways of interactions. We have a host myriad of drugs, most popular and most impactful being corticosteroids. Of course, we have anti-CD6 monoclonal antibodies, we have IL-6 inhibitors, IL-1 inhibitors, anti-TNF-alpha inhibitors, and so many other compounds which have been used. And this list is exhaustive and is persistent. So obviously, immunity and immune response against SARS-CoV-2 and the adaptive system response is complex. And these factors may differ between natural immunity obtained by infection and vaccine-generated immunity. So now there is a new concept called hybrid immunity. What is hybrid immunity? Hybrid immunity means people who have mounted a response due to natural infection. You can see on the tree here, memory B cells, CD4 T cells, CD4 T8 cells, and antibodies. Vaccine immunity is little better. And Chen Crotty in Science wrote this very nice paper. The hybrid vigor can occur in different plant lines which breed together. And the hybrid is always a stronger plant. Something similar happens when natural immunity is combined with vaccine-generated immunity. Then there is a 25 to 100 times higher antibody responses given by memory B cells and CD4 T cells with a broader cross variation, and that is where the world is headed. So now we are looking at immunological memory as a source of protective immunity. So we are trying to have a natural immunity, vaccine-generated immunity for two different paths of protection. The adaptive immune system consists of three branches: the B cells, the CD4 T cells, and the CD8 T cells. From a natural immunity standpoint, the immunological memory is observed for more than 8 months in CD4 T cells, CD8 T cells, and memory B cells. While antibodies usually decline and partially they stabilize within a year. So the levels of immunity which can be placed on the spectrum of natural immunity against symptomatic infection over 7 to 8 months is clear cut. And most of them has been documented. Also remember that all we are doing is we have various variants now. There's a beta variant, gamma variant, iota variant, delta variant. The neutralizing antibody activity against most variants of concern is reduced for natural immunity and vaccine-generated immunity. Most variants of concerns have mutations endangering the partial antibody escape, and there is a evidence of selection pressure to evade natural immunity. So the biological relevance of reduction in neutralizing antibody potential against variants is most clearly evident from vaccine trials and observational studies. So this is what we are seeing, the breakthrough infections. So hybrid immunity has become a new concept. We know this concept came earlier. This was predominantly seen with the Shingrix vaccine of shingles. We know in Shingrix vaccine prevent shingles, which are given to people with previously infected with varicella zoster virus, and there was 97% efficacy with antibody response, and such combinations might be the useful things. That is why currently we are looking at a mix and match strategy of combining two different kinds of vaccine with a heterologous prime boost regimen for a stronger immune response. So COVID immunology is a pleasant surprise. It keeps on changing, and we need to leverage science to generate better immunity for COVID-19. Thank you for a patient hearing.
Thank you, sir. So it was a very lucid presentation on COVID immunology. I would like to hand over to Dr. Moitro, sir, the chairperson, for his valuable comments. Moitro, sir. Hello.
Yeah.
Am I audible?
Yeah, you are audible. Dr. Shoban Moitro, sir, are you there, sir? First of all, we are really thankful to Professor Shashank Joshi for giving us time and to illuminate us with this very important topic. This is a really interesting one, and the most important part that is true regarding COVID, that every day, the science is changing, and there was some thought, and till date, we also from our center, we are experiencing the same thing, same evidence, like the patients who are suffering from allergic diseases, as there is very high Th2 response, they are mostly protective from that dysregulated immunity, what happened due to the COVID-19 infection. But yes, it requires further studies, thorough investigations. But this is a very important observation we found, and that is why our initial presentation by Dr. Neeraj Gupta, he had also shown the two extreme of ages where the Th2 responses are very high compared to Th1 response. One is in the pediatric population, specifically the infants, and the very elderly population. So again, if we compare the morbidity or mortality in these groups, I think this suggests something, maybe the hyper Th2 response protective against allergic COVID-19 related mortality or morbidity. May I request, today we have Professor Shantanu Tripathi, sir, to say some important words, because he had a lot of experiences and expertise in this field. So may I request sir to say some few words on this, and then we will move forward towards our next symposium, that is on skin and allergy. Professor Shantanu Tripathi, sir.
No, I couldn't hear you later part of your talk. There was some problem in the network. Can you repeat what you wanted?
The thing is that the Th2 response, hyper Th2 response may be protective for COVID-19 related immune dysregulation. So what is your comment, sir?
Yes, there are some evidences, there are some reports also. But then there is a need for more research in this area, as we know that insofar as the nature and the ever-changing profile of the virus that we have experienced over the last 2 years, okay, it's very difficult really to predict that
how things are moving. Like right now, there are also a lot of speculation about whether the pandemic is now almost ending, or it can come back with a vengeance after some time. So anybody's guess, but there are different experts are having the different opinions, and most of such opinions are based on speculations rather. We had a very unfortunate and very severe kind of impact during the second wave. Okay, and that was also because some kind of complacency that we had demonstrated after the first wave, and the lockdown was withdrawn, and the second wave was even much more serious, and with almost more than 4 lakhs of active cases daily. Okay, during the, I think in the month of May, probably this was around 6th May, when the peak of the second wave we had experienced. And since then, and then gradually it had declined in the next 1 month or so. And since then we were always have an anxiety, and that whether we are also going to face another wave, third wave or so. But then there are a lot of predictions about third wave in the last September end or October. But now the situation is more and more infection. What we find, mostly they remain asymptomatic, and also the case fatality rate probably has been otherwise gone down. Nobody can say what's going to happen really in the coming few months, because we are gradually more and more opening up. So it is better not to speculate, and let us always think that there might be also a risk. So accordingly, we should continue to have the COVID appropriate behaviors for a couple of months, or the 3-4 months. It is also possible that gradually the way it is behaving, the virus is behaving, that it is going to be a relatively more innocuous. It is going to otherwise love to reside in our oropharynx, okay, without disturbing us much. So that's how there is a tendency, which is found right now. There are more and more number of asymptomatic cases, and as you test them, you find many of them are getting positive. I think we need to keep our eyes and ears open, and also continue to exhibit COVID appropriate behavior. That remains the take home message from whatever we learned from Dr. Shashank Joshi. It was a great presentation, great lecture. Thank you very much. We can, I think, go to the next part. Dr. Shambhu.
Yes, sir. So may I request Professor Rothindranath Datta sir and Professor Gautam Banerjee sir and Professor Shantanu Tripathi sir to please chair the session on skin and allergy. So the first,
yeah, Dr. Gautam Banerjee also has arrived. Welcome, Dr. Gautam Banerjee.
Yes, sir.
And we find Professor Datta is also there, Rothindranath Datta, two very senior dermatologists of the city and very well known nationally and internationally. So I think now we can go ahead with the next session. Professor Datta has some issue with his voice, but then let us have your presence. At least say a couple of words to start with, and then probably Dr. Gautam Banerjee, Professor Gautam Banerjee may take over. Over to Professor Rothindranath Datta and Professor Gautam Banerjee. Thank you. Over. So please unmute yourself, Professor Datta. Unmute yourself. You are not audible. Yes.
Thank you, Professor Tripathi, for inviting me for this session. It is really fantastic. And I have a very bad voice now. I can't talk. So I request Dr. Gautam Banerjee to take over and do the talking. Dr. Gautam, please take over. Dr. Banerjee, Dr. Gautam Banerjee.
Dr. Banerjee, if you can please unmute yourself. Professor Gautam Banerjee. So Professor Gautam Banerjee has joined. Dr. Shambhu?
Yes, sir. Sir has told. I think there is some network issue from sir's side.
Okay.
So we can start, sir.
Let us start then. Let us have the first session. And just a second.
First session is atopic dermatitis, a clinical approach by Dr. Kaushik Lahiri. I'd like to invite Dr. Kaushik Lahiri for the session. Dr. Kaushik, are you there? Kaushik?
Hello, everybody. Thank you for this kind invitation to the 10th Annual National Conference of Allergic Disease, that is ALLERCON 2021. And I'm immensely thankful to the two-person Professor Sherbai Mocho and also Dr. Shambhu Namaste for inviting me to share my views on this topic. So the topic assigned to me is the topic dermatitis clinical approach. This is me, Professor and Senior Consultant Dermatologist of the Multi-Specialty Hospital, Kolkata. And what exactly is atopic dermatitis? Atopic dermatitis is a chronic inflammatory disease persisting predominantly in the pediatric population. Its development is most usually multifactorial and a derivative of interplay between genetic, neurologic, and environmental causes. In the absence of specific diagnostic laboratory markers, atopic dermatitis diagnosis is performed clinically based on the patient's medical history, specific clinical symptoms, and exclusion of other non-inflammatory disorders. Atopic dermatitis possesses a significant burden on healthcare resources and patients' quality of life because of sleep deprivation and itchiness and enjoyment loss and scientific care exponential loss. I'll elaborate in the next slides. So it starts actually in childhood, and most of our patients are children and represent the initial stage of so-called atopic march, which represents the natural history of atopic manifestation characterized by typical sequence of atopic diseases of childhood, preceding the development of other allergic disorders later in life. 50% of these atopic dermatitis develop other allergic symptoms within the first year of their life, and probably as many as 85% of the patients experience an onset below 5 years of age. Patients usually outgrow the disease in late childhood, around 70% of the patients, and the disease onset during childhood have a spontaneous remission during adolescence. However, early childhood atopic dermatitis is often an initial indication. Child may later develop other problems like allergic rhinitis or hay fever. Not all my slides are on text. There are many wonderful photos, like charts and diagrams. Like the prevalence of atopic dermatitis is definitely on the rise, and there's a future projection how it will go in the next decade, the next few years. And worldwide epidemiology, here you can see India, and India is somewhere here, just below Germany and above Mexico and above New Zealand. So it is not exactly always a disease of the affluent, not exactly a disease of the civilized and developed world. But yes, 20% of the children and up to 3% of the adults, they have atopy. 2 to 3% fold increase in last decade, and higher prevalences definitely with urban environment, higher socioeconomic status, and higher level of family education. Female, 5 years and older, small family size, and the family history of atopic dermatitis, a migrant group. What are the clinical features? If we can just look at the clinical features, these are the major and minor criteria by Hannifin and Riker. Major criteria, pruritus has to be there, typical morphology and distribution, and a dermatologist will not miss it. And under the age of 2 years, face, trunk, and extensor involvement, and over the age of 2 years, face, neck, and flexural involvement. This is almost it happens always, and personal or family history of atopy, asthma, or allergic rhinitis. Minor features are many, and the many interesting minor features which as dermatologists we look into: xerosis, pityriasis alba, periorbital eczema, and periauricular eczema, cheilitis, tendency towards on-specific hand and foot dermatitis, scalp scaling, periauricular follicular accentuation, nipple eczema, itch when sweating, white dermographism, skin prick test negativity, reactivity, elevated serum IgE, though this is not very specific, tendency towards cutaneous area indications. So these are, in brief, this is infantile eczema to the left of your screen, and childhood eczema to the right. And this is xerosis, and this is hyperlinearity of the palm. Often we get and we diagnose it, the atopic dermatitis, from the hyperlinearity. And atopic cheilitis, you can see this this child with a classical atopic cheilitis and head and neck dermatitis, the very, very concerned and serious look of a patient, penoscrotal fissure, and a retroauricular fissure as well, and nipple eczema. We often get this nipple eczema as well. And so there are some mimickers of atopic dermatitis, which many of the students or who are new into dermatology, they sometimes miss, even we miss. And atopic seborrheic dermatitis appears in the bath or just a few years after that. Non-pruritic seborrheic dermatitis. Areas are adapted area, axilla, retroauricular area, cranial cap. It doesn't mean that seborrheic dermatitis patients are always atopic. It doesn't mean that way. Morphology, the greasy scale and well-defined shiny red rash, dermatitis, eyebrow, nasolabial port. And most importantly, in spite of extensive involvement, infants are actually happy babies. Like atopics are irritable and itchy, unlike the seborrheic dermatitis baby. So this is seborrheic dermatitis, and skid is the patient's, yes, always the itch. Sometimes it confuses that. Nocturnal itching. The other members of the family are also involved. Facial eczema is confusing. In babies, it can happen on the face. Distribution of the older children similar to adults. Genitalia, axilla, wrist. Yes, we can get confused. Additional sites of involvement as a scalp, face, vesicle papillae eruption of the palms and sole. And 8-leg mite demonstration can be the dramatic response to permethrin that never happens with atopics, and it may unmask the atopy symptoms. So these are, you can see. And this kind of face with a very, very funny face with atopy you will not get. The patient is actually enjoying taking the photo. It rarely happens in atopy. Atopic children are cranky always. Miliary eczema, it happens in the summer, 30 to 45 degree. It happens here in India. And extremely pruritic papillovesicles, if you subside to the fine briny discommission, and extremely common in India and in March to September. And in southern part of India where there is no winter, it can happen. Facial eczema is confusing with atopic oozing of malarial district eczema formation. So this is classical malarial eczema, and but when to suspect immunodeficiency. I like this photo, and really suspecting something, right? So the skin rash appears immediately after bath, right? And male or female predominance according to the inheritance pattern. Failure to thrive, recurrence of skin infection, rash resistant to topical steroid, the internal organ involvement, that is hepatosplenomegaly, not matching with atopy, lymphadenopathy, it may be present. So another entity is acrodermatitis enteropathica. Pediatricians, they will very quickly diagnose it. History of diarrhea, irritability, failure to thrive, photophobia, loss of hair, paronychia, like eczematous rash over perioral area, the parlish, stomatitis, dramatic response to zinc supplementation. This always happens. So this is the classical features. And Woodcock allergic syndrome is a very interesting topic that it appears immediately after bath, and X-linked recessive recurrent infection, purpura, bleeding diathesis, thrombocytopenia, small platelet, low IgM. So like levels of suspicion should be high. This is a case of Scott-Aldrich. And dermatitis, that is also very interesting. Dermatologists will love to diagnose it. Actually, the DAPA area is usually spared, and it happens as a primary irritant contact dermatitis, and rash may appear secondarily infected. Pruritus are intractable, and the man may not appear before the 2 months of age. The baby cannot tell you that he or she is itching. And signs of atopy is other parts of the body. And Langerhans and histiocytosis, we need to know the head neck dermatitis resembling AD, dermatitis-like presentation. Post-auricular involvement, yellow, brown, infiltrated papules with pruritic component, intractable. Dermatitis initially resembles seborrheic dermatitis and rash resistant to topical steroid. Pruritic nodular palms and soles, systemic involvement, face, and hepatosplenomegaly, lymphadenopathy. So these all point towards, at most important, skeletal tube. So this is that Langerhans and histiocytosis. And now the other part, like how impact of COVID on atopic dermatitis. This is a new dimension altogether, and COVID and atopic dermatitis has opened a plethora after this in last couple of years. Increased hand washing, disinfectant use that created real problem, prolonged washing of the hand, mask, and high stress level during this time, and liberal use of moisturizer, especially in the hands, that should be counseled to decrease the risk of it. And we have many articles in last couple of years. This is one from the World Allergy Organization, atopic dermatitis in the COVID-19 era of the web-based survey, and this is what we do. This coronavirus disease has faced life-changing in population, and like the factors triggered by all adverse psychological effects related to the quarantine, diet change, less physical activity, less exposure to sunlight. So it increased the AD flare, definitely, because it is a direct stress. And the majority of the patient or the itching remain moderate. A major concern is sleep disturbance, anxiety, sensation of uncertainty, all are related to this global pandemic. And other causes of disease worsening, like the hand washing, lack of use of gentle soap, and prolonged use of gloves, mask, all these areas. Like a major concern is early months of pandemic, the risk of patients stopping emollient and prescribed medication due to lockdown over the counter. So we have our paper on that topic as well. And strategies to minimize the dermatitis, reinforce the proper skincare regime, advise the patient to follow proper hand washing technique preferred over hand sanitizer. And CDC has described it a warm water and soap wash at least 20 seconds, and gently pat until dry, and use a moisturizer after that. Consider hand moisturizer must be used in no excess of water and soap is there. When the patient is outdoor, the patient's access to running water is limited, so he should use always moisturizer. Gentle cleanser and hand sanitizers do not contain high-risk sanitizing ingredients such as fragrance, unnecessary antiseptic. So go for a colorless and a fragrance-free sanitizer. And that's also important. And use of gloves. That is, we always said gloves should be worn, and watercloth face covering, and it's a must not only for COVID but also for atopic dermatitis in public setting. It is a must, and we try to avoid wool or irritating fabric. The cloth box should be laundered regularly along with other clothing items, and using fragrance free. Provide access to telehealth encounters. It completely changed in last couple of years. Every day we are with our telehealth patients, and it was not so a couple of years back. And reinforce the eczema action plans to empower patients to self-engage and optimize atopic dermatitis treatment regime. We used to use the immunosuppressant prednisolone, methotrexate, mycophenolate, azathioprine, cyclosporine to the lowest effective dose. Cut down the dose. And the appropriate patient may continue receiving dupilumab, that is one medicine, and consider discontinuation of upper respiratory tract viral infection symptoms present. And starting dupilumab may be preferable to start a traditional immunosuppressant. So discontinuation of Janus kinase inhibitor. We use a lot of JAK inhibitors these days in dermatology. So that may be beneficial in the initial infection, and maximize the pillar of atopic dermatitis treatment, what we used to learn from our teachers, like bleach bath, moisturizer, and topical therapeutics. And initially, definitely, we were closed and aesthetic procedures were not done at the first phase, and the close contact with the patient and physicians were avoided. And like a halting off, like in the second wave, again, it came back, and the strains and social isolation during the quarantine may exacerbate this condition. The National Eczema Association, not in our country, but in US, definitely that can help. And there are many supporting groups are there on the net. So engage the patient always, and be with the patient, be with the patient's family, tell the patient. And in India, actually, the family cushioning helps a lot, and consideration for safety, and the use of systemic medication for psoriasis and atopic dermatitis during the COVID time. Oral corticosteroid should be avoided during the SARS-CoV-2 time. Methotrexate cyclosporine is associated with decreased infection rate, but cyclosporine has anti-coronavirus activity in vitro, but in effect in human is still unknown. Acitretin you can use others like smaller compounds like your azathioprine may increase the susceptibility of infection, and exposure to COVID-19 should be minimized. So apremilast seems to be safe, effective, and uninfected patient. Dupilumab, apremilast, and acitretin. So this is where the world was sticking to in the last couple of years. And dysbiosis, this is the last part of my lecture, atopic dermatitis, role of probiotics. This is a new part. The probiotics are helping a lot. I'm not going into the details because it's a completely different, huge scope of discussion on this. And this is how the probiotic help. I'll just touch at the liver microenzymes that administer to the epidermis, and establishment of microbial flora in the early postnatal period activates the innate and adaptive immune system. And the uninterrupted microbial stimulus serves to match the gut mucous immune system. An early compromised microbial stimulus may lead to increased intestinal microflora and area in coordination and alteration of the mucosal intermediary metabolism, the dysbiosis so-called, and sensitive mucosal barrier, and the secretory mucosal IgS system. So probiotic actually contribute to regulate an allergic hypersensitivity reaction by suppressing the Th2 mediated response that helps in balancing Th1 and Th2 immune response. And a number of studies has explored the potential efficacy of probiotics in the prevention and treatment of atopic dermatitis. So Lactobacillus rhamnosus, GG or LGG, is now our favorite and commonly studied probiotic strain atopic dermatitis. We are writing a lot, and this is also a new addition to our armamentarium. In 2004, this was a Nobel Prize winning topic, aquaporin, and in many dermatological conditions, the barrier factor defect is a huge thing, starting from psoriasis to acne vulgaris, even atopic dermatitis. So aquaporin 3, this is a future area where we are plugging in, and it is involved in upregulation of aquaporin 3, is involved in keratinocyte proliferation and epidermal hyperplasia. Increased expression of aquaporin 3 in atopic eczema. This is where the world is moving towards. And this is from all this, I had to collect evidence to present before you, the August gathering. And these are the books that I have published over the last couple of decades. And very recently, last month only, we published this, the postgraduate dermatology book, a huge book for our students. And I'm indebted to my student, my junior colleague, brilliant student, Abhijit Saha, for preparing the slides. Thank you, Abhijit. And so stay safe. And so this is how the world is staying safe. The physical distancing, but the mental bonding must be strong enough, not only for atopic dermatitis patient, but for everybody. So thank you for your kind attention. Thank you very much.
Professor Dotto, are you there? Would you comment? I think Professor Dotto might have lost the link or something. Thank you very much, Dr. Lairi. It was very informative and quite exhaustive also. You have very nicely, within very brief time, you have considered the clinical approach to atopic dermatitis. I'm sure our delegates must have benefited a lot. Because of constraint of time, we'll go to the next session directly, and if time permits, at the end of all the three presentations, we'll take some questions and comments. I'll request Dr. Lairi, if you can afford, if you please stay back until the end of the three lectures. May I now request the next speaker, Dr. Anupam Das, to speak on contact dermatitis, patch test, and angry back syndrome. Dr. Anupam Das, would you please come up?
Thank you, sir.
Can you have it full screen?
Yes.
And before you start, I'll request you, I'll request you to give a couple of words about yourself, self-introduce yourself.
Yes, sir. At the very outset, I would like to thank the organizing and scientific team for giving me this opportunity to speak on contact dermatitis, patch test, and angry back syndrome. This is always a pleasure to be a part of this August gathering. I'm Dr. Anupam Das. I'm working as an assistant professor in the Department of Dermatology, KPC Medical College in Kolkata. I have been working in multiple journals in different posts as section editor in IJDVL, deputy editor in IJD and Pigment International, and also as editorial consultant in BJD. And I have published a few articles over the last few years. So I will not waste time and straight away go to what I am supposed to do today. Okay, eczema and dermatitis are two terms which are used synonymously by us. So to be very specific and to be on point, eczema is something which is used by the common man. Dermatitis is something which we dermatologists, we use the term instead of eczema. Now, what is dermatitis? As the name suggests, dermatitis is inflammation of the skin, right? And eczema is the same thing, which means boiling froth. It's a foreign term, so we'll focus on the word dermatitis only. Now, if we go by etiology, dermatitis can be of two categories. One is your exogenous category, one is your endogenous category. So dermatitis is mostly induced by some agent. It can be an external agent, so it can be exogenous dermatitis. If it's an endogenous agent, it's an endogenous dermatitis. So contact dermatitis is the prototype example of exogenous dermatitis. So it is probably the commonest inflammatory dermatological condition which we encounter in our day-to-day practice, in our OPDs. Doesn't matter whether we are working in a corporate setup or a government setup or a private clinic, wherever we work, contact dermatitis is something which is very common, which is troublesome for the patients. It is troublesome for the doctors also to treat, because finding the cause is the key. And that is probably the most difficult thing in our discipline. And of course, there is an exogenous substance which leads to an immune response, which elicits an immune response, resulting in inflammation of the skin with or without involvement of the mucosa. Now, contact dermatitis can be classified into various types. The most important types include allergic contact dermatitis, photoallergic contact dermatitis, irritant contact dermatitis, photoirritant contact dermatitis, and protein contact dermatitis. Contact urticaria is one entity which is an elusive entity which has a bit of overlap with your photocontact dermatitis as well. And occupational contact dermatitis is it's a new term which encompasses different types of contact dermatitis, and this is related to the exposure in the work environment, and this is probably the most common occupational dermatological condition. Now, to start with, we just need to understand what is the difference between allergic contact dermatitis and irritant contact dermatitis. Now, ICD is basically, it's a non-immunological response. it's mostly a non-immunological response. It is caused by direct cellular toxicity, leading to the inflammation and activation of the innate immune system. So for our undergraduate students, for the beginners, we just asked to remember that ICD is a non-immunological thing and ACD is an immunological thing. ACD, basically allergic contact dermatitis, basically it's a type 4 delayed type hypersensitivity reaction, which involves both innate and acquired immune responses. Now, what happens in ACD is after the initial exposure to an allergen, which generates a pro-inflammatory skin environment where clinical signs and symptoms are usually absent, ACD lesions will usually develop during the subsequent exposures when the antigen-specific effector cells and the memory T cells are activated. This is a brief overview of the different types of contact dermatitis. Allergic contact dermatitis, as I already mentioned, it's a type 4 hypersensitivity reaction. The important culprits are metals, most commonly nickel. That is the most common cause of ACD in our country, worldwide also. Apart from that, fragrances, preservatives, dyes, adhesives, topical medications, and various other things can be the cause. So far as photoallergic contact dermatitis is concerned, it's again a type 4 hypersensitivity response, but yes, this requires a light exposure as the name suggests. And this is mostly caused by chemical sunscreens, NSAIDs, and fragrances. Irritant contact dermatitis, as I already mentioned, it's a direct cellular damage, and the most common cause is the housewives dermatitis, which we very commonly see because of repeated exposure to soaps, detergents, water, acids, alkalis, and all those things. Photoirritant contact dermatitis and protein contact dermatitis is beyond the purview of this presentation, so I'll skip these two entities. Contact urticaria, as I already mentioned, this is a very interesting entity which is thought to have a bit of overlap with contact dermatitis, allergic contact dermatitis also. So this basically urticaria, as we all know, the predominant lesion, the primary lesion is a wheal. Wheal is a erythematous, edematous, evanescent lesion which travels from one place to the other, and this is extremely itchy. And in contact urticaria, the lesions develop within an hour of exposure to the culprit irritant or the urticant, we call it. And this usually resolves, this classically resolves within 24 hours. And if it does not resolve within 24 hours, if it stays back beyond 24 hours, we think of some other entities which are thought to be close clinical mimickers of contact urticaria. Now, this contact urticaria can be immunological, it can be non-immunological, it can be mixed type. There are various causes. I'm not going into the details. Skin prick test, of course, and open test or skin provocation test can be performed for diagnosis of contact urticaria. If possible, IgE specific antibodies often help in us in arriving at a specific diagnosis. Treatment, of course, we need to avoid the identifiable causes. We have to ask the patient to wear protective equipment such as gloves for unavoidable occupational food exposures. We need to give antihistamines, aspirin, NSAIDs, and various other things need to be given. And of course, if it's an acute case, we need to go for adrenaline as well to manage the anaphylactic situations. So if you go to literature, this is taken from a very recently published review article in the Nature journal, where the top sensitizers in various regions all across the world were enumerated. And as you can see in different parts, in all parts of the country, starting from all parts of the world, starting from Europe, Germany, Austria, Switzerland, Greece, USA, Australia, Singapore, everywhere, nickel stands out to be the most common cause of allergic contact dermatitis worldwide. After nickel, the other causes include fragrance mix, then your MITC, then your potassium dichromate, formaldehyde, thiomersal, cobalt, colophonium, a lot of things are there. But nickel is something which is extremely important, and that should always be kept in mind. This is a very brief schematic representation of what actually happens in ICD and ACD. In ICD, basically what happens is there is a disruption of the epidermal barrier and cell necrosis. The irritant enters, there are stress signals, there are damage signals, a pro-inflammatory milieu is generated, different cytokines are released, starting from interleukin 1, 6, TNF, alpha, GM-CSF. Ultimately, a neurogenic inflammation is also brought into the game by the release of substance P, serotonin, and the ultimate result is an increased vascular permeability, and finally you have the activation of the nerve fibers leading to acute pain. So this is in very brief the pathophysiology of ICD. And if we come to ACD, as I already mentioned, it has a sensitization phase, and then finally it has the response phase. So during the sensitization phase, the memory T cells are generated, and at that time, the damage signals, stress signals, everything is happening. The pro-inflammatory milieu is generated, the dendritic cells are activated, but the patients do not come up with the typical signs and symptoms. It is during repeated exposures when the patients develop, vesicles, they develop bulla, they develop blisters, itching, erythema, and those classical, wheel and flare response and different things develop. So the basic difference between ICD and ACD is more or less the immunity has much less role to play in case of ICD, whereas in ACD, it's all in all DTH response. So just to simplify, it is, as I already mentioned, I'll repeat, it's a two-phase process. There is a sensitization phase and there is a elicitation phase. And the dendritic cells, they are very importantly involved in hapten recognition. Hapten, we all know, it's an incomplete antigen. Hapten recognition, and finally there is activation of Langerhans cells, myeloid dendritic cells, and interleukin-1 beta is something which is intricately involved in the pathomechanism of ACD. So this is how the haptens and metal allergens are recognized by the innate immune system. There is a very important pathway going on inside the pattern recognition receptors, PRR. So PRR signaling takes place. It can be a direct PRR signaling. It can be an indirect PRR signaling. This is a very busy slide. I would just summarize by mentioning that what happens is after recognition of the hapten, caspases and inflammasomes are activated. So this is the basic endpoint. After activation of the caspases and inflammasomes, the basic manifestations develop. So this is something very interesting, which is being increasingly discussed in our CMEs, in our conferences. It is increasingly being noted that patients who have an underlying atopic dermatitis, which Dr. Kaushik Lahiri was recently discussing in the previous presentation, patients who present with patients who have an underlying atopic dermatitis, and especially those elderly patients, they are thought to be more susceptible to develop ACD and ICD. And this is attributed to a compromised skin barrier. So what happens is individuals with atopic dermatitis, that they are exposed to numerous products on a daily basis, various exogenous pollens, various metallic items, various fragrances, all of us are exposed. That is not an issue. But what happens in atopic patients is, since the skin barrier is compromised, these patients are repeatedly exposed and they are at an increased risk for sensitization. So that is something very important. So these are different photographs. I've taken these photographs from an article. As you can see, there are typical contact dermatitis reactions to, hair dyes. You can see the reactions around the eyebrows. You can see erythema, vesiculation. Pustules are also there. There is reaction along the retroauricular area because of application of hair dye on the, hairline. Then there is a contact dermatitis to, contact dermatitis to your lipstick. There is contact dermatitis to your aftershave lotion, shaving foam. This is very interesting, contact dermatitis to wristwatch, right? This is contact dermatitis to tattoos. This is pompholics. This is your contact dermatitis to, adhesive glues. So these are certain interesting clinical patterns to various chemicals. This is very interesting. We all must remember that various formulations which are available in the market, starting from various creams, ointments, fragrances, all those things, they have an excipient, they have a vehicle. And that is responsible for causing the allergic contact dermatitis in many cases. Recently, COVID-19 vaccine is now ruling the roost. So propylene glycol is something, this is very interesting and very important. Propylene glycol is something which is a component of the COVID-19 vaccine. And most of the reactions which are developing to the COVID-19 vaccine, be it acute response, be it a delayed response, this propylene glycol is thought to be one of the most important precipitators. Patch test, it's a huge topic. So what is a patch test? Patch test is nothing but, as I already mentioned, the most difficult part, the most difficult job for us is to pinpoint the cause of allergic contact dermatitis. So patch test is something which is the gold standard investigation to find out the cause. So here, what we do is the patient is re-exposed to the culprit allergen, and this re-exposure to the allergen or the drug will elicit a similar clinical reaction pattern in a previously sensitized individual. So patch test is basically done for contact dermatitis, and also it is done in cases of drug reactions as well. So in very simple language, we have some aluminum chambers. I'll show you a photograph. there are aluminum chambers which are known as fin chambers. So you on the back, say you have a chamber where there are say 16 to 20 areas, 16 to 20 boxes where different kinds of allergens are placed. The strip is applied to the back of the patient. After say 48 hours, after 72 hours, after 96 hours, the strips are removed and we see what reaction is developing to which area, right? I'll show you the photograph. So results are usually read at the 48 hours on day 2, day 3 and day 7 also results are read if the initial results are negative. Very important is patch test can be false negative, patch test can be false positive. So always we should wait for at least 4 days or 7 days even if there are no results, because there are certain compounds, specifically your neomycin and some other topical antibiotics, which are thought to give positive results at a very late stage. These are the different types of reaction which we can see while we are reading a patch test strip. And these are the different scores which are allotted by the ICD-RGC criteria. And you can have a no reaction, which is labeled as 0. If it's a doubtful reaction, that's a questionable score. Weak positive, it's 1+, strongly positive is 2+, extremely positive is 3+, and irritant reaction is something very confusing. And this is something which should be taken care of. So this, as I was mentioning, this is how fin chamber, an aluminum fin chamber looks like. As you can see, this strip is applied to the back of the patient. Say here you have, say, balsam of Peru. Say here you have a fragrance. Say here you have a nickel. Say here you have hair dye. So this strip will be applied to the back of the patient, right? So after say 48 hours, after 72 hours, we remove the strip. So if we see a reaction has developed here, now I will try to corroborate that in this particular chamber, in this particular area, which allergen was given. So on the basis of this corroboration, on the basis of this tallying, I will understand the patient is reactive to which of the components present in the fin chamber. There are certain practical tips which should be given to the patients after patch testing. Very important is patient should not expose his back to the sunlight for at least 4 weeks before the patch test. Old clothing must be worn preferably. Do not swim, do not rub, do not exercise as the patches may come off. That is very important. It is a great difficulty to perform the patch test if it's a sweaty weather, if it's a humid weather, which we face in most of our months in our place in Kolkata especially. These are the different photographs of a grading system, which I was telling, the 1+, 2+, question mark. This is negative, as you can see. This is negative. This is mildly positive. This is more positive. You can appreciate the vesicles, right? So these are different kinds of reactions. Adverse reactions to patch test is something which is important, which should be kept in mind. Occasionally, the patch test reaction may persist for several weeks, so the patients should be counseled. Very important is patch test. Unfortunately, in rare circumstances, they can provoke other areas of dermatitis to recur or to appear for the first time. And something very interesting and very important is an angry back phenomenon or an exciting back phenomenon, which is referred to as a phenomenon where a patient with active dermatitis at the time of testing, and this may be seen in someone who has multiple positive reactions. So angry back, in simple words, in simple terms, refers to false positive to many or all of the tested allergens. I will come to this in details later on. These are certain, you can see these are certain examples of adverse reactions. As you can see, the extension of dermatitis has happened to the surrounding skin. So this is an erroneous result of the patch test. Here you can see dermatitis to the tape has developed. This is again an adverse reaction. This is what I was calling an angry back. You can see there are multiple false positive reactions all across the back. So this is also now known as excited back syndrome. Now, since we are encountering this COVID-19 pandemic, this article we published in a symposium in our very own Indian Journal of Dermatology. Now, as of now, the recommendations of patch test have been laid down by a Spanish group of authors. And this we had published in the excerpt we had published in our journal. Patch test right now should be scheduled in a well-planned manner in order to avoid crowding in the waiting room. We ideally ask 1 patient per hour, not more than that. And patch tests should be prioritized now in conditions like occupational eczema, severe eczema, facial eczema, hand eczema, and very importantly, where the quality of life is getting impaired, and most importantly, where the patient is planning to undergo any intervention where the result of my patch test is going to be very, decisive, whether a particular intervention can be done or not. These are the cases where a patch test should be prioritized. Apart from that, it should be postponed in high-risk cases. That is extremely important. And to avoid multiple readings, to avoid asking the patient to come to our clinic for the reading multiple times, we can go for the first reading immediately after the removal of the patches. This can reduce the exposure of the patient to the pro-COVID environment in our clinics and everywhere. So this is the diagnostic algorithm. This is the diagnostic algorithm. As you can see, when we have a positive patch test, when we have a positive patch test, if it's due to a topical exposure, we think of ACD. If it's due to an airborne exposure, we think of airborne contact dermatitis or ABCD. If it's because of systemic exposure, we think of systemic ACD. If a patch test is positive along with photo exposure, that is one exposure to sunlight, we call it as a positive photo patch test. And now if the clinical pattern is suggestive of PACD, photoallergic contact dermatitis, we think of PACD. If it's in contact with proteins, typically in food, we consider for protein contact dermatitis. If it's a negative patch test and we can pinpoint a temporal relationship between the exposure to the irritant and the outbreak of the dermatitis, we think of irritant contact dermatitis. These are certain important mimickers of contact dermatitis. When we are not able to cure the patient, when the history, the clinical examination and the diagnosis is not fitting, is not gelling with each other, we should think of something like cutaneous T-cell lymphoma, especially in elderly patients. Pre-bullous pemphigoid, this is something, a vesicular bullous disease, where in elderly patients you get tense pull all over the body. So this can mimic contact dermatitis. Of course, psoriasis, some rare variants. If there is no proper gelling of the history, clinical examination, and diagnosis, we should always think of a paraneoplastic phenomenon which is ensuing. So this is a suggested algorithm for treatment of ACD. If it's a mild case, usually topical steroids, topical calcineurin inhibitors, topical phosphodiesterase 4 inhibitor, if it's available, cicrizaborole, they usually suffice. If the patient is cured, fine. If not cured, we have to weigh the risks and benefits and ask the patient for phototherapy. If it's a moderate or severe dermatitis, of course, the treatment starts as we do in case of mild cases only. If unresponsive or if the response is poor, the quality of life is impaired, we need to go for phototherapy, especially narrowband UVB and PUVA therapy. Still no response, we need to go for immunosuppressants and immunomodulators, starting from systemic corticosteroids, methotrexate, azathioprine, mycophenolate mofetil, cyclosporin, and dupilumab. So dupilumab is a molecule which is approved for atopic dermatitis. Right now, dupilumab and ustekinumab are two molecules which are being increasingly tried in multiple cases of allergic contact dermatitis also. Coming to angry back syndrome, since I have been asked to speak on this, angry back syndrome was first described by Michel in 1975. So as I mentioned, it consists of a hyperreactive state of the skin in which false positive patch test reactions concur with dermatitis at a distant body site or with adjacent strong positive skin test reactions. Now, this hyperreactivity is usually not restricted to the back of the patient. It can involve the entire skin also. Therefore, few years later, in early 1980s and 1990s, Maybach and Michel, they widened the term of angry back syndrome to excited skin syndrome. Now, this is a very beautiful depiction of pathomechanism of angry back syndrome. I'll not discuss all. You can just focus on the first photograph, which is on the left side of your screen, this one, where I'm moving this cursor. Here you can see now, just imagine a strong allergic response. Say in site one, you have a there's a strong allergic response on patch test. Here you have a strong allergic response on patch test. Whereas in site 2, the individual has no response. Lymphocytes are absolutely zero. However, the patient reacts to the application of substance B. The patient should not react to application of B. He should react to application of A only. But the patient reacts to the application of substance B with induction of mediators such as TNF and consequently the expression of adhesion molecules. So basically what happens is when substance A is applied in this part of the body, as a result of increased vascular permeability, as a result of what we know as microcontamination, because of vascular leakage, some amount of A gets seeped out of that area, right? By vascular channels, it comes to the area B, right? It comes to the area B. When it comes to the area B, now this B area has some amount of A substance also. Now, the patient has a strong allergic response to A substance also. So now in this particular area, there will be an allergic response as well. So ideally, the patient should have had response to A only. But since because of microcontamination, because of increased vascular permeability, some amount of A seeps into this particular area. And now the patient will have a positive response in site 1 also and site 2 also. So this will be an angry back syndrome. He should have had response in this particular area only. But because of microcontamination, the response is positive here as well. So these are some other examples of angry back syndrome. I'm not going into the details. This is a very interesting case report which I came across while searching the literature. I'll briefly tell you. There was a 77-year-old male with trigeminal neuralgia. He was initially treated with carbamazepine. Now, when he was treated with carbamazepine, everything was fine. But 3 weeks later, when pregabalin was added to his treatment regimen because of poor response to carbamazepine, he developed generalized maculopapular rash along with facial edema, fever, hepatomegaly, splenomegaly. So this was basically something called as DRESS syndrome, which we call as a drug rash, eosinophilia, and systemic symptoms. Now, the interesting thing starts now. The patient was diagnosed with DRESS fine, but the therapy with carbamazepine and pregabalin was stopped. The patient recovered within 1 month, and the recovery was absolutely good with levocetirizine. Patch tests were performed. Patch test results were positive with both the drugs, pregabalin and carbamazepine. But the same test was then repeated with these two drugs, but on 2 different arms at a 2-week interval. Say pregabalin was given on the dorsal region of the right arm, carbamazepine was given on the dorsal region of the left arm. What the authors found was, and this was published in Contact Dermatitis Journal, what the authors found was now the patch test reaction was positive with carbamazepine and negative with pregabalin. So the important message is in the initial patch test, when pregabalin and carbamazepine were placed close to each other, the patch test result was positive in both the cases. But the positive response to pregabalin could not be elicited, it could not be reproduced when the 2 drugs were re-examined separately in 2 different parts of the body. So the proximity of the patch tests in the initial patch test series had caused this syndrome. So this is a very classical example of what can happen in false positive patch test reaction, which is referred to as an angry back syndrome or an excited back syndrome. Briefly, topical treatments of contact dermatitis. We have topical steroids, we have topical calcineurin inhibitors, tacrolimus and pimecrolimus. These are favorite drugs of all dermatologists. Crisaborole is something which will gradually rule the market in a very short span of time. Topical tacrolimus gives excellent results in nickel-induced allergic contact dermatitis also. Coming to phototherapy, I'm not going into the details. Narrowband UVB and Sorolin plus PUVA, that is Sorolin plus UVA, that is PUVA, these can be used. Coming to systemic therapy, especially in cases of recalcitrant dermatitis, we need to give systemic steroids, cyclosporin, methotrexate, azathioprine, mycophenolate mofetil, and as I already mentioned, dupilumab and ustekinumab are 2 drugs which are increasingly being investigated in the treatment of CD. But since we are facing a COVID pandemic right now, we have to be very careful before starting any immunosuppressive to any patient. So the way forward in future is we have to monitor the sensitization trends. We have to update the patch test procedure. We have to prevent early sensitization. We have to intervene early. We have to advance through technology, and we have to adopt newer treatment approaches. So monitoring sensitization trend, I mean, we have to keep identifying newer allergens. As I mentioned, COVID vaccine is being increasingly given. Propylene glycol is something which is causing the reactions to COVID-19 vaccine. So this is something which should be kept in mind. Patch test procedure has to be updated. One of the greatest challenges which we face, which the dermatologists face, is we have to differentiate between irritant reaction versus an allergic reactions. There are some allergens such as benzalkonium chloride, then your carbamate mix, they are known to produce an irritant reaction as well as allergic reaction. So there are some authors which have proposed the inclusion of one molecule called as sodium lauryl sulfate as a marker of increased skin reactivity. So this is something which is important. And since this is a COVID-19 pandemic, we are suggesting to remove the patch test strip within a day, or rather within immediately after application, so that the visits can be minimized. So these things should be taken into account. Preventing sensitization is extremely important, especially in healthcare workers, especially in occupational industries, where concerted efforts need to be given by the industry, need to be made by the industry to reduce the exposure to allergens, even weak ones whenever possible, because I've already mentioned repeated exposure can lead to a severe manifestation in the future. Intervening early is extremely important. There is a limited information in the literature so far as screening of patients in high-risk industries is concerned, most importantly, hand dermatitis. A very interesting hand dermatitis screening tool has recently been developed, and this has been tested in healthcare workers. And this has been found to be a useful screening tool in prevention of irritant contact dermatitis. We have to advance through technology, and now recently a very interesting proof of concept study has been published. I have not shared the link here, and this has shown that image mass spectrometry can be done And it can be very useful for visualization of the nickel. It can visualize the penetration of nickel. It can visualize the distribution of nickel in the human skin. Now, often what happens is, I would like to quote Professor A.K. Bajaj sir here, who had expired last year to certain major illnesses. He had done a lot of work on contact dermatitis, contact leukoderma, and a lot of things. And from him only, I learned, a lot of us learned in multiple webinars and all those things, that whenever patients present to us, whenever patient present to us with recalcitrant hand dermatitis, patch testing is something which should be advised, which should be advocated, because nickel containing diets, that is something, especially the canned foods, the preserved foods, the canned foods, they contain nickel. And whenever the food is kept in a can, the nickel seeps from the can into the products. And that nickel can lead to systemic allergic contact dermatitis, which if not treated, and the patient, if not advised to stop the nickel containing diet, not advised to stop the canned foods, the treatment will not suffice. So this is something which is very important, and this needs to be taken care of. Yes, dupilumab is a ray of hope, and chemokine receptor systems, they are now gradually coming up. The interesting thing is this CXCR3 signaling pathways, specifically the endogenous chemokines, they are found to be upregulated in ACD and not in ICD. So probably 10 years down the line, they can become potential therapeutic targets. So since we are facing COVID-19 pandemic, contact dermatitis to personal protective equipments is something extremely common, to surgical masks, to N95 masks, contact dermatitis to gloves, that is again very common. Irritant contact dermatitis to the use of hand sanitizers, that is again very common and needs to be taken care of. We always advise, increased use of moisturizers. There are certain sanitizers which have inbuilt moisturizing systems, some aloe vera-like molecules within the formulation itself. We always advise such moisturizers to our patients. And yes, there is an upsurge of hand dermatitis. As you can see, this is everything because of COVID-19 pandemic itself. You can see an cumulative irritant contact dermatitis. You can see erythema in scaling because of excessive use of sanitizers. You can see exacerbation of candidiasis in an OCD patient, and allergic contact dermatitis due to the use of latex gloves in a healthcare worker. So just to summarize is, there is an upsurge of hand dermatitis amidst this pandemic. And yes, we as the frontline doctors, dermatologists are of course not the frontline doctors, but our students, our postgraduate residents have been forced to work as frontline doctors, and they have developed multiple manifestations of enhanced protective measures induced contact dermatitis. And what we found was frequent hand hygiene more than 10 times a day, that significantly increased the risk of hand skin damage. And that was something very interesting finding in our study. So I would like to end my presentation here just to make everyone aware that as a member of Skin Allergy Research Society, we have recently started Skin Allergy Journal also. And there's a very new journal, and we are inviting submissions. We are accepting articles in all sorts of categories, starting from original articles, review articles, case reports, letters, quizzes, everything. So you can just go to this website, skinallergyjournal.com. And yes, we will wait for your submissions. I would like to thank the organizing and scientific team again, Shoibal Mitro sir and Dr. Shambo, for this kind invite. Thank you everyone for your patient hearing. Thank you.
Thank you very much, Dr. Das, for the extensive presentation on this topic. And I'm sure that all of us have benefited from this. I request you to stay back up to the end. We have another presentation now, and after that we can take up a few questions and comments on the areas that you have covered. Thank you again. So let's now move to the next presentation. Our next speaker is Professor Sudip Ghosh, who will be speaking on role of immunomodulatory agents in allergic skin diseases. So Professor Ghosh, Sudip Ghosh, if you are there, please come up and make your first introductory slide, and then we can go to the topic. Professor Ghosh, please.
So good evening, everybody. The skin is a large immune organ. It consists of keratinocytes that play a key role in the immune recognition by producing a variety of cytokines. It also contains antigen-presenting cells that communicate with immunocompetent T lymphocyte in the dermis and provide an optimum environment for the induction of immune reaction. Several cutaneous disorders occur as a result of imbalance in the immunological path. Respected Chairperson, sir, my respected teachers and dear colleagues. Today, my topic of discussion is role of immunomodulatory agent in allergic skin disease. And I would like to focus on the indications, mode of actions, basic workup, and side effect profile of this commonly used immunomodulator in allergic skin diseases. Now, what do you mean by the term allergic skin diseases? According to American Academy of Allergy, Asthma and Immunology, it encompasses urticaria and angioedema, allergic contact dermatitis, and atopic eczema. So, in my discussion, I would like to restrict on these three entities. Now, how to identify urticaria? Urticaria is clinically characterized by wheal or angioedema formation. So, there may be some transient evanescent swelling, erythematous swelling on different parts of the body, or there may be some swelling either in the subcutaneous tissue in the periorbital region or in the hand or feet. They are known as angioedema, and these are the typical picture of dermographism, and some small bumps may be there in the setting of cholinergic urticaria. So these are the several presentations of urticaria. And allergic contact dermatitis is clinically characterized by several changes of eczematous skin reaction pattern, and it depends on the phase of the reaction. Suppose in case of a sandal induced or footwear induced allergic contact dermatitis, you may get a characteristic pattern of allergic contact dermatitis, and if there is oozing or crusting and vesiculation, it belongs to acute eczematous reaction. There may be some scaling. There may be some scaling and edema in case of subacute eczema. These are the pictures of airborne contact dermatitis. This is a picture of allergic contact dermatitis. Along with that, there are some angioedema-like reaction due to hair dye application. These are metallic contact dermatitis, as Dr. Anupam Das has already mentioned. Nickel, cobalt, chromium may be the responsible agent for that. And this is a allergic contact dermatitis due to temporary tattoo application. Whenever in an adult patient you get this sort of eczematous pattern, this is a picture of acute eczema characterized by oozing and vesiculation, and this is a picture of chronic eczema characterized by lichenification, that is presence of thickening of the skin, hyperpigmentation, and accentuation of the normal skin markings, along with rhinitis or conjunctivitis or bronchial asthma. Always you have to rule out atopic eczema. Now, what do you mean by the term immunomodulatory agents? By the term immunomodulatory agents, we mean a substance that affects the functioning of the immune system. In other way, these are intrinsic or extrinsic substances which regulate or alter the scope, type, duration, or competency of the immune response. So to summarize, these are the biologic or non-biologic agents that alters the host immunoregulatory response. Now, let me enumerate some common immunomodulatory agents that are used commonly in our allergic skin diseases. Among the topical immunomodulator, corticosteroid is the prototype agent, which is used in the setting of atopic dermatitis or allergic contact dermatitis, as my previous speakers have already mentioned. Calcineurin inhibitor, particularly tacrolimus and pimecrolimus, they are used in the setting of atopic or allergic contact dermatitis. And a recently introduced drug, phosphodiesterase inhibitor, crisaborole, they are a very important drug recently approved for the treatment of atopic dermatitis. Now coming to the systemic agent. Regarding the systemic immunomodulator, again corticosteroid is the prototype drug which can be used in urticaria, allergic contact dermatitis, or atopic dermatitis. Methotrexate is particularly used in the setting of atopic dermatitis or urticaria in some situation. Azathioprine is particularly used in allergic contact dermatitis and atopic dermatitis. Mycophenolate mofetil, it is rarely used in atopic dermatitis and in urticaria. Cyclosporin is a very important drug nowadays for the treatment of acute urticaria or in chronic urticaria in some restricted cases, atopic dermatitis and in allergic contact dermatitis. Tofacitinib, my previous speaker, Dr. Lahiri, has already mentioned that it has been used in atopic dermatitis nowadays. Hydroxychloroquine, they may be rarely used in atopic dermatitis and solar urticaria. Dupilumab, this is recently approved for the treatment of atopic dermatitis, and they have some offline use in the treatment of chronic urticaria. Omalizumab, this is currently used in refractory chronic urticaria. There also they have some other use like latex or peanut induced allergy, severe delayed pressure angioedema, bullous urticaria, amongst others. Now let us start one by one. Let us start with urticaria and angioedema. Now, when should we use immunomodulators in the setting of urticaria and angioedema? Usually in our clinical practice, we follow two important guidelines. One is ESCCI Gallen, and another one is Joint Task Force guideline. In ESCCI guideline, they should be used as an add-on therapy in the third step of the management algorithm, omalizumab. And if it is refractory to that, we should use cyclosporin. On the other hand, in the practice parameter guideline, it should be used as a fourth step, omalizumab or cyclosporin or other immunosuppressants or other biologic agents. Now, how they act? This immunomodulator, what is the mechanism of action in the setting of urticaria? To know the answer of this question, we have to know the basic pathogenesis of urticaria. Urticaria may be immunological in origin, where classical type 1 hypersensitivity reaction and autoimmune phenomenon plays important role, or it may be non-immunological or complement dependent or idiopathic in origin. And ultimately, there is release of vasoactive mediators from the mast cells and basophils, leading to the several types of cutaneous features. So mast cell degranulation plays a very important role in the pathogenesis of urticaria. So that may lead to pruritus, vasodilation may lead to erythema and wheal formation, and there are recruitment of the several inflammatory cells leading to cutaneous infiltrate. And particularly cyclosporin and omalizumab deserve special mention in the setting of treatment of urticaria. So how does it act, omalizumab? There are several mechanisms of actions has been hypothesized, amongst which lowering Ig level and downregulating the Ig receptor are the most important mechanism of action of omalizumab. There is, in the same time, there is they reduce the mast cell releasability of the several chemokines and cytokines. The other mechanisms proposed are reversing basopenia and improving the basophil Ig receptor function, reducing activity of Ig autoantibodies against epsilon E receptor 1 and IgE, and reducing activity of Ig autoantibodies against an unknown autoantigen, and reduction of the activity of intrinsically abnormal IgE, and the recently proposed hypothesis that they may decrease the role of anticoagulant coagulation involvement in the setting of urticaria. The initial starting dose of omalizumab is 300 milligrams subcutaneous every 4 weeks, and they should be used as an add-on therapy, as I have already mentioned. In addition to the antihistamine, we should use omalizumab. And when should we stop the treatment of omalizumab? There are three, we have to consider three different situations. Number one, if there is severe side effect, when there is lack of efficacy after some point of time, and when the disease is in remission, then we should consider stoppage of omalizumab. The adverse effects are usually mild and rare. Commonly, the patient may present with nasopharyngitis, sinusitis, upper respiratory tract infection, headache, and cough. Anaphylaxis is a severe side effect of omalizumab, although it has not been reported in the three clinical important key clinical trials. And there are a number of promising drugs in the pipeline for the treatment of your chronic urticaria particularly. I'm not going into the detail. I am just mentioning a few of them, just like ligelizumab, dupilumab have some effect in the treatment of chronic urticaria. Even rituximab and risiluzumab, they have some important effect. So these are the important drugs in the pipeline for the treatment of chronic urticaria in the future. Coming to cyclosporine, the exact mechanism of cyclosporine remains elusive in the treatment of chronic urticaria. However, it could be related to inhibition of anti-IgE induced histamine release from basophil and mast cell. The dose of cyclosporine, there are some controversies. Several trials shows that even very mild dose, 1 milligram per kg, or moderate 2 to 3 milligram or 3 to 5 milligram, all have some significant effect in the treatment of chronic urticaria. On an average, the classic adult dose is 100 to 150 milligram twice daily. Initially, they should be used for 3 months, and then we have to try to taper the dose over several months as tolerated by the patient. And they are particularly indicated in the chronic urticaria. In the ESCCI guideline, we have already shown that they can be used in the refractory urticaria, refractory to omalizumab therapy. For the short-term treatment, the side effects of cyclosporine are usually mild and dose-related. There may be paresthesia, some gastrointestinal side effect, and headache. On the other hand, if it has been used for a longer time, then hypertension and renal insufficiency may be the dose-limiting side effect. There are some other immunomodulators that can be used in the treatment of urticaria. Methotrexate is one of them, very important drug. It has been used for 15 milligram per week or 0.2 milligram per kg per week. For the short-term use, it has very minimal side effect. However, nausea and vomiting is common, and rarely, although it is a very significant side effect, is bone marrow suppression. Mycophenolate mofetil is very rarely used in the treatment of chronic urticaria. Gastrointestinal symptom and leukopenia are the common dose-limiting side effect. Hydroxychloroquine is also been used rarely in the treatment of urticaria, particularly in case of pressure-induced urticaria and solar urticaria and refractory chronic spontaneous urticaria. Coming to allergic contact dermatitis, how immunomodulators act in allergic contact dermatitis. My previous speaker has made my job very easy because he has extensively described the pathogenesis of allergic contact dermatitis. Usually there are two important phases. One is sensitization phase. During this phase, the patient acquire allergic sensitization, and there is a elicitation phase when onset of allergy in already sensitized person takes place. So most of the immunomodulators acts in this elicitation phase. The most common topical drug that has been used in the treatment of allergic contact dermatitis is topical corticosteroid. It is used for the localized allergic contact dermatitis. And the main use of topical calcineurin inhibitors are chronic localized allergic contact dermatitis, localized allergic contact dermatitis resistant to topical corticosteroid, allergic contact dermatitis over the face and intertriginous areas, and allergic contact dermatitis induced by topical steroid. Regarding the systemic treatment, oral corticosteroid is the first line treatment, and they have been used for the acute and extensive allergic contact dermatitis, particularly when it involves the face and decreases the quality of life of the patient. And it should be used in acute allergic contact dermatitis involving more than 20% of the body surface area. However, whenever it involves less than 20% of the body surface area, but the disease condition is very disabling, decreasing the quality of the life, and has not responded to the treatment with topical steroid or other topical immunomodulators, in that case, we should use systemic steroid for a shorter period of time. Prednisolone is the doses of choice. The initial dose should be 0.5 to 1 milligram per kg, maximum 60 milligram per day in an adult patient, and it should be gradually tapered up as soon as possible and should be replaced by an steroid sparing agent. For the shorter period of time, the side effect is usually minimal, but for longer period of time, it may produce hypothalamic pituitary adrenal axis suppression. There are some metabolic or bone side effect. Rarefaction of the bone can occur. Gastrointestinal side effect like gastrointestinal ulcer can take place. Ocular, psychiatric, neurologic side effects can be there. So it should be used for a shorter period of time in the treatment of acute allergic contact dermatitis. Azathioprine is another important drug that can be used in the treatment of allergic contact dermatitis, particularly in airborne composite dermatitis or Parthenium-induced dermatitis. The initial starting dose should be 1 to 2 milligram per kg per day. Infections, hepatic, hematologic, GI side effects are the dose-limiting side effect of azathioprine. And in pregnancy, it has lower risk in the up to second trimester, but it has moderate high risk in the third trimester and should be avoided in the first trimester. The other systemic immunomodulator that can be used in allergic contact dermatitis are mycophenolate mofetil, cyclosporin, or methotrexate. Coming to atopic eczema, so how immunomodulators act in atopic dermatitis? So, to know the answer of this question, you have to know the basic pathogenesis of atopic dermatitis. My previous speaker, Dr. Lahiri, has already mentioned that there is an interplay between the barrier function, immunological factors, environmental factors, and pruritus for the pathogenesis of atopic dermatitis. The key cytokines involved in atopic dermatitis are interleukin-4 and interleukin-13. They play similar role in both acute and chronic stages of the disease. These two cytokines inhibit epidermal differentiation and enhance production of antimicrobial peptides. Although several other pathways has recently been highlighted, particularly the JAK-STAT pathway. Several cell types are involved in atopic dermatitis. They include the dendritic cell, dermal dendritic cell, eosinophils, and inflammatory dendritic epidermal cells. All of them play important role in the causation of atopic dermatitis. And interferon, Ig, interleukin, and T helper cell lymphocytes and thymic stromal lymphopoietin, they are increased in the epidermis in the setting of atopic dermatitis. Now, what are the recommendations of topical immunomodulators for the treatment of atopic dermatitis? So, atopic dermatitis affected individuals who have failed to respond to good skin care and regular use of emollient alone, they should be prescribed your topical steroid. Intermittent use of topical steroid is indicated as for maintenance therapy as well. So, there are some important role of calcineurin inhibitor for the treatment of atopic dermatitis. They are particularly used when the lesions are recalcitrant to steroid, particularly in the sensitive area over the face, in the anogenital area, in the intertriginous areas. And when steroid-induced atrophy is there, they should be replaced by topical calcineurin inhibitors. And long-term interrupted topical steroid use is another important indication for topical calcineurin inhibitors. There are several new and emerging topical immunomodulator therapy in atopic dermatitis, amongst which bisabolol deserves special mention. They are phosphodiesterase 4 inhibitor, and recently they have been approved for the treatment of atopic dermatitis by FDA over 3 months of age. Now, when should we use systemic immunomodulatory agent in the treatment of atopic dermatitis? So, in whom optimized topical treatment regime and or phototherapy do not adequately control the signs and symptoms of the disease, and when the patient's skin disease has significant negative physical, emotional, or social impact. Several systemic immunomodulators have been used for acute severe exacerbation of the disease. Systemic steroids should be used, and later on it should be replaced by other steroid sparing agents like cyclosporin, azathioprine, methotrexate, mycophenolate mofetil, or interferon gamma in selected cases. So, all immunomodulatory agents should be adjusted to the minimal effective dose once response is attained and sustained. Adjunctive therapies should be continued to use to the lowest dose and duration of systemic agent possible. Insufficient data exists to firmly recommend the optimal dosing, duration of therapy, and precise monitoring protocols for any immunomodulatory agents. Now, atopic dermatitis, as we have already discussed, that it is a complex immunological disorder which is characterized by overexpression of Th2 cytokines, particularly interleukin-4 and interleukin-13. And moderate to severe atopic dermatitis can be a challenge to treat, and current off-label systemic treatment options may suffer from primary or secondary loss of response, off-target side effects, or contraindications. And here, the increased knowledge of atopic dermatitis disease pathogenesis has allowed the development of targeted therapies. Amongst which, dupilumab is the most important drug, which has been recently approved by FDA in children above 6 years of age. And it usually works by targeting the shared interleukin 4 or alpha subunit of the receptor, and particularly it inhibits interleukin 4 and interleukin 13 signal transduction. Aberrant Th2 response has also been diminished. The initial dose of dupilumab is 600 milligram, followed by 300 milligram every other week. The common side effects, dose-limiting side effects, are injection site reaction and conjunctivitis, blepharitis, keratitis, eye pruritus, and oral herpes or other herpes simplex virus activation is another important side effects of dupilumab. And there are some new and emerging monoclonal antibodies are in the pipeline for the treatment of atopic dermatitis. In the future, they may take the market to reduce the other complicated therapy. Now, what about the workup and monitoring of these immunomodulators? So, routine workup is very important for both monitoring as a baseline investigation protocol for any immunomodulator. Complete hemogram is very important for methotrexate, cyclosporine, or mycophenolate treatment. Routine urine for renal toxicity of methotrexate and cyclosporine. Creatinine. It is a very important biochemical marker to monitor the therapy with cyclosporine. So, baseline and timely creatinine monitoring is very important to continue the therapy with cyclosporine. Liver function test is mandatory for the treatment with methotrexate and other immunosuppressants. Viral hepatitis screening, HIV screening. Lipid profile is another very important to monitor, particularly for corticosteroid therapy and also in cyclosporine therapy. Blood sugar monitoring, ECG, echo, and chest X-ray all should be done. And some special states, these are special mention, particularly TPMT enzyme level is estimated for the treatment of azathioprine. Liver biopsy may rarely be required in long-term treatment with methotrexate. Hepatic ultrasound, procollagen 3 is indicated for the method to identify the hepatotoxicity of methotrexate, and pregnancy test should be done whenever needed before starting immunomodulatory agent. Now, COVID-19 and immunomodulators deserve some special mention. Some particularly corticosteroid, tacrolimus, cyclosporine, mycophenolate, azathioprine, or methotrexate, there is likely concerning risk. And consider stopping these immunomodulators when viral symptoms present, especially with known or potential exposure. On the other hand, dupilumab, it has likely low risk. And whenever we have to initiate any immunomodulator, it should be started in the COVID setting in a very minimum dose. For azathioprine, it should be near about 0.5 milligram per kg per day. For cyclosporine, less than 1 milligram should be the starting dose. Methotrexate, the starting dose is less than 10 milligram per week. For mycophenolate, it is less than equal to 1 gram per day. And for systemic steroid, it should be used in less than 10 milligram per day. So thank you. Thank you all for patient hearing.
So thank you very much, Professor Das. It was quite extensive and very illuminating. And I think we have come to the end of the presentations. And now this is open for questions and comments. If there are questions in the chat box, let us see. I don't find any questions here, but we have, I suppose all the speakers are there, Dr. Anupam Das, Dr. Ghosh, Sudip Ghosh, and also we have Dr. Kaushik. So all three are there. We find there are no questions or comments. Professor Datta, are you there? Professor Rothin Datta or Professor Gautam Banerjee? Might be they have lost contact. So I would now request all the speakers, the three speakers, one after another, if in a couple of lines, you can also summarize the take-home message of your presentation very briefly. To start with, Dr. Kaushik, are you there? Maybe Dr. Kaushik is also not there. Dr. Anupam Das, can you hear us?
Dr. Anupam Das had shared there is some technical glitch from his side, some network issue. So
Okay, let me request Dr. Sudeep Ghosh. Would you please tell us a little bit about your own presentation and also comment on the other two presentations? You are a very senior dermatologist. You are the right person to have concluding remarks in this area. Truly speaking, I am not an expert in dermatology. So I'm sorry the other two chairpersons are not there. So I'll request Professor Sudeep Ghosh to please help us give your comments on the three presentations, brief comments on each of these, including yours. Over to Dr. Ghosh.
So let us start with the first presentation by Dr. Kaushik Lahiri. He has extensively elaborated the several clinical features of atopic dermatitis. In a nutshell, when should we suspect atopic dermatitis in any patient with eczematous skin reaction, may it be acute, may it be chronic, particularly in the adult, particularly involving the flexural area. So flexural dermatitis in association with conjunctivitis or allergic rhinitis or bronchial asthma. And we should always search for the family history of the patient. So this is the constellation of symptoms and signs. The lesions are extremely pruritic. Then we should suspect atopic dermatitis. So the clinical approach Dr. Lahiri has already mentioned. We have to examine the patient from head to toe to find out several important major and minor criteria to fulfill. And we should always rule out the other mimicker like seborrheic dermatitis, like scabies, and other itchy skin conditions. And regarding the presentation of Dr. Das, he has extensively elaborated the pathogenesis of allergic contact dermatitis and irritant contact dermatitis and the differentiation between the two. So in a nutshell, allergic contact dermatitis usually happens in a already sensitized person who is already been sensitized, and repeated exposure to that allergen may lead to allergic contact dermatitis. There are several phases. It may be acute, may be chronic, or may be subacute. And depending on the, there are several stages of allergic contact dermatitis as well. In the stage 1, the disease is usually localized to the precise site of contact. And in the second stage, there may be regional dissemination by lymphatic spread, then by hematogenous spread, it may be disseminated, or there may be systemic reactivation of allergic contact dermatitis after ingestion of a particular food or particular drug. And regarding the PAST test, in a nutshell, PAST test is a mini model of allergic contact dermatitis. So we have to reproduce the phenomenon of delayed hypersensitivity in a controlled way. So that is the basic principle of allergic contact dermatitis, and it is the gold standard of investigation for allergic contact dermatitis. PAST test is the gold standard of investigation for allergic contact dermatitis, but we have to assess the PAST test and evaluate the PAST test result very carefully. There may have some present significance, they may have some past significance, and always we have to rule out the Angry-Back syndrome or other irritant contact dermatitis during the interpretation of the PAST test reaction. And regarding the nickel sensitivity, we have several ornaments may lead to nickel sensitivity, and sometimes nickel may be present in dark chocolate or canned food, as Dr. Das has already mentioned, and they may reactivate the complex like vesicular Palmer eruption or Palmer vesicular reaction in the soul as well. And regarding my presentation, to summarize, the use of your immunomodulators are limited to the allergic skin diseases in the form of urticaria and angioedema, although they should not be used as a first-line treatment. They should be used when it is not responded to routine use of antihistamine. Even fourfold of antihistamine may not produce significant improvement of the patient. In that case, we should use your biologics and cyclosporine. So, and basic monitoring, baseline investigation and follow-up investigation should be done in all shots of biologic therapy, and it should be clearly mentioned in the prescription. Otherwise, you may land up with some catastrophe, and even it may lead to death of the patient as well in some cases, particularly in methotrexate or other therapy. And always look for the clinical side effects as well. Particularly in the case of methotrexate, we should find out anemia, mucositis, and other ominous findings like jaundice. We should always examine the patient in the follow-up visit for elicitation of the clinical findings regarding the side effects. So that's all from my point.
Thank you very much, Professor Ghosh. And it was wonderful session, your own, and also the other two sessions preceding yours. And I'm sure that the participants today have immensely benefited from these deliberations. We once again, on behalf of the organizing committee, we thank you all the speakers for your extensive presentation on very focused topics around the broad theme of allergic disorders. Thank you again. And now I hand over to Dr. Shambhu for the next steps in the proceedings, or the day's proceedings.
Thank you, sir. Thank you very much. And we are really thankful to all the faculties, specifically Dr. Kaushik Lahiri, Dr. Anupam Das, and our teacher, Professor Sudhir Ghosh, sir. So we are really thankful to all of you. And we are there is some technical glitch from the side of our respected chairpersons, Professor Rabindranath Datta sir and Professor Gautam Bandyopadhyay sir. But we are really thankful to them also, as they had agreed to be chair in this session. And to conduct this session, we are really appreciate the effort of Professor Shantanu Kumar Tripathi sir, who had chaired the session along with the other distinguished dermatologists. So with that, the proceedings of this hall ends, and may I request the other delegates. Now another hall in the program is ongoing, a very interesting topic on air pollution and asthma, the relationship between air pollution and asthma that has been taken by Dr. Sandeep Salvi, a renowned pulmonologist from Pune. I request all of you to join there. And tomorrow, again, from 10 a.m., we'll start our proceeding from this hall. There is two sessions simultaneously tomorrow. One is ENT and allergy, ENT and allergy in Hall B. And this Hall A, we will organize the approach to allergic disorder, the clinical proceedings. So I request on behalf of Team ALLERCON to all of you to present with us tomorrow also. Now I request you all to move towards Hall B. There is an ongoing talk on air pollution and asthma, the relationship. With that, thank you all and good night.
Thank you. Goodbye.
Thank you, sir. Thank you.